skills are being required by several institutions para makita nyo lang where do we get the backbone. Why is it required for us to have basic life support? Is it because they just want the basic life support or the advanced cardiovascular life support program? Roll it, to medical institutions. Well, I can say yes, but that's not really the main show. The main show ay there is an institutionalization of the first aid. Papatay lang po na inyong pamute lang. Institutionalization of these courses. First and foremost, we are now undergoing the sunset review of the Republic Act 10121. What is that, people? Baka medyo magtaka tayo kung saan galing yan, saan hinugot. So yung 10121 is Disaster Risk Reduction Law ng Pilipinas. Now, if you don't know it yet, one of the few countries with a very structured risk reduction science and philosophy, and even in academics, is here in the country. Something that I can be proud of. We have the Office of Civil Defense, National Disaster Risk Reduction Management Council. We institutionalize the risk reduction. Pag sinabing risk reduction, we look at the disaster and we are not the reactive anymore. Hindi yung pag may disaster, saka tayo magre-react. Hindi na tayo proactive. Kita niyo na, ha? Kasi kung ang nasa utak niyo, proactive tayo, medyo pagkakamali na tayo. Lilampasan na natin. Pinapasok na natin yung tinatawag na predictive. Medyo na, it's a scary word, but we're trying to predict of the ugly things to come. Now, another thing, before I'll start my rundown is...
Ada daw ang boses. Ang pigiglik, unmute.
Pamute lang. Naririnig ko kayo nag-usap.
Ano go?
One is... Saglit. Okay. Palaking ko lang yan. Now, the issue is we are creating a resilient culture. So the government saw it, one of the answers so that we can be a ready nation, ready ang bansa, is for us to bring it down to the baseline level, some skills na makatulong sa kanila in a stand-alone scenario. Pag sinabing stand-alone, tinamaan ka ng bagyo, you're all by yourself. Tinamaan ka ng lindol, you're all by yourself. Ang tawag doon, yo-yo, you're on your own. Now, if I'm gonna give you a bad news for this morning, last year, 2022, the Philippines is ranked, tayo po ay naitalaga na pinakauna, we are number 1 in the World Risk Index when it comes to calamities, disaster. Numero 1 na ang Pilipinas. Meaning, natural hazards, walang natural disaster. Yung mga nakikinig sa akin ngayon, walang natural disaster. There's no such thing as natural disaster. It's called a hazard. The bagyo, the lindol are phenomena. In relation to civilization, to me, andyan si bagyo, sarap ko, likelihood tatamaan ako, ang tawag ko doon hazard. Pero nagpapakute ako, hindi ako nag-ready, madi-disaster ako. So there's no such thing as natural disaster according to United Nations International Strategy for Disaster Risk Reduction. So because of these challenges, ladies and gentlemen, here in WIPAM, we do the microscopic approach, for example, capacitating our healthcare workers on basic life skills. Baka sabihin niyo, nurse naman ako, doctor naman ako, inherent yun. Hindi po. Maraming nagkakamali. Mamaya makikita ko, pati pagkasa ng bag valve mask, maraming nagkakamali dyan. Pag-iintindi ng 15 liters per minute, maraming nagkakamali, even doctors. No? Ang ating hospital, mainly, sa emergency room, lalo na yung mga peripheral hospitals, mga non-teaching hospitals. Naku, Diyos mio, nagsi-CPR. Ang nakahook ay 10 liters lang. Hindi pwede yun. 15 liters dapat kasi yun yung American Heart Association guidelines. So today is a revisit to the standards because there are outfits or institutions which go into the highway of doing research after research, doing meta-analysis of interventions and even drugs so that we can improve science and practice of medicine. Ayan. That is why we adopt the 2022 interim guidelines. Hindi ko alam kung kami lang dito sa WIPAM ang gumagawa niyan kasi lahat ng nakikita ko, minsan nakikiusyoso eh. May pagka-marites din ako. 2020 pa rin sila. 2020. So dito we are so proud na 2022 guidelines. Okay? Now, basic life support. By the way, I'm a field operator in medicine, meaning I'm a doctor, but I did not take the usual run in the hospital like residency courses. No, that's not my line. My line is I was trained in the field, so I was trained in combat medicine because I was in the uniform service before. And of course, I was trained on expedition and wilderness medicine. So wala yan dito sa Pilipinas. So ang aking ICU ay yung field. Doon ako sa mga katulad nung early this year sa February, I was in Turkey. Yeah. So my hospital is the field. So why am I here in front of you? Well, on two things. It's because I'm an instructor of ACLS. So ngayon, dito sa WIPAM sponsored me to be an instructor under American Safety and Health Institute because WIPAM's backbone is the American Safety and Health Institute. Preceding that, so many years ago, I was with AHA, sa California Registry ng AHA. So I was an instructor on BLS, ACLS, PULSE, and neonatal resuscitation program. So I had my trauma life support already. Although ngayon I have an invitation this November para mag-rerun ako. Hindi na kaya because I have foreign engagement baka sa January. But dito sa Pilipinas, nagtuturo ako ng trauma but I'm not allied with Philippine College of Surgeons. So ang aking alignment is always foreign. So nagtuturo lang under North American Rescue and Disaster Tech Lab. Now, I'm gonna scare you a little bit, people. And I know I'm gonna go straight with you. I will not play Cinderella with you. How many are you? There are 51. 51. Siguro, minusan ko ng tatlo. O sige, sama na natin, including me. Okay. Ipunin ko lahat yung namatay sa gera, sa Aleppo. Ngayon, sama ko na ang Gaza. Sige, partidahan ko kayo. Sama ko si Gaza, Ukraine, sama ko si Malawi. I will total them up. You cannot still defeat the statistical count of people dying from cardiac arrest and or stroke. Anything na vessel. The main problem is the vessel. Pwedeng mabarahan, pwedeng sumabog pag nasa brain. Number one, okay. Ngayon, kayong nakikinig sa akin nung dumating si COVID, kasama naman ako, muntik akong namatay kay COVID. Nataranta tayo kay COVID. Pero kung na-COVID ka, you'll not die right away. Pwede ka pa mag-TikTok. Pero cardiovascular, ladies and gentlemen, I'm not gonna emphasize this to you, Pag medyo massive yan, ay hindi ka makaporma. Walang closure yan, walang goodbye. Pwede natulog ka, hindi ka magising. Naglakad ka lang dyan, biglang tumba, boom! Hindi ka na resuscitate kasi massive MI or delayed conduction to the hospital. Or perhaps you're already too old and your heart is too old to live. But we are here today, people, for a heart that is too young to die. That's why in WIPAM, we advocate the quality of training so that we can save more lives. Kasi despite the fact that my hands are trained to do advanced life support, pero mas marami siyang nahawakang patay. Kasi siyempre sa disaster ako. Bago darating yan sa inyo, nasa akin muna yan, sa field mo na yan. So, Well, it's so exciting in the field because I don't have nurses with me. I do it on my own. Like I dilute my own drugs. I intraosseous intravenous all by myself. I I give advanced airway all by myself. Wala akong pwedeng utusan kundi sarili ko rin. So yung ginagawa ng nurse, ginagawa ko. At ang ginagawa ng doktor, ginagawa ko. So yun yung medyo sabihin natin overloading thing. But the worst thing in the field is you carry your own heavy equipment. Mga gadget, tingnan nyo lang sa likod ko. Sample na yan. O konti pa yan. So yan. No? So yan lang. Kailangan medyo physically you are there. Hindi lang pwedeng hindi ka physically fit tapos bit-bit ka ng mga armada. Now, balik ako dito sa statistics. Okay. This is more the scary part. This is the scary part. Yung tinamaan ng statistika ng cardiovascular incident, pabata ng pabata na. So therefore kayo, isa sa mga nakikinig, dalawa or tatlo siguro, kandidato, including me. Or maybe all of us, kandidato. Lalo na tayong mga healthcare practitioner, medyo patamad-tamad sa physical exercise. Now, at the outset, I'm gonna bring you into a realization that cardiovascular incident, CVA, heart attack and cardiac arrest, all heart vessel, the vessel of the heart. Number one, sa buong mundo. Ha? Sa Pilipinas, numero 1 siya. Sa United States, numero 1. Sa Canada, numero 1. Aba, sa Europe, numero 1. Sikat siya. Now, there are two things. It's not in my slide. But I want you to know this. And I know most of you are guilty. There are two things about this cardiovascular incident. Can we go around it? Yes. Absolutely yes. That's the good news. So, I'll start with a little bad news bago mag-good news. Mas maganda kasi ihuli ko yung good news. The bad news is there are things I cannot anymore modify and you cannot anymore modify. And three of them. Number one, EDAD. Anong EDAD? Edad. Siyempre, pag edad-edad ka na, wala na akong magawa. Bugbog na rin yung wear and tear na rin yung ano ko. Wear and tear na rin yung vessels ko. Pati heart ko. Kasi minsan, pag nagyoyosi ka or stressful ka, your heart ages than your chronological age. Nauuna. So, nabubugbog si heart. Nauuna siyang tumanda. Okay. So, hindi balanse. Kailangan kasi balanse. So, age is something we cannot deny. Number two is hereditary. Siyempre, pag nasa lahi mo, wala ka ng choice. Talagang most likely makukuha mo siya. Number three is gender. Well, merong nagsabi, one according to the book, ang mga lalaki daw ay high tendency. The statistics is high amongst men to have cardiac arrest than women. Well, anthropologically, I attribute it to testosterone. Sorry, mata ko. Testosterone. Testosterone, as you know, it's a warring hormone. War, 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 war. Ganyan, bugbog yan. Very active ang lalaki. So, nabubugbog din yung beso. But there is a certain age category that stroke is more seen in women. Nakalimutan ko ng age category. Whatever it is, those are the things na wala na akong magawa because I cannot change my testosterone not be a warring hormone. Talagang yun siya. Okay? So itong tatlo, wala akong magawa. Age, hereditary, gender. Dito tayo mag-go around sa tinatawag na modifiable factors. Number one, ang makinig, baka kayo guilty. Hypertension. O, siyempre, huwag niyo kong gayahin. Ako, wala naman akong problema, pero ako yung taong maraming denial. Magkasakit lang ako, denial. Parang nasanay kasi ako ng katawan ko malakas. I tend to deny. Baka kung magpakuha akong BP ngayon, hindi ko alam. But I'm okay naman. Pero malay mo, out of nowhere, baka sumipot na sa katawan ko kasi hindi na nga ako nag-exercise. So, pag may hypertension, correct it. Kasi wala tayong magawa dyan. correct it, or else you'll just slowly going down. Walang ano yan. You have to control your blood pressure, and strictly it should be 119. Okay? Absolutely right. Kasi nasanay tayo 120/80. Huwag tayong ganun. That's not very micro. Ang 120 is the start up of a pre-hypertension. 129, 39 ba yan? Bago mag-stage 1, stage 2. Yeah. Pangalawa, hypercholesterolemia. O di syempre, pababain natin. Pwede tayo mag-statins. No? Konsulta tayo. Kung kayo ay nurse, hindi kayo doktor, konsulta. May mga doktor pasaway, pakonsulta din. Yung mga doktor pasaway. Yeah, I've seen one too many. Doktor na nagtuturo ng lintik na wellness. Pero siya mismo nagyoyosi, bad, doing bad things for the body. Yan. So, dalawa na. No? Kaya we can correct this. Pangatlo, hyperglycemia. Ayan. Sus, nako, sumisirit na ang diabetes ngayon. Mga sakit ng mga banyaga, sakit ng mga first world countries because these people are, with all the fast food looming around left and right. Ang Pilipino, nawala ang ating pagtingin sa kalinangan, sa kultura, ginaya natin. Gaya-gaya lang naman tayo. Kung anong ginagawa ng puti, gaya din tayo. Pati fashion nila. No? Nakakatawa tayo. Hindi naman tayo, pati Christmas nila, ginaya natin. Meron tayong mga Santa Claus. Wala naman tayong snow sa reindeer. Pero meron tayong Santa Claus. And we put pine trees there. But that's Western practice. Well, it's okay with that, no? It's Christmas time. But ginaya natin the way of life nila. Kaya tayo, numero 1 na rin. Ang diabetes atin ay pareho na rin sa US, UK, France, Germany. Yeah, pareho. So, sumasakay na tayo sa railroad. Pero correct na ko, correct. Correct naman eh. Pababain natin. So, depende kung anong type of diabetes meron ka. No? Ano pa? O ito, medyo alam ko, mahirap tanggalin. Smoking. Ayan. I don't smoke, no? But I'll advise you on 2 things. As a doctor, of course, you're stupid enough to do that. You know it's so harmful. Walang wisdom dun. So I'm no better than the cow and the dog. Wala ako. I cannot formulate reason because, my brain and your brain are capable of reasoning. So the reason is it's gonna destroy my cells, my body. So ganun lang. So that's the doctor's perspective. Pangalawa, in the wellness perspective, syempre, bakit mo pabilisin ang buhay mo when you can do other, is there are lots of things outside smoking. Okay. Kasi ako, siguro dahil sa trabaho ko, guys, na I'm inside the aircraft. Literally, I still jump out of the airplane and parachute and what. Hindi naman pwedeng pakuyakoy lang yung katawan ko. Kailangan malakas din ako. Naglalakad ako sa malayang bundok, paangat. Malaki ang payload ko. Kahit tumatanda na ako. Kaya nga yung galing ako sa Europe, nahirapan ako kasi hindi na nila ako i-allow. Halimbawa, puntang Morocco, hindi na pwede yun. Kasi daw, 55 na ako. 55 years old na ako. Yeah. Di, saglit tinatawag ako nung, for a while, just few seconds. And then sa basic life support, kasi ano siya no, kasi ano siya he's although it's not allowed to say deaf mute, it's person with disability siya, cannot hear and cannot talk. So I just do sign language. Siya yung mga parang inadapt ko lang kasi pagala-gala. So pinapalinis ko. Tapos ngayon, pinapabuhat ko ng tao-tao para mag-CPR. Sa CPR natin sa ating sa ating ano, ma'am. So yun. Kaya sign language ako. Huh? So where am I? Well, anyway, now the issue here is um, with modifiable traits. One is like obesity. We can, of course, we can trim down. But although it's not really easy, people, it's not really easy. Kung ako nga, natatabaan ako sa sarili ko. Really, natatabaan na. And I have hard time disciplining myself lately. I'm becoming slow. Hindi katulad dati, lean and mean ako. Mabilis ako kasi manipis ako. So obesity is modifiable siya. And then sedentary lifestyle, paupo-upo ka lang. Nako, sakit ng mga healthcare workers yan. Parang stressful na ang job. Tapos wala na. Hindi na sila, nawala na yung physical phase na mag-exercise. Yung iba siguro, yeah, good if they have time. So these are the modifiable things. Ayaw mag-move ang ating slide. Ayun. So what are our objectives? Tao-tao. Tao-tao. Dami. Tao-tao. So describe what's basic life support and then let's visit the new chain of survival. Okay. And what is the BLS and COVID protocol? Nakakatuwa, no? Kasi yung ginawa, yung 2020, ginawa yung 2018, 2019. Pinino 2019, nirelease 2020. Kaya kung magbasa kayo ng 2020, no amount of COVID na mention. 2020, may gali. Walang COVID. So biglang nag-create sila ng insert. Kasi wala na eh, na-release na eh. Saglit. So, grabe, maling ano. Wala na magawa. Kasi na-release yung hard copy. The problem is the hard copy. Sorry, may dadaan sa likod ko, yung tao-tao natin. Yung tao-tao sa likod. Okay, thank you. Thank you very much. Okay, good. So, mamaya, para may practical pa rin. Magugulat kayo. Now, that's because there's a new chain of survival. And then some skills, no? Yung tinatawag nating stations, foreign body airway obstruction management, AED. Kaya pag nakakita kayong BLS with AED, wrong po yun. Pag merong nag-offer ng course of basic life support with AED, mali po yun. Because basic life support, AED is incorporated. Pamali-mali na. Alam mo talagang invento just to, to amuse and to lure people to take the course. But BLS, one of the batteries of BLS, learning battery, is AED operation. Shock naman ako, pero sige lang, okay, fine. Ang AED ay hindi pang healthcare provider. Ang ginagamit ng healthcare, doctor, nurses, ay manual defib. Hindi po tayo nag-AED. Pwede tayo mag-AED override, i-describe ko mamaya. Kapag ikaw, nag-iisa pa lang, pwede ka mag-AED override kasi may mga delays ngayon. Sa Interim Guidelines 2022, may mga delay. Hindi katulad dati na diretso compression. Ngayon, hindi. Hindi tayo diretso compression. Kung susundin natin si Interim Guidelines 2022. And then for those who will be taking ACLS, so there's the bridge from the BLS primary into the ACLS secondary. Yan. So we call it the bridge. Okay. So basic life support is an intervention to an emergency wherein we address to a person who is undergoing cardiac arrest. One. Number two, a person who is suffering from chest pain, they have to do something about it. A person who is choking, a person who has have a agonal breathing, hirap huminga, because he's not yet arresting, but perhaps with somehow a laryngospasm, no? Hirap huminga, or anaphylactic, going into anaphylactic siya. So mga ganun na. Now we intervene without employing advanced life support modalities. One, advanced airway. Sa BLS, meron tayong airway, basic airway, tinatawag na oropharyngeal airway insertion. Pangalawa, nasopharyngeal airway insertion. Okay. Yun. Tapos, pag nagbigay ba ng drugs, ACLS na? No. Unless the drugs are given given intravenously or intraosseously. Okay? Yun na yung ACLS. Ang binibigay natin na drugs, it's either passing hot, yung tinatawag na atomizer, nasal spray, or hypoglycemia siya, nag-glucometer ka, pinahira natin ng glucose dito sa buccal mucosa, yung mga simple sugar, para masolusyonan ang hypoglycemia, because hypoglycemia is an emergency. Bakit kaya emergency hypoglycemia? Kailangan i-describe yan. Alam nyo naman, ang pinaka magaling kumain ng sugar ay ang brain. Whether you are sleeping, the brain eats sugar, because if the brain stops, then you are gone. No? So, ang unang isipin mo, brain. Sa oxygen starvation, brain ulit. It's always the brain. In everything, it's the brain. Oh, so ang sugar, kaya maigi pa mataas sugar mo, huwag ka lang maubusan ng sugar kasi mag-a-arrest ka talaga. The scope is protocol. I'm not gonna give you protocol because you can ask for that, and it's even available online, and you can read the 2020 protocol. And then I'll give you compression mechanics. So pag nagbigay akong compression, gusto kong linawin sa inyo kasi maraming nagagalit sa akin. Ang una, alam mo, nakakatuwa dito sa Pilipinas. Binabash ako. Ang nagbabash akin, hindi doktor karamihan. EMT. Nakakala mo mas magaling pa. No? Kahit bobo akong doktor, magaling silang EMT. EMT pa rin sila. Doktor pa rin ako. Kahit sabihin kong pinakabobong doktor ako sa buong mundo. Eh, kung magaling sila, mag-medicine sila. Bago nila, they counteract yun. Ang gagaling, lalo na naka-abroad. Galing din ako abroad. Eh ako, instructor sa abroad. Ayoko na may pagmayabang. No? Ang Pilipinas, Pilipino, no? Makalangaw na ang kapatong sa kalabaw. Akala mo kung sino. It's very disgusting because I'm ashamed when I'm dealing sa abroad. Makikita mo yung mga bad habits natin. Tanggalin natin yung ganyan. Siyempre, field, I'm into field. Nagkataon, doktor ako. So, medyo nalamang. Okay? And sa compression mechanic, maraming ginagawa ang military na hindi naabot sa civilian. Hindi naintindihan ng civilian provider. Katulad ng CPR using this ulnar line. Kasi low headroom. Merong nag-comment na nagtuturo daw CPR gamit elbow. Do you think I'm stupid? No? Hindi yun. Merong ulnar line, papakita ko sa inyo. Low headroom. Kasi helicopter, low headroom, hindi medevac helicopter. Paano ka mag-CPR? So natutunan ko to sa Dutch Special Forces. Eh hindi naman nagsundalo tong mga tao na to. Alam nila sa military medicine. Merong striding CPR. So may mga CPR na hindi na ituturo sa civilian world. Sorry if I use the word civilian world. But it works. No? Nasanay kasi tayo, friendly yung environment. From where I come from, it's not, my environment is not friendly. Nagsisagip ako ng buhay na ang mga bala lumilipad. That's totally a different world. Na hindi ko naman pwede ituro sa inyo kasi kayo ay hospital-based. So doon ako, igulma ko sa hospital-based. But I'm also going to give you a little glimpse of what's happening outside. Kasi alas 5 ng hapon, uwi na kayo, yung PRC niyo, walang alas 5 ng hapon. Doktor pa rin kayo. Ang problema ninyo, nung pumasa kayo sa board exam, yung inyong mga kamag-anak, pinaglalagay yung mukha ninyo at saka tarpaulin na pumasa kayo. So the whole society and the neighborhood knows you are the nurse or the doctor. Eh ngayon, alas 7 ng gabi, nag-arrest yung kapitbahay, sino pupuntahan nila? Yung magsasaka? Yung guro? Hindi. Ay, si Dr. Juan de la Cruz, yung kapitbahay. Kakatukin ka nila. Eh alas 5, off duty ka na. May alas 5 ba sa PRC ID nyo? Wala kasi ako nakita sa ID ko eh. Oh. So, you will perform it. That's why I'm gonna give you the field also. Because whether you like it or not, in the new normal people, you will be treating casualties in the field. Pag I don't know if you're all from Manila, pag pinabagsak ko tong Manila ng 7.2 magnitude earthquake, wala na kayong ospital. Magluluhod talaga kayo dyan. You are not trained in the medical school and nursing school. Luluhod. Because we are trained on the bed, addressing casualties on the bed. Diyan na kayo magkakaroon ng delivery. Kaya nung 2030, pagdating ng Yolanda, suksuksukan mga with all the excited doctors. Pagbukas ng C-130 sa likod, taranta sila lahat eh. Na walang comfort doon eh. Na-shock. Because we were not trained on austere environment life support. So I will give you some hints on that. And then we will go into FBAW management. FBAW is foreign body airway. Then rescue breathing. Ang rescue breathing natin, hindi mouth to mouth ha. Mag-ano tayo, bag valve mask or bag mask valve. BMV, BVM, yan ang tamang term. Bag mask valve or bag valve mask. Pag sinabing ambu bag, ano po yon? Trade name po yung pangalan po ng gamit. Ang generic is BVM or BMV. Parang battery, hindi everready. Ang everready is the trade name. Okay? So, the dry cell battery is that thing there. Dry cell battery. Hindi Colgate. Pabili akong Pepsodent na Colgate. Colgate is the trade name. It's a toothpaste. No? So, the BMB and BBM is the generic name. Okay? And then the naloxone induction na hindi kayo, na-shock kayo. Ano itong naloxone induction? Because it's not being taught in this country. On two things. Ginagamit lang to sa opioid overdose. Sino ba nakaka-afford unless super yaman ka, mag-opioid ka? Yung mga nagdudroga-droga dito, third world lang yan, mga ano, yung methamphetamine, yung shabu, poor man's amphetamine yan. So yun lang tayo. Although, of course, there is opioid, there are cocaine, but in few amounts, no, na nakapasok, no? It's gonna be costly, no? So, hindi sikat ang naloxone. Ang naloxone available in your hospital is the one that can be given intravenously or intraosseously. Meron na po ngayong papakita ko mamaya, yung nasal spray. So, basic life support is a mandatory requirement for ACLS, for PALS, and NRP, Pediatric Advanced Life Support, and Neonatal Resuscitation Program. Hindi kayo pwedeng mag-ACLS na wala kayong BLS. Hindi ko alam kung saang kolorum na eskwelahan i-allow kayo. Hindi kayo pwede mag-pulse, wala kayong standing updated BLS. Same thing with NRP, Neonatal Resuscitation Program. In Advanced Trauma Life Support, hindi kayo pwede kumuha niyan unless you're a doctor. So anong pwedeng kunin ng nurses and EMT? Pag nurse ka, pwede ka kumuha ng Advanced Trauma for Nursing ATN, pwede ka rin kumuha ng PHTLS saka ITLS, International Trauma Life Support. Okay? MOET, Management of Obstetric Emergency and Trauma, ano siya, hindi siya mandatory requirement, pero kailangan marunong ka mag-BLS kasi ang MOET, ang landingan mo, mag-CPR ka pa rin. Lahat to, landing mo, mag-CPR ka pa rin, balik ka talaga. The baseline of all is always the compression which is under the battery of the BLS. ADLS is Advanced Disaster Life Support. So BDLS to ADLS, Basic Disaster Life Support, sa Advanced Disaster Life Support, Advanced Medical Life Support, Wilderness Advanced Life Support, Austere Environment, Acls, Austere Environment Life Support. Hindi ko nalagay dito. Oy, no? Acls. Para lang yan. Sige, idaglag ko nga. Austere Environment Life Support. Para rin siyang wilderness. Pero basic lang si Acls. Yan, sinama ko na. Para hindi ko makalimutan. Yan. Austere Environment Life Support. Mga pinapausa. Ito, tinuturo na namin. Now, what are the batteries of learning or the subtopics? Number one, alamin natin ang chain of survival kasi yan yung storyline. Pag nag-BLS kayo tapos hindi nyo memorize, ito memorize ha, baka ipapa-enumerate yan sa exam. As in, enumerate word for word. So yan yung storyline. Hindi kayo pwedeng lumukso from 1, grade 6 kagad kayo. Hindi pwede po ganyan. Mag-grade 1, grade 2, grade 3, grade 4, grade 5, grade 6. Yan si chain of survival. Pag hindi nyo, ayun yung alamin si chain of survival, huwag tayo mag-aral ng BLS kasi niloloko natin sarili natin. Susundin natin. Kasi sa ethics, sa science, pag nagkamali-mali lahat, or sorry with the word, the shit hits the fan, kung ako lawyer, babalikan ko yun, nasunod ba yung chain of survival na yun. And then the compression mechanics for adult, child, infant, foreign body airway obstruction management, rescue breathing, AED operation, sa naloxone. Pag-pronounce yan is naloxone. Hindi, ako kasi, Bisaya kasi ako, naloxone. So, kinorek ako, nasa abroad ako. Naloxone. Hindi mo kinorek na, hey, that you're wrong. Lahat sila naloxone. Okay, give naloxone. Ganun para yun, naloxone. Ako naman, naloxone. So, naloxone. Okay. Now, here is the chain of survival, people. So, there are two sets of chain of survival. The in-hospital cardiac arrest, na kayo, lahat, wala naman siguro nakikinig sa akin na field operator dito unless you're an EMT. Then we have the out of hospital. This is my world. Pero I will not teach my world. I'll teach your world. So number one, ay ang pinakaunang dogma ng practice of medicine sa buong mundo. The early recognition and prevention. Kasi doon tayo sa risk reduction. Nag-i-invest ang practice of medicine on preventing the illness. Ayan. Lahat. Yung sinabi kong modifiable traits and non-modifiable traits kanina, dyan po nahulog yon. Paano ma-prevent? Mag-cardiac arrest ako, o pababain ko yung alta presyon ko, pababain ko yung cholesterol, yung sugar, kailangan di ako mag-smoke. Ayun yun. No? Then I go into active lifestyle compared to sedentary lifestyle. Then activation of emergency response. Dati, activation of emergency medical services, EMS. Hindi lahat ng mundo ay may EMS program, particularly Pilipinas. Oh, wala ba? Wala. Meron tayong EMT. Gustong-gusto, marami tayong schools of EMTs, pero wala tayong EMS law, pre-hospital law. Very crazy, no? Kayo ha, nakikinig sa akin, mali mo maging Secretary of Healthcare someday. That's crazy. We are the Philippines is along the disaster and accident corridor. Alam nyo ba, number one tayo sa Southeast Asia, sa vehicular accident, hindi kayo nahiya doon? Ibig sabihin, napakaraming kamote dito sa Pilipinas. Ay nako, medyo may pagkasira ulo ko sa kalye. Yun yung pinipigil ang dinadasal ko sa Diyos kasi nagbibigay talaga akong leksyon sa kalye. No, I love my country. And if there are people, my student in combat medicine, and some of my men died in war to preserve democracy and peace so that you can enjoy your 24. You will sit down with your family with a sumptuous turkey or whatever let's on in front of you or ham, eating and enjoying Christmas. And so my men, they're there in the field, safeguarding the freedom. And they died. Now you can witness kamote rider. Hindi ko palulusutin yan. Hinaharangan ko. Matapang pa. Sira ulo din ako. Dito kami sa kalye. It's not road rage. I'll just correct you. Huwag ka lang matapang. Kasi iba yung story. Pag matapang ka, may kasalanan ka, may pagkalagyan. Sa harap ng pulis, binibinggahan ko pa yan. To correct you. Because sabi ni Mark Twain, hindi sikat ang may kasalanan. Ang sikat, the bad man. Ang mali doon ay the good men when they do nothing. So I have to do something because I paid so much for this country. Talagang lileksyonan ko yan sa kalye. Pag matapang pa yan, mo siya, malasin talaga siya. Kasi matanda na ako eh. Ayoko na ipalusutin yung mga mali eh. Dito, ayusin ko na itong mundo na to. So, yun. Kaya medyo sikat ako sa mga, sir, wala eh. Ayaw niyong hulihin. Hindi ako matapang eh. Pagdating sa presinto, lalo siyang maipit. Kasuhan mo ako kasi pinitikan kita. Ayan o, merong TV. Yung sakyan, puno-puno ng camera yan. You are wrong. Swerve ka, pumasok ka. Napitik ka, bakit kita bayaran? Yan. Ganito na lang, file ka sa court. I'll appear. Pag hindi, tapos minsan ito mali ay hindi ko pinapaan. Pitikan ko talaga yan. Huwag kang matapang pag mali ka. Kasi madadala mo yan. At may tuturo mo sa anak ko. Ngayon, dito sa harap ng pulis. Kukulungin ako ng pulis pero napupakan kita. Swerte ka, naupakan kita sa presinto kung doon sa labas. Siyempre ako, may weapon akong tao. Kasi siyempre, nagtuturo ako sa mga sundalo. Siyempre, pag-iinitan din ako ng ISIS. Namarkado din ako ng terorista dahil nagtuturo ako. Siyempre, nagtuturo sundalo yan. Kaya ako, I weaponize myself. Because nag-araw lang hinihintay ko matitsempuhan din siguro ako nitong mga kumag na to, na ito yung nagtuturo ng combat medicine. So nag-ready din ako. Kasi I was informed by military. Aha, sir, na meron kasing siraulong sundalo nag-post sa training nila, yung mukha mo nakabalandra. Namarkado tuloy nung Marawi. Kaya wala akong magawa. Galit yung family ko sa akin. Wala akong magawa. Destiny yun eh. So I ready myself. Anyway, high quality CPR is push hard, push fast, adequate recall, yan, high quality. Avoid interruption. Yan. Yan lang. Diyan muna ako start. No? Compression, tama. Tinanggal na yung 2 to 2.4 kasi hindi mo na malaman ano yung 2 to 2.4 kalalim eh. Paano mo silipin? Doon ka sa gilid ng chest na tao, ganunin mo. Ganito dapat kalalim yung compression ko. Yung loko mo sarili mo. You know how to look for a good compression? Pag maganda ang compression mo, makikita mo yung chan umaalon. Ang tawag doon siso effect. Kahit pa 6 packs yan, makikita mo magsisiso yan. Yan ang maganda. Intrathoracic pressure, ipupus niya intra-abdominal pressure. Dalawa lang naman eh. Lalabas lang yung hangin. Okay? Saka papasok doon, tutulak yung diaphragm, itutulak yung chan. Kaya kahit flat tummy ka, matatalbog yung chan. Ang tawag dyan siso. So pag maganda ang siso, that's good. You don't need to measure it at 2 to 2.4. You're crazy doing it. So sa high quality compression, tatlo. Push hard, push fast, 100 to 120. Adequate recoil. Ibig sabihin, anong lalim? Yun yung bari. Ni slow motion ka lang. No? Huwag mong panggigilan. Ganun ka. Boom, 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 boom. Ganun. Um, avoid interruption. So, wag yung, although sa interim guideline, may konting interruption. I-demo ko yun mamaya. Then, defibrillation. So, dito sa bahay, may tatlo akong defibrillator. Dalawang AED, isang Zol, isang ginagamit ko ngayon, Mindray. Mindray. Ganda siya, German technology, ginawa sa China. And then, may manual ako, LifePack 12. So, gagamitin natin sa ACLS. At long last, binalik. Tapos, gamitin ko rin yung, meron ako ultrasound. I'm crazy. My house is an ICU also. Then, post-ACLS care, yung cardiac arrest. So, unless you're ICU guy, you're fine. Or CCU, cardiac coronary care yun. Sakop mo pa yan. On me, hindi na. Kasi ako, pre-hospital, ang laro ko lang, hanggang defib eh. Yung post-cardiac care, unless stay and play ako, akin pa rin yun. Pero pag na-endorse ng sa hospital, hindi na akin yun. And then, ito yung dinagdag people, recovery. Lalo na sa Pilipino, napaka-poor compliance. Pag pinuwi na sa bahay, wala na, pasaway na ang pasyente. Including my patient. Meron, doktor ako na ICU lately, namatay na lang yung pasyente ko sa old age. I mean, umalis kasi ako pang Turkey, tapos pagbalik ko na ICU siya, there were doctors who handled him. And isa sa pinakamayaman sa Pilipinas. But it's not because he's rich. It is because he's my friend. He is the one who financed our Mount Everest climb. So the time na nanghina na siya, talaga na. I was his doctor. Nag-create kami ng sarili naming ICU. So, yun. Until he just passed. They died just this year. I lost a friend. Siya nga nag-repair ng bahay namin. Bago ako nag-work sa Lopez Group, inayos na. Kasi friend nga siya. I don't like to work sa Lopez Group kasi I'm a friend to this old man. Baka sablay ako na empleyado. Pero gusto niya doon ako. Tapos medyo nagkaaway-away kami ni Secretary Marojas ng Yolanda. Sabi niya, umalis ka na sa gobyerno, sayang talent. So, with a heavy heart, umalis talaga. Pero masensa ako. When I was outside the government, I became better. Wala ako sa bureaucracy. I can go, okay, I just came from Europe. Although, hindi ako nagtutur, training for Ukraine, Morocco. Ngayon, meron akong invitation papuntang Gaza for humanitarian work. Tinitingnan ko lang kasi siyempre, pag nawala ako, how much is mawawala sa akin? So, i-compute ko yun para dadagdagan nila, may times 2 times 3 kasi hostile environment. Hindi naman sa gusto ko ng pera. Siyempre, I have family to feed. Kino-compensate yung loss ko. Tapos delikado, siyempre, flying bullets doon. But that's my training. So, ano ko pa. And then, by the way, gusto ko lang sabihin sa inyo, pag matuloy na to, malaki problema ni Joy, Ma'am Joy. Kinukuha po ako mag-undersecretary ni BBM sa Interagency Task Force. I did not say yes. pinag-aralan nila kasi ayoko bayaran ako ng gobyerno. Gusto ko i-loan lang ako. Kasi pag tapos na ng term ni BBM, wala na rin ako. So i-loan lang ako ng company namin, 100%, walang problema, na dinaan ko lang sa liga. Ang Malacanang na lang ang hindi alam bakit ganun loan. Sabi ko, ako, hindi naman ako atat na atat mag-USEC. Nasa inyo. I'm okay. Nako, Joy, pag USEC na, baka hindi na ako makaturo ACLS. Anyway, this is the PDEA. Pareho lang sa PDEA. Kung papansinin nyo, sa in-hospital, saka sa out-of-hospital. Sa out-of-hospital, walang prevention. Pero pag tingnan nyo sa PDEA, bakit ang out-of-hospital may prevention? Dapat ganun ang tanong. Anong pagka-difference ng adult sa PDEA? Okay. Hindi po naisagot yan ng medical science. Buksan yung mga libro, walang sagot yan. Sasagutin kayo sa anthropological, sa socio-anthropological perspective. Ang mundo, merong bias between the adult and the child in distress. Ang tao mas naaawa sa bata. Ano yun? Innate yun. Hindi ko ma-quantify gaano. Between sa lalaki sa babae, mas maawa sa babae ang mundo. Between sa may kapansanan at sa isang taong okay, mas maawa siya sa may kapansanan. In equal ground. Hindi ko naman sinabi yung may kapansanan may hawak na AK. Yung walang kapansanan ay good guy. Hindi naman ganon. Yung on equal stance na these are all harmless people. Sa may kapansanan o sa walang kapansanan, mas maawa ka sa may kapansanan. Mas maawa ka sa bata, mas maawa ka sa katutubo, yun. Yun yung merong sinasawang na preset of bias. Kaya sa bata, kahit out of hospital, kinonsider pa rin ang tinatawag na prevention as the number one dictum. Ayan. So, kasi baka may magtanong sa akin, bakit adult wala? Kasi kahit tayong mga adult, makasalanan na tayo, okay na tayo. Just kidding. So, ganun yan. Sasagutin kayo not on the medical science, but on the socio-anthropological perspective. So, what do we do? Parang ganitong rundown. After you scene is safe, assess responsiveness, activate emergency response, hindi na EMS, or dahil kayo ay in hospital, code blue po. Ngayon, maglilinaw. Bago ako uusad, lilinawin ko muna. Nung gumagamit ba kayo ng word na code blue sa ospital? Kasi kung hindi, ganito yon. Karamihan, hindi naman sinasabing mandatory. Karamihan, kapag cardiac arrest condition o cardiac arrest case, ang ginagamit ng word, may kaso pumasok, kunwari sa ER, ang tawag ko doon code blue. So isang individual na cardiac arrest case, code blue. Arrest hindi heart attack. Pag nag-arrest yan, code blue ang tawag. So sa hospital, depende sa laki ng hospital, meron tayong mga code to activate a certain group of interventionists. Pag sinabing code blue, alam natin, cardiac arrest. So na-train ka sa ACLS, tatakbo ka kung saan may code blue kasi ina-announce yan sa hospital. Code blue, bed number 2 ER, bed number 2 ER, code blue, bed number 2 ER. Kinukode natin. Kasi pangit naman, ina-announce mo tapos yung hospital, mayroong mga tao, ay cardiac arrest, bed number 2 ER. Tapos nag-announce buong hospital, yung ano ba yun? Ano ba yun? No? Kinukode lang natin. So kung ikaw hindi ka nakakaintindi, ano ka lang, pasyente ka, anong yung code blue na yun? Ano ba yung raffle? May raffle siguro dito sa ospital. O yun. May mga spinal unit activation kung trauma. No? Merong stroke unit, stroke team. Activate. May kanya-kanyang code. Nasunog ng ospital, karamihan tawag doon code red. No? So, depende. Hindi naman siya strictly na i-code red sunog. May mga ibang nagpapauso din kung anong tawag nila doon. Pero mainly, pag sinabing code blue, cardiac arrest yan. Ano tong cover the patient with mask prior to compression? Ito po ay pre-hospital. Sa atin, hindi po. Ngayon, meron tayong tinatawag na time-bound. No? Dahil ito'y ginawa sa Western country, hindi totoo to sa Pilipinas. So 10 minutes ay hindi nangyayari sa Pilipinas. Sa atin is 8 minutes, irreversible brain damage na. Kasi mas mainit tayo. 0 to 1 minute, cardiac irritability. 1 to 2 minutes, brain damage not likely. 2 to 4 minutes, brain damage possible. 4 to 8 minutes, brain damage very likely. So, nasa 8 minutes ang ating running time. So, mapapansin ninyo sa picture na to, nag-arrest ang tao, ventricular fibrillation, wala kang ginawa, patay talaga yan. So, yan, diretso. Kasi ang heart, although alam ng doctor, nurses to, pero yung mga iba baka hindi niyo alam, pag ang tao ay nag-cardiac arrest, hindi po humihinto ang puso niya. Tumitibok po yan. Wala lang hemodynamics, hindi nakakasipa ng dugo kasi mali yung tibok. Masyadong mababaw or masyadong mabilis na yung fibrillate. Kung titingnan niyo ang kamay ko, so ito yung normal, biglang fibrillate is ganun. So hindi siya nakaka-pump ng dugo. Or bitak pero mababaw, hindi nakakasipa ng dugo. Kaya ang tawag pulseless ventricular tachycardia. Mababaw siya. Hindi siya nagkasipa. Ganun lang. Wala talaga yung tinatawag nating inotropic, yung squeezing na hemodynamics, sisipa ng dugo. Kaya ang tao bumabagsak. Yung asystole, wala na. Pero karamihang arrest is fibrillation. Pag pinabayan mo yung fibrillation, nakita mo sa picture din, biglang, titingnan yung kamay ko ha, manood kayo sa video, biglang mauubos ang metabolites, babagal, agonal, beating, wala na, flatline na. Meron pa yung fine. Magpa-fine pa yan, fine pa pala. Oh. Yan, fine. Hanggang agonal beating, agonal beat, bagal. Wala na. Flatline na talaga totally. So pag nag-flatline, mahirap na buhay. Iba ang approach natin. You don't shock it anymore. What we shock in the defibrillation, using the defibrillator, is the ventricular fibrillation, whether it's coarse or fine, or a pulseless ventricular tachycardia. Ang pulseless, makikita mo, talagang ang fibrillation is ganyan, no? Ang bitak is ganun siya, mabilis, ganun. Pero ang dugo hindi na umuusad. Wala na. Pulseless ventricular tachycardia. Now dito, nag-fibrillate ako, ventricular fibrillation, pero nag-defibrillate. May chances. Depende sa age category. Wrong English. Age bracket. Dito, nag-fibrillation ako, nag-CPR, pero huli, dumaan sa EDSA yung defibrillator, nahuli siya. So meron akong ilang percentage. Actually, parang hindi na to ngayon, hindi na siya 8%. Nagbago na yung statistics. Ito, nag-fibrillate ako, mataas. Actually, umakyat to ng 40. 40 to even 40, even 70. Depende sa age bracket. Umakyat to ng 70. Pag kinumpleto to, umakyat to ng 80. Na meron akong ACLS care. Wow. Kaya dito sa bahay, may sarili akong amiodaron, epinephrine. Kaya yung mga anak ko, hindi doktor ang anak ko ha, hindi doktor, hindi nurse ha. Ang mother-in-law ko, nabuhay ng mga anak ko. Meron akong defibrillator, oxygen, wala lang silang advanced aerobic. Marunong, pero natalanta sila. I was from the hangar, galing sa isang air rescue operation. Pag pitik ng cellphone ko, naku, yung mother-in-law. So taranta, kasi siya na lang yung matanda sa amin. Inaalagaan namin. Kaya nabuhay ng kids ko. So wag kayong mga nakikinig sa akin, wag kayong magpatalo ha. Kayo patalo sa mga anak ko kasi hindi nurse doctor yun, mga ano lang yun, mga estudyante. Kagagraduate lang kahapon ng isa ng multimedia, hindi siya medicine. O, wag kayong magpatalo ha. Sige, competitive tayo ngayon. Welcome to the interim guidelines of 2022. Baka magtaka ka, ano kaya meron sa interim guidelines? Wala. More on COVID lang siya. Pero alam nyo, kung susundin natin, kung we are very dogmatic and orthodoxy, susundin natin. Ibig sabihin, nang ginawa to, kasagsagan ng COVID. Kaya required daw pa, pag rumisponde ka sa pasyente, naka level 4, level 3 ka. Yun yung don't PPE. Tapos limit personnel. Ngayon, parang binalik na. Dati, ang ideal head count ng basic life support, ideal head count na, ang minimum is 4. With a team leader na yun. Ang team leader ay nasa paa. Okay? Na nagmamando. Wala siyang hawak. Ngayon, 3. Ang team leader ay nagde-defibrillate. Ang tawag doon, Jaworski. Playing coach. No? Coach ka na naglalaro. Okay? So, limit personnel. So, nasa inyo pa yon kung isusundin nyo. So, pwede natin, kung sa tingin nyo, kayang-kaya ng di wag na natin i-limit yung personnel. Pwede tayo mag 4 or 5. So nasa inyo na yun. Pero kung susundin ko pa rin yung interim guidelines kasi very black and white ako, limit personnel. I-demo ko mamaya yan. Then using mechanical CPR device, yung tamper, I call it tamper, yung nagpapa-CPR sa dibdib mo. Yan. Okay? Hindi ko na i-run down tong next wave. Itong use a HEPA filter for all ventilation. So, actually, yes, meron tayong in-encourage noon na merong inlet, pasok yung hangin, tapos gagawa ka ng wind corridor doon sa ward, tapos may outlet. Tapos maglagay ka ng HEPA filter. Katulad nung ako'y na COVID, punong-puno ng HEPA filter yung St. Luke's paligid. Tapos post-chest compressions to intubate kasi dati hindi na nagpo-post kasi tuloy-tuloy bang intubate. Bumubula kasi yung daanan ng airway. Suksok lang ngayon, pause, pero kailangan ang intubation material mo ay camera, video guided, no? Although meron ako, tapos I was informed lately nasira na daw. Sabi ko, ibalik mo lang kasi pang demo ko. Umuo. Malayo lang kasi nasa Cagayan daw siya. So, napakatagal na nung ko, bago na uso si COVID, gumagamit na talaga ako ng video aided laryngoscopy. Okay? Kasi minsan, hindi pabor yung nasa loob ng helicopter. Hindi ako makayuko. Kaya laryngoscopy, video aided siya. So, yan lang yung mga gusto kong ilinaw dito. Hindi siya, hindi ibig sabihin, ito yung sundin. Kasi I will still honor the standing policies and procedure guidelines you practice in your own facility. By the way, a hospital is called a facility. It's not an infrastructure, it's not a utility, it is a facility. Pagkaharap mo ay isang disaster or emergency manager, it's called a facility. A police station is a facility. A BFP station is a facility. A school evacuation is a facility. Hospital is a facility. Yung power generation is a utility. Yung garbage disposal is a utility. Yung storage for fuel is a utility. So may mga right sets na ginagamit. Right words. So ito po yung interim guidelines. Hindi ko na siya i-run down. No? Anyway, you can have my slide and just have a read on it. This is the latest 2020 with interim guideline of 2022. Okay? 2020 ginawa ang reformulation of the algorithm, but the emphasis for COVID is 2022 interim guideline. Okay. Dati, tingnan nyo cursor ko, check for responsiveness, call for help. Yan. Ngayon, hindi na. Ang unang box algorithm, don't PPE. Yan. Kasi kung lalabas sa exam, kung mag-exam, pag itanong, what is the first consideration in the updated 2020 basic life support piggyback with interim guidelines of 2022. So may mga check for responsiveness, call for help, don't PPE, start CPR, mga ganun. So alam mo, ang sagot, don't PPE. So yun yung uno. So hindi ka daw pwede. Dito in hospital to. So don't PPE, limit personnel, then establish consciousness, shout for code blue, no? Tapos look for breathing, kung chest rising. If yes, monitor. Normal breathing, may pulse, monitor lang. Normal breathing, no normal breathing, organal breathing siya with pulse, bag mask device, bag, ambubag na lang. Hirap. Ambubag with filter and tight seal. Now, ituturo ko yung mga kasi dito magkakamal. Pero yung aking bag valve mask ay wala siyang filter. Military grade siya. Ang uso kasi ngayon ay yung merong makikita mo box na merong binabatong filter, kinakasang filter kasi yung exhaust niya matatrap doon. So after magamit siya, pinapalitan lang yung filter kasi nandoon si COVID. Kung COVID pa siya. So alam ko, hindi lahat may gano'n. magkapera ako, I'll buy one. Para lang for training purposes. Kasi sa akin, military mag-valve yun. Collapsible. Tapos, syempre, we give one breath per 5 to 6 seconds. I-demo ko yun mamaya. And then, continue rescue breathing until the patient will recover or will resort into no pulse. So, assuming dito, pagdating ko dito, no breathing or gasping, tapos no pulse, CPR. Pero tingnan nyo, bago mag-compress, ito yung difference. Bago mag-compress, kailangan may nakalagay sa ilong. Kung solo ka, tingnan nyo, dito magkaano solo. Kasi peripheral hospital ako, nasa probinsya, kung saan sa amin nasa. Hindi ko minamalita. Kasi syempre, pag malayo ka sa kusina, medyo kulang ang budget mo. So kulang ka talaga. Bago ka mag-compress kasi mag-isa ka lang, nadidelay ka sa 3. Tingnan nyo, makinig kayo, wala to dyan. I-emphasize ko lang, madidelay kayo sa 3. The second delay, may first delay. Ang first delay is wala akong magawa. Yung check, trapezius pins, non-responsive, call for help while check for pulse. Dalawa yan, ang tawag doon overlapping. Pag check ng pulse, code blue ako, bed number 2. Code blue bed number 2. So yung isang nurse or aide mo nandun sa station, tatawag yun. Code blue, surgical ward, bed number 2. Code blue, surgical ward, bed number 2. Tapos, kukunin niya cross card kasi hindi naman tayo social na hospital na per bed. Andun tulad sa St. Luke's, no? Well, merong government hospital, high-tech, sa ER. Sa Davao, antindi. Merong ultrasound pa. Grabe. High-tech talaga. So lovely. Anyway, habang nag-check, call blue. Pagkatapos, 5,000, 6,000, 7,000, 8,000. Delay na yun. 10,000. No pulse. Pag no pulse, ito yung second delay. 3. Ibababa mo pa yung bed. Pero kung magaling ka, talagang may yung bed mo, ano rin, pag check, merong lever yun. Hinahinay, bababa. Pwede yun. So habang nag-check ng pulse. Then, pababa ng bed, first delay sa second phase. Anong next delay? Insertion of cardiac board. Ito problema, inagsosolo ka. Maghintay ka pa ng kasama. Yun yung problem. Kaya ideally, dapat merong cardiac board per bed. Assuming may cardiac board per bed, hindi mo naman kaya ang tao. Pangit naman sa harap ng kamag-anak, hatakin mo lang itong para umakyat o suksok. Ang gawin mo, ang kamag-anak, sir, taakat si tatay, suksok yung cardiac cord, baba siya, para yung ulo nakatingala. Second delay. Third delay, huwag ka mag-compress muna. Lagay mo ng non-rebreather mask. Kasi yun yung pangharang mo sa aerosol. Pero pag may kasama ka, bagbal mask ang harang bago ka mag-compress. Hindi katulad natin compress. Pag nag-compress ako, lipad lahat ang aerosol, assuming positive yan, positive na rin tayo maya-maya. Yun. So yun yung emphasis dito, no? Then compress. So habang nagko-compress, tuloy-tuloy lang, kung interface of 2, 30:2, kung merong bagbal mask, 2, pag wala, or compression ka pa rin. Huwag kang huminto. At lilipat ka sa ulo, tanggalin mo yung bagbal mask ka nila, wham, balik ulit yung that's too much delay. Kasi sabi na American Heart Association, avoid interruption, yung prolong, or i-minimize interruption ang term nila. Hindi avoid. Hindi mo talaga ma-avoid. Pero you can minimize. Therefore, before you start compression, you put the mask. Okay? So, going down, dumating si AED, kasi tayo ay in hospital. Dalawa yan. Andyan si AED. Habang nagko-compress kabit, huwag kang huminto. Kabit ng pads. Tapos, pareho kang nurse, pwede kayo mag-AED kasi dalawa pa lang kayo eh. No? O 3 pa lang. Pwede AD. Yun tinatawag na mag-AED pa kayo tapos later on imamanual niyo pala. Parang overkill, sayang sa gamit, no? Yung mga bagong unit ngayon ay merong AED override. Okay? So, CPR and then sabi ng AED, Kasi susundin mo yung AED. By the way, nauna na ako mag-CPR, tapos biglang nag-shout out si AED. Sabihin ni AED, check responsiveness, huwag ka na huminto. Tuloy-tuloy lang yan. Huwag mo na siya sundin. Call for help. Huwag ka na mag-call for help. Nag-call for help ka lang. Papunta na si COVID. Tuloy-tuloy ka lang. Okay? Mga ganun. Start compression. Magkakadensya. Pip, 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 pip. Yun yung susundin mo. Yun yung compression speed mo. Rate. Okay. 2 minutes yan, guys. 2 minutes. Pip, 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 pip. Dumating si Cold Blue. Ngayon si Cold Blue, mga siga na to. Train sa ACLS. Katulad sa inyo. Pag na-train kayo sa ACLS, pwede na kayo ang members Cold Blue. Kung may Cold Blue. Kung wala kayong Cold Blue, pwede kayo magtayo ng Cold Blue. Yan. Cold Blue team. After 2 minutes, sisigaw siya. Kung walang interruption, sisigaw siya. Analyzing. Bitaw tayo. Kasi analyze niya whether the return is shockable versus non-shockable. Same thing with pediatric access. So this is the luma na algorithm, 2015 up. Ito yung 2015 up. Ito yung 2013 up, 2010 up. Yan. Yan lang yung mga difference. So that's with BLS with AED. So i-demo ko na lang siya. Let's go into ito yung 2020 na insert nila. Nagawa na si 2020, walang COVID, biglang nag-insert sila. Sa soft copy, lumabas yan. Sa hard copy, nag-print out sila. Ini-insert lang sa libro. Okay? So this is what happens. Sorry, this is what happens kapag huminto ka. So maganda ang compression mo, push hard, push fast ka, umabot ka ng 140 to 160 pressure. Tumatakbo yung dugo, na-oxygenate yung brain. Ang problem is pag huminto ka, bagsak yan. Walang oxygenation. Kaya hindi maganda sa pre-hospital na nagbibigay ka ng hangin. Pwede kang huminto, magbigay ka ng hangin kapag dalawa na kayo. Allowed yun. Okay? Pero pag nag-solo ka lang, huwag kang huminto. Tuloy-tuloy ka lang. Now, let's go into choking. Choking dati ay tatlong parameter. Mild choke with good air entry, mild choke with poor air entry, and then the total choke. Ngayon, iba na. Mild obstruction, may breathing, may wheezing, kaya mag-cough. Ang isang parameter, kaya mag-cough. Pag severe obstruction, may sense of doom na. Weak, ang coughing niya hindi buwelo, hindi makagawa ng noise or talk, hirap ng huminga, tapos dito na mamumutla, nagbo-bluish, nagbo-blackish na siya. So balik ako sa mild stroke. Stay on the side of the patient, facilitate breathing, yung breathing huwag pabigla, gagayahin ka, inhale slowly and then cough. Tapos pag cough niya, ganun siya, para siyang inhale slowly, exhale, huwag cough. Inhale slowly, namin cough ulit, may interval na wala. So, kasi pag ipa-cough ng ipa-cough mo, tapos hindi siya nakaka-inhale, ang tendency, i-inhale siya ng biglaan. So baka yung aking obstruction ay lalong ma-dislodge interiorly. Now, in severe obstruction, this is where we will do the Heimlich's maneuver, or we call it now abdominal thrust. They avoid using the Heimlich's. So, i-demo ko na lang yan. So, yan ang i-demo ko siya. Ngayon, you might have undergone training in the Red Cross wherein they do a back slap sa adult. Sa bata, meron. Pero sa adult, binaback slap nila sa scapula. Ang American Heart ay hindi po nagbaback slap. Ang nagbaback slap lang ay American Red Cross. Pero syempre, sinong susundin ko? AHA, ARC. Siyempre, susundin ko si AHA. Bakit? Hindi dahil AHA ako dati. Kasi si AHA ay merong research facility, research unit. Sa American Red Cross, wala eh. Hindi sila yun eh. So more on research si AHA, kaya masusundin ko siya. Ngayon, sa infant, i-demo ko lang, although adult tayo ngayon, i-ano ko lang, i-ano ko, i-demo ko lang. Sa AED naman, depende sa klaseng AED, there is an AED with 2 switches and AED with 3 switches. Yung 2 switches, the first switch is on and off. Alisin mo yung lead, kukunin ko yung AED para marinig mo. So ito, bago to, ito yung tinatawag na mind ray. So, yung mind ray, pinakabago siya, na AED. Yan. Activated by the lead. Pag binuksan ko, magsasalita na siya ko sa akin. Tingnan niyo.
Powered on. Stay calm. Follow the instructions. Remove clothing from patient's chest.
Yan.
Apply.
So, merong lead activated. Tapos, meron pa siyang dalawang switch. Yung unang switch is adult or child mode. And then the last switch is the shock switch. Pag sinabing AD, shock advice, pipindutin mo yan para mag-deliver ng shock. Meron namang AED na ito, trainer's AED. Na hindi siya lead operated. Tinanggal ko battery kasi maingay. Ako na lang mag-announce. Tanggal, tapos i-on mo lang siya. Meron siyang on. Pag on mo, unit okay. Apply type. Child mode. Pag pindot ito, child mode. So, ang child mode is 8 years old below. 8 years old up is adult mode. Tapos shock. So, tatlo. May shock button. Ito pula. May lightning pula. Shock button. Whatever it is, people, this is not rocket science. Two things. AED is not rocket science. Hindi siya big time. Number 2. AED increases the margin of survival. Yan yung maganda. Increases the margin of survival of any down person because of cardiac arrest. Kumpara sa plain CPR. Kung plain CPR ako, one book says 46%. Pag may AED ako, akyat ako ng 82%. Grabe. Kaya ako sa bahay, meron akong AED. Donated lahat. Yung isa, hindi sa akin, pero ako ang nag-take care, caretaker. Yan. So, yun ang assembly, no? Pero kayo as healthcare provider, kaya hindi pwede sa inyo to. Ako pwede kasi may mga anak ako pwede. Kung gusto niyo bumili kayo sa rin niyo, fine. Kasi hindi naman healthcare provider. Sa ospital, hindi tayo nag-AED, nagmamanual tayo. Nilinawin ko lang. Manual po tayo. Okay. So, i-demo ko as AED, ganito na lang. Sabihin ko. Pag turn on, siyempre nakabukas ang dibdib ng pasyente. Apply pads ka. No? Susunod ka lang sa visual at saka sa voice prompt. Visual guide voice prompt. Okay? So, depende sa klaseng AED, iba-ibang command. English yan. Sa Japan, may Nihongo. Sa South Korean, Koreano. Sa Russian, Russian. Wala pa ako narinig na Filipino AED. So, kinakabit natin, merong interrupted pads saka uninterrupted. Yung uninterrupted pads ay katulad ng ZOL kasi merong sensor. yung sol. Mamaya papakita ko yung uninterrupted ng sol. Madali lang siya. Basta susundin mo lang. Pag ang ano lang naman, ang unang susundin mo, kasi nangyari, ang AED, nangyayari yan. Ano na eh, nasa compression ka na eh. Ang unang susundin mo, pag dumating na yung start compression, tit, 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 tit. Ang 2020 is ganito. Tit, 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 tit. Kasi aabot ka ng 120. Pag luma yung AED mo, ganun lang siya. Tit, 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 tit. Luma pa yan. Hindi pa yan updated. So ngayon, ang 2020 is tit, 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 tit. Para abot ka ng 100 to 120. Pag 2 minutes, sisigaw siya ulit. Pup, hinto siya. Analyzing. Wala body part mo or any sa companion mo ang nakahawak sa pasyente. Kasi, tandaan natin, the heart is an electrical organ. Di ba? Ang heart is tatlo yung kanyang, tatlo ang kanyang katangian. It is a mechanical organ, no? Kaya muscle siya. It is a chemical organ, kaya nagre-react siya sa mga epinephrine, no? Tapos, it is an electrical organ, kaya nababasa natin siya as per ECG. Kasi mechanical organ siya. So, yung kuryente, dahil ang katawan ng tao ay 70% water, ang water is ionized. So, conductor siya. So, pag nagpitik ang sinoatrial node ng kuryente, hindi lang ang heart na kuryente, buong body. Hindi ko lang naramdaman yan. Ang body natin, may kuryente yan. Kaya naglalagay tayo ng mga leads dito. Bakit hindi malapit sa heart? Well, vital sa heart monitor, yeah. Pero nalagay tayo dito sa ECG kasi ang electricity tumatapon siya. Yan yung para malaman niya lang. So, ang body tissue natin actually void of any water. Non-conductor siya, para siyang wood, para siyang rubber. Because of water, naging conductor tayo. Kaya pag experiment, huwag naman mag-experimento, baka gawin nyo, no? Isaksak niyo yung daliri niyo diyan sa sakit. Magulantang talaga kayo para kayong na-defibrillate like 200 times over pa. Kasi ang defibrillator, ang pinakabago ngayon is 200 joules. Dati 360. 200 joules is 20 volts yan. Yan, 20 volts. Eh yung nasa sakit mo, 220. Tayo talaga, buhok mo yan. Gusto ko lang linawin, guys. No? Ang AED ay hindi weapon. Nakita niyo sa palabas. Di po totoo yan. Or, assuming, no, just for fun sake, I want to die because iniwan ako, sawi ako. Naglagay ka ngayon ng defibrillator sa dibdib mo. Inon mo ngayon, thinking that you'll be defibrillated. Mamamatay ka sa buwisit. Hindi ka mamamatay sa defibrillator because the defibrillator will not fire. Naglagay ka, salita-salita, pindot ka ng pula, hindi yan magpa-fire because it will not fire unless you have a fibrillating heart. That's number one. Number two, manual defibrillator, yung kinasang ganito, nagsuntukan sa loob ng ospital, kinawas manual, ginano lumipad yung tao. Dalawang error. Una, hindi ka po makapag-fire ng defibrillator. Bakit? Magcha-charge ka pa. Ilang segundo? Mga 1 to 2 seconds. Ilang suntok na tumama sa mukha mo? 3, 4 na siguro. Habang nagcha-charge siya. Hindi totoo. Pangalawa, pag sinyak kita, hindi ka po lumilipad. No? Kaya ako nabibwisit ako sa mga ganyang palabas. Loloko ako dito, hindi naman ganyan. That's exaggeration. Okay, ang ating positioning ng pads is sternum and one is on the apex part. Tapos, ang ating chant, kahit AED, kunwari AED ginamit natin, 1 I'm clear, 2 you're clear, tingin ko may airway ka, 2 you're clear. Pag walang airway, I'm clear, everybody's clear, tingin ka, clear, pindot, boom. Pero ang sequence of chant is, kung manual ka, 1 I'm clear, tingin sa airway, kung doon ang airway or doon ang airway. 2 you're clear, kailangan ng oxygen nakapatay. O bakit nakapatay oxygen? Kasi, electrical yan. Para magkaroon ng apoy, meron kang minimum of 3. 4 yun. Tetrahedron. Pero triangle of fire muna tayo. 1. Presence of oxygen. How many percent? For you to have fire, by the way, sa environment, ilang percent ng oxygen? According to Dalton's law. I know you love physics.
21.
Very good. According to Dalton's law, it's 21. So Dalton's law, the partial pressure of nitrogen around 70+% plus 21% oxygen plus few percentage from other inert gases is equal to 100% at 760 millimeters of mercury sea level. That's Dalton's law. Physics, ha? Para masagot niyo yung mga dilema ng mundo. Love physics because all questions in the world, physics. Kung gusto niyo magaling kayong doktor, in relation to the world, galingan niyo physics. Kuha niyo na ang mundo. Gusto niyo malalim kang humanitarian worker? Physics. Physio. Antro. Wherever you go to the world, you can relate to the dynamics and variations of culture and humanity. Ganun lang. It's not really rocket science. Yun lang, mag-aaral lang tayo. So yung physics is napaka-magandang baseline subject. So 21. Pero to start a fire, ladies and gentlemen, hindi ko kailangan 21. As low as 16% you can have a fire. Saan ako kukuha ng 16? Exhalation. Aba, di ba pag nag-exhale ako, carbon dioxide, bakit may oxygen percentage of 16? Because not everything will be converted into carbon dioxide. Bakit? May tinatawag akong anatomical dead space. Itong space, trachea hanggang sa bronchi, hanggat hindi yan bronchoalveolar, oxygen 21 pa rin yan. Pag binuga ko yan, 21 oxygen. Pero mabilisan nag-admix yung carbon dioxide molecules kasi gano'n naman talaga, maghalo-halo yan sila. No? It's either by diffusion, or by osmosis. Physics ulit. So diffusion is the movement of particles from an area of higher concentration to an area of lower concentration, passing through a membrane which is permeable for that solute. Osmosis naman is the movement of water potential, movement of water from an area less saturated to an area of densely or highly saturated until two comes into an equilibrium. Same with diffusion. And diffusion and osmosis occurs at the same time. Pagdating ko sa fluid, i-discuss ko rin yan. So yun. Yung oxygen mo, kulay green, ilang percentage of oxygen? 100! Naku, Diyos mio. Patay tayo dyan. Kung 21 ang aapoy, ano pa kayang 100? Di sasabog tayo, people. Kaya, pag 1 ang clear, pag 2 you're clear, be sure, ikaw mismo nakita mo, oxygen nakapatay. Pag hindi, pag nag-spark yan, kunwari, merong hindi ka na resolve, basa konti, nag-spark, tapos may oxygen, kita-kita tayo sa, hindi ko alam kung langit o impyerno. Yan, ha? 1 ang clear. Tingin sa airway, clear. Bago sisigaw si airway, clear. Be sure, 0. Clear. 3, everybody's clear. Be sure, the kamag-anak is not touching the patient. Tatay, kapatid ka. Walang hawak. Everybody's clear. Bago pipindot. Hindi lang yung pipindot ka, may nakahawak. Una, ganito yan. Pag hinawakan niyo yung pasyente, nag-analyze yan, hindi siya makakabasa maayos. Baka, sasabihin, continue CPR. Yun pala, isa-shock na. Bakit? Hinawakan mo eh. Ikaw may electricity ka, plus electricity na wenda ngayon sa AED. Kaya, sa analyzing, tinataas ang kamay. Analyzing. Ang tuhod hindi nakagarahe sa katawan ng pasyente. Yan. Tingnan yung picture na to. Pero sa pakiramdam niyo lang, ang thigh na sa pasyente hindi nakatouch. Okay? Then kung ang nakita ng AED ay flatline, no shock advice. Pag nakita niya ay shockable rhythm, pulseless ventricular tachycardia or VF, then shock advice. Magsisigaw, shock advice, stand clear. Shock advice, stand clear. Wala kang gagawin, sisigaw lang siya, shock advice, stand clear. Ganun lang si AED. Halimbawa, binuksan ko si AED. Apply pads. Hindi mo in-apply hanggang Pasko, darating ang Pasko, hanggat may bateryan. Apply pads. Paulit-ulit lang yan. Apply pads. Kasi dinisign siya na gano'n. Hindi naman siya AI eh. Program siya. Okay? Pag after the shock given, check for pulse, pwedeng ganun, or shock given. Continue CPR, depende sa anong advice ni AED. Okay? Pag sumigaw siya, check responsiveness, ibig sabihin, parang may nakapa na siya. Pag check responsiveness, check for pulse ka. So, I will not give a rundown so much, no? Sige lang, sige, shortcutting ko na. AED and children. Ang AED and children, automated po ang AED. Pag nag-child mode siya, 2 joules per kilogram yan. Ina-adjust na niya. Don't worry of computing, the machine will do that for you. Number 2, wet person, you have to dry. Kasi yung AED, pag buksan nyo, yung full set nyo, makikita may towelet, pangpuna sa dibdib. Yan. Then, hairy chest, merong kasamang razor si AED. So, nire-razor, hindi buong chest, no? Unless feel mo, i-razor mo kasi guwapo, yan, no? Pero, ano mo lang, nire-razor mo lang ay yung sa sternum part, at saka kung merong chest, hair dito sa apex part. So, yun lang. Pacemaker. Karamihang pacemaker ay nakalagay dito. So, hindi talaga siya matamaan kasi yung aking, ito nakalagay sa left upper. Yung aking AED naman, apex, ano dito? Wala namang naglagay ng pacer dito sa kanan. Matatakpan siya, bawal yun. Tapos AED and bra, gupitin pa natin bra, pwedeng hindi expose yung breast mismo kasi hindi naman siya matamaan. Ilagay lang natin. AED and jewelry, actually hindi siya halos nakatan. Huwag naman yung exaggerated jewelry, baka lang. Pero it's just okay. Pero, kasi it might delay na. Wala naman siya ng bibit jewelry na sangkatutak na katulad nitong loko na to. O yan, maraming jewelry. Yan, tanggalin mo na yan kasi wala tayong magawa. Asan ko ilalagay si pads dito? Okay. Now, let's go into naloxone before I'll give you a break. Kasi give you a break dahil magde-demo na. Si naloxone, dalawa po siya, si Narcan at saka si Cloxado. To be honest with you, I haven't tried Cloxado. No, I'm not gonna fool you around. I tried Narcan. Actually, meron ako. Pero expired na at hindi ko mahanap saan. Marami ko nawalang gamit sa daming gamit. Nag-isang spray ko lang. Gusto ko siya i-demo. Dinemo ko na dati. Nawala, in a misplace. So, ang si Narcan, dalawa ang preparation. Isang 2 mg, isang 4 mg. Si Cloxado, 8 mg. Malakas siya. So, simple lang yan. Initial dosing, 1 spray, intranasal, sa isang nostril. Bakit? Kasi kahit anong CPR mo, pinakamagaling ka mag-CPR dyan, may AED ka pa, hanggat umiikot yung opioid sa katawan mo, mag-erratic talaga ang heart rate mo. Hindi talaga yan madadala sa ganun. So, kailangan i-reverse mo siya para may justice ang CPR defibrillation mo. In US nga, pag nag-responde EMS ng US, lalo na pag overdose, may respiratory depression, sinasamahan ng polis. Kasi, assuming hindi siya cardiac arrest, respiratory depression pa lang siya, no? Tapos, ang sarap ng feeling, hindi niya alam mamamatay na siya. Yung kasamahan ng tumawag ng 911, ni-reverse mo yan, nawala yung pagkabangag niya, saksakin ka niya. Because it took him or her heaven and earth to get the opioid. Ngayon, binasag mo yung trip niya. Kaya ang EMT na rumiresponde sa drug overdose, may kasamang pulis. Kasi pag pumalag yan, bahala na si pulis. No? Ganon. So yan po si nasal spray. I call it atomizer because it atomizes the fluid. Ganyan kaliit. So isang spray, diretso sa brain, na-reverse ang respiratory depression. Okay. Now, if you need to have repeat dosing, just in case, no, you can ask for medical control or the doctor. So, ganyan ang posisyon para tatama sa turbinates. Okay. Now, ang interval natin is 2 to 3 minutes. Kung hindi na-reverse ang depression, pwede ka pa mag-add. So, ayun natin. Now, I will also introduce you to the field CPR. Ano yung field CPR? Nasa field tayo, paano gawin? Out of hospital. So, sa libro, merong 5C. Sa libro sa Philippine Heart Association, ako 10C. Pero hindi ibig sabihin magaling ako kasi 10C. Kinumpleto ko lang yung array. So, number 1, consider everyone to be COVID positive. Pag nasa field ka, rumisponde ka, isipin mo, baka may COVID. Okay? Yan. Number 2, check-in. The word check-in is used in incident command system. Huwag kang basta-basta papasok sa loob. Magpapakilala ka. Ako po, si Juan de la Cruz, isa po akong nurse, baka po makatulong. Ang word baka. Kasi sa atin, wala tayong Good Samaritan law, number 1. Number 2, wala tayong EMS law. Para alam niyo lang. Pero ang maganda, pag doctor, nurse ka, nag-responde ka sa field, malaki ang walang problema kasi meron tayong PRC. So, ang laki ng ating right, karapatan. But you still use the word, maybe I can help. Number 3, crowd control. Pinrepare ko yung sarili natin kasi mga Pilipino, karamihan marites. Pag may tumumba dyan sa kalye, nako, labas ang cellphone, nakikiusyoso, walang ginawa. So, crowd control, huwag mong palapitin sa'yo. Malay mo, may COVID positive. Yung tawag nito, tawag ng transmission na yan, pag marami yan. Super spreading event yan. Next, number 4 is check for hazard. Ano hazard? Bakit siya natumba dyan? Na kuryente, nasaksak? Kasi baka nandyan pa rin yung hazard. So check for hazard. Number 4, check for responsiveness. Pag nag-check kayo ng responsiveness, huwag dalawang tap. Pag gumamit ako ng my right, sa right, para mas malayo ako kasi pag dalawang tap, mas malapit ako sa tao. Pag single tap, tapos trapezius pins, ipins nyo to yan. Hindi halata yan sa camera. Masakit po yan, pero pag ipins mo sarili mo, hindi ka masasaktan. Pero pag iba mag-pins sa'yo, masakit yan. So, gingiwi ang mukha ng tao, ibig sabihin, gising yan. Pag wala, wala. Then, kung healthcare practitioner ka, you can, pag ganun, call for help. You can call 911 or any local number. Pag tumawag kayo, dalawa. Sir, patawag po ng tulong, patawag po ng ambulansya at saka tanod, tatlo. Call for help kung hindi mo kayang gawin. Call for the ambulance. Next, call for the tanod. Sabayin mo lahat yan. Bakit? Kasi wala tayong pre-hospital at saka Good Samaritan. I-endorse mo sa tanod along the way. Para sila na ang magbitbit at mag-continue ng CPR. Huwag ikaw. Kawawa ka. Next, bago mag-CPR, cover the mouth and the nose with mask para yung aerosol matrap doon sa mask. Yan yon. Yan yung interim guideline of 2020. Then, compress of no less than 100 to 120 per minute in straight 2 minutes. After 2 minutes, check for responsiveness. Biglang dumating, number 9, connect to AED, listen to voice prompt, then continue CPR, and then AED. Walang ambulance, case evacuation. Case evacuation is the evacuation of casualty not in a normal medical transport unit. Kaya sinabi ko case. Nangyari po yun sa akin nung kasagsagan ng COVID. Lahat ng ambulance ay for COVID. So, nilagay namin sa likod ng pick-up. 2 hours ako naghintay, walang tulong. Pero buhay naman yung tao. 3 o'clock in the morning, inabutan ako ng 5. Kaya tingnan nyo, ang tina ko, nakapantulog pa ako. So, ito rin, kasama sa BLS, is your stroke identification. So, ang sinundan natin is Cincinnati pre-hospital care, which is fast, pero ito revise. Be fast na. Letter B, there is sudden loss of balance. Tatlo yung letter B, loss of balance. Sudden, and or behavioral change. Iba to, parang blunt, tapos parang irritable, pero blunt affect siya. Yun pala, may stroke na. And or brain fog. No, wala siyang alam. And or eyes, blurring of vision. And or facial asymmetry, ngumiwi ang mukha. And or arm and leg weakness on one side. And or lang yan, hindi man lahat nandyan. And or slurring of speech. Ladies and gentlemen, kung nasa labas kayo, pakidala na sa ospital, mabilisan yan. Para ma-practice natin yung door-to-needle approach. So ayan, be fast, just in case of stroke. Okay? So ito, although ACLS to, status epilepticus, pinick up namin, kasagsagan ng COVID, Dumaguete to Manila. Now, what is the form of BLS? Ito po yun. Airway, compression, defibrillator. Yan yung the list lang. Si leader ay nasa defibrillator. Pwede siya makipagpalitan sa compressor kasi every 2 minutes magpalitan. Basta nasa kanila ang team leader. Palitan yan hanggat darating niya. Si airway lang siya. Bawal siyang palitan para hindi tayo magka-cross-contamination. When do you stop CPR? Number 1, tandaan niyo lang yung stops. Spontaneous return of circulation. Bumalik na. Magkamalay na. 2, transfer to higher level of care. Halimbawa, first aider ka, dumating yung EMT. EMT, dumating yung nurse, doctor. Endorse mo lang na endorse. 3, operator is exhausted. Huwag ka na magpahiro. Baka ikaw, pangalawa mag-arrest. 4, physician's advice. Legal medicine yan. Hindi kasi doktor ako guys ha, for the nurses. I'm still the captain of the ship. It's my command. Whatever I command you, you follow it. Kasi legal medicine. Yan yung tinatawag na physician's advice. Next, scene becomes unsafe. For example, nagsi-CPR ka, biglang nasunog yung ospital. Alam, mag-CPR ka. Dalhin mo na, i-drag mo na yung pasyente outside. Assuming hindi talaga man-drag outside, sobrang bigat, tumakbo ka na. Wala na akong magawa. Universal law yun. Okay? Now, what if you break a rib? According to the revised penal code, Article 12, paragraph 4, any person who, while performing a lawful act with due care, at saka professional ka, causes an injury by mere accident without fault or intention of causing it, you will be exempted from such. Nagkataon lang, bumigay lang talaga yung ribs. But it takes a weak individual or a very strong or a broken rib, not yet broken, dahil trauma, tapos na-break na lang siya. So, there are factors to be considered. Remember, 85 to 90% is ventricular fibrillation, shockable rhythm, yung nagka-cardiac arrest. So, this guy, the cardiac arrest, nabuhay namin, twice siya nag-arrest, nabuhay siya, meron kasi akong sariling defibrillator. Kinasuhan niya ako kasi nangitim yung dibdib niya. Pero hindi na puso yung kaso. A month ago, na-meet ko yung, kasi sundalo, yung kanyang kasama sa airport. Pinasalamatan niya. Sir, salamat po na binuhay niyo po yung aking bangki. Kasama niya sa barracks. So we don't know, people, basta we just save life because there is a young heart which is too young to die. Lahat tayo kailangan buhay niyan. But we have to note that there is also a heart which is too old to live. Let's give it a decent one. Okay? With that, I'll give you a break while I'm gonna prepare my dummy para sa ating demonstration. Do you have any question? I'll give you 15 minutes break. Kaya natin sa lahat ng demo before 12 matatapos. Question? Grabe. Hindi ko alam kung may naintindihan kayo. Walang question, isa. Okay, kung wala, I'll give you a break. See you after 15 minutes para sa ating demo. Now, let's start with choking. So sa choking, doon tayo sa mild. Pag merong mild, stay on the side of the patient, assure him or her, teach the breathing pattern. Yung breathing pattern, yung inhale. Ay, sige po ha. Inhale soft lang. Sige, relax lang kayo, tingin sa akin. Tapos luluha yan. Inhale ha. Sige, gahin niyo ako. Ganun mo. Tapos cough. Sige cough. Ganun. Ganun siya. No? Okay. Konti lang, inhale. Sige. Buga. Inhale. Okay. Pakinggan mo kung mayroong sound. May wheeze. No? Pag next, buga ulit. Tap lang konti second. Sige. Cough. Cough. Ganun. Sige. Cough. Sige. Inhale konti. Sige. May naramdaman ito, na? Meron? Sige nga, sige, sige. Cough. Yeah. Inhale. Until he or she coughs off whatever is there. For severe obstruction, you will hear sounds or no sound. Ito pa lang sa mild, may sound yan. Kasi may air entry. Severe obstruction, minsan meron, minimal, sirap siya. Tapos, nasa side ka, tendency harap sa iyo, hahawak sa iyo. Hawak na yan. Sa mga experience ko, na ganun lang, hindi dalawa. Nakamanage na ako ng ilan. Hawak ganun, sisinyas, pero mas grabe hawak siya. Hawak ko, ganun talaga yan. Kasi ang tawag dun, sense of doom. So, you prepare yourself kung saan, tingnan nyo to, nakatayo, kasi half body lang. Yung sa ibaba ko, full body, pero mabigat. Yung paa mo, nasa gitna ng paa niya. Kung nakatayo, nasa gitna. Kasi in case matumba kayo, kung wala sa gitna, nakatayo ka, ganun lang, pwede kayong matumba dalawa kung nakatayo. Bakit na ganun? Kasi in case na mawalan siya ng malay, pwede mo siyang paslide lang hanggang maihiga na. So, nandoon, tapos dito sa xiphoid process, 2-finger bridge down, gawa ka ng ganito. It can be right or it can be left. No? Push mo siya, ito masakit. Don't do this at home. Gawin nyo na. 45 degrees towards the scapula of the patient. Okay? Hinga. Okay, sige. Tapos, sabay mo kung kaya mo. Kung wala naman, pwedeng asynchronous. Okay, sige. 2, 3, 4. And then up until he comes out. For freak reason, wala. Slide the patient. Wala nang malay. Pag wala na, ano pa siya, gasping, wala. Kapit, wala. Di ganun nag-react. Chest compression. So, two things. Meron sa military, ginagawang 2 and hold, 2 and hold. 5 and hold. 1, 2, 3, 4, 5. Tingin kung may lumabas. 1, 2, 3, 4, 5. Pag may lumabas, sabay hinga yan. Atakin mo yung damit para mag-side ka agad. Huwag na yung 4 counts na recovery position. So, hatak damit mo hanggang iluwa niya. Ganun lang. So, i-demo ko mamaya pagdating ko sa BLS. Lalo na isama ko sa drowning program. Okay? Now, anong gawin ko kapag choking na resolve na? Kapag na-choke niya, may mga sharp. Na-expel na choke, may mga sharp. 1, 2. Pag choke niya, may kasama, may dugo. Dalhin niyo sa ospital yan. The two things. Baka na-injure ang larynx at mag-laryngospasm. Mag-asphyxiate yan kahit wala na sa choke. 1, 2. Mag-infection yan. Tandaan niyo, there are more organisms in the mouth kumpara sa anus. So, siyempre, mas malapit ang mouth papunta doon, mas marami organism. So, prone sa infection. Kaya, mandatory hospital. Parang drowning din. Pag na-drown yan, na-revive mo, okay na, sir, salamat po, you are my hero. Hindi po yan dinadala sa bahay. Inoobligado po natin dalhin sa ospital para ma-observe kasi magkakaroon ng sa lumang libro, tinatawag na secondary drowning. Ngayon, hindi na ginagamit. Family na lang siya ng ARDS, Adult Respiratory Distress Syndrome. Pero dahil may history na drowning siya, post-drowning condition. Sabihin natin may laryngospasm or what, or distress syndrome na nag-spasm. Kasi ang drowning kasi is spasm. Hindi na puno ng tubig ang baga kasi pag i-autopsy niya, halos walang tubig pa rin ang lungs. Kasi nagsara lang yung larynx. The larynx will close every time you lunok. Lunok ka maka-close. The second thing na mag-close yan kapag sa martial arts, tinamaan niya or any trauma na tumama to. Third is pag nalubog yan, submersion or immersion sa water. Pag sinabing submersion, nasa ilalim ka ng tubig. Pag sinabing immersion, wala ka sa tubig pero nakatihaya ka. Tihaya ba tama sa Tagalog? Nakasupine, binubuhusan tubig yung torture, tawag ng drowning by immersion. So, yun. Okay? Now, let's go into doing, unless you have question with what if hindi na-resolve? Pag hindi na-resolve yan, mag-BBLS. Pag nag-BLS ka, yan, compression lang. Kasi hindi ko alam na saan ang bara. It's not your problem until it goes to the hospital. Mas huwag mo siyang bitawan compression. Until ACLS arrives, ganun ka lang. Kung wala ka makita. And do not blind sleep. Wala ka makita, kutkot ka ng kutkot. Do not blind sleep. Okay? Lalo na sa bata, do not blind sleep. Yun lang yung rule of thumb. Now, what do we do with, what do you call this? Respiratory distress. So, dito ako, bababa. Uy, nako, nahulog ko Ito. Pag-valve mask, pag-valve mask is a complete mask, a complete set with the valve, and the mask. Pero hindi siya pwedeng ganito kasi walang silbi kahit nakalagay si oxygen, hindi aabot ng 90+% oxygen delivery. Kailangan meron kang reservoir. So this reservoir will fill this up more oxygen para umakyat siya ng 90% up. 90% kasi yung bottle oxygen mo, dalawang klaseng oxygen, yung merong humidifier is a medical oxygen. Yung wala na merong 50 liters per minute is the emergency oxygen. So ang ginagamit natin sa emergency is the emergency oxygen. So 15 liters per minute, hinanap ko yung oxygen ko sa ilas. Kumalap sa amin. Hinanap ko nga pamay. Nakita ko lang somewhere yung 15 liters ko ang naiwan kasi dyan yung may humidifier. So assuming meron akong bottle oxygen, 15. So 15 yung sirit-sirit. Okay, ganito nagkakamali. Karamihan ng valve mask, ginaganon lang nila. Ay, doctor, nurses, nakikita ko, yan. Mali po yan. Okay? Hindi ko totoo yan. Pag nag-valve mask kayo, letter C, letter E. Dito kayo sa head part. Pwede rin dito sa side part. Ito yung tinatawag na side approach. Ang side approach, pag nandito ko sa kaliwa ng pasyente, gagamitin ko yung kanan. E, dito sa bony, mandible, inferior margin. C is the seal. Seal. Ang galing ko. Seal. Letter C is the seal. Seal. Tapos ito, angat. Kalso dito. Alam mo lapit. Kung ayaw nyo magkalso, gamit kayo ng Tootsie Roll. The Tootsie Roll is something na ilagay mo under the neck or cardiac board. Pag nilagay mo ng cardiac board, mahanap yung cardiac board. Assuming ito na lang yung cardiac mode. Sorry guys, kompleto ang gamit. Nagkagulo-gulo yung gamit ko. Ito na lang cardiac mode. Lagay ko sa mama. Walang katulong eh. Boom. So nakatingala siya ngayon. Nakatingala. Yan. Naka-hyperextend ang neck. Okay? So hindi ko na kailangan basta yan. Kasi pag nakatingala yan, kahit kayo, subukan nyo na nakatingala kayo. Tingala kayo lang. Tingala. Tingala talaga. Hyperextend. Lunok. So hindi na kayo makalunok. Yun yung ina-achieve natin. Kasi, pag nag-valve mass ako, tatlo pinupuntahan yan. Mag-bleed out yan dito sa gilid. Pangalawa, pupunta sa baga. May hindi pupunta sa baga. Pupunta sa tiyan, saka mag-bleed out. Meaning mag-bleed sa side. Pag sinil ko yan, I sealed it. I mean, I'm so tight, walang bleed out. The problem is, na-hyperextend ko. Pag hindi ko na-hyperextend, pupunta sa tiyan. Kailangan naka-hyperextend. Kung dito ka sa harap, ganun din dito. Kung two-man approach, dalawa, seal. Yung isa magbabag. Pero single approach na ako kasi limit personnel, hyperextend and back up. Back, 1,000, 2,000, 3,000, 4,000, 5,000, 6,000. Back, 1,000, 2,000, 3,000, 4,000, 5,000, 6,000. Sorry, natanggal. Back, 1,000, 2,000, 3,000. Gano'n na. Sa respiratory address or respiratory disease. Okay? Never kang mag-bag na hindi mo yung hyperextend kasi useless. Maya-maya, mapuno yung hangin ng tiyan. Pag mag-reverse yun, malaking problema natin yan. Yan ang dilemma. So, kailangan sa lungs lang pupunta. So, again, letter C, letter E. Hyperextend. Okay? Yan. Pag CPR na, tapos two-man rescue, huwag bitawan. Yan lang siya. Yan lang. CPR siya. Pam, 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 30! Ngayon, mayroong defibrillator. Analyzing. Huwag mong hawakan ng skin. Bitawan mo. Put off the oxygen. Shock advice. Stand clear. Huwag mo nang tanggalin kasi minimaintain natin close. Wala namang conductor yan. Diyan lang. Shock, move, shock given. Continue CPR. Put on the oxygen. CPR ulit. Diyan lang siya. Para habang nagsi-CPR, yung aerosol matap niya. Yung pasyente dumating or pasyente nag-arrest, bago mag-CPR, unahin mo muna ito. Then, wag kang mag-bag, unahin lang. Flow of oxygen, CPR. Hayaan mo lang siya. Diyan lang yan. Right seat. By the time na 1, 2, CPR ulit. Hayaan mo lang siya dyan. 30, 1, 2, yan. Until the ACLS team arrives or the closed book team. Okay? Question again. You can use a junk, nasopharyngeal or airway, depende sa inyong protocol. So, mag-oropharyngeal, i-demo ko siya sa ACLS. Mag-bridging towards sa ACLS ko siya. Tapos nasopharyngeal. So, ito pala, ito. Ang ina-encourage sa interim guideline is the closed circuit. Kailangan hindi umiikot ang ano na tao. Kasi ito, kailangan lalabas siya. Ang labasan kasi pag nag-exhale ka kasi dito, dito siya lumalabas. Yung bagong pag-valve mask ngayon, meron siyang square na merong HEPA filter. Ito luma. meron akong pamilitary doon, pero ito naman ang gamitin. Bugbog na masyado. Okay? Question, guys. Now, let's go into BLS. Itayo ko lang ito para makita. Kita niyo yung dibdib ng tao. Klaro. Okay, so merong pasyente dumating. Patient, nakagupit na eh. Came in, sabihin natin fresh case. Fresh case. Okay. Sinabing fresh case, labas yung tiyan. Fresh case. First, isipin nyo, naka-down ako, PPE. Sino ang kailangan eh? Down PPE. And approach the patient. Mag-down na lang ako. Ayoko yung nagtuturo ako, hindi ako naka-down. Wala ako ng gloves. Guys, ito na yung sequence. Naka-down ako, pero kulang pa ko kasi sabi nila level 4. Pero dahil nababa ng COVID, pinakamataas siguro, level 3 na lang. Wala ng shield. Okay. Dito ako, may pasyente, first case, dala sa ER, sinakay sa jeep, pagdating sa'yo, check level of responsiveness. Okay? Ideally, dalawa. Pero dinidiscourage, isa na lang. I'm on the left side pas malayo. Sir, trapezius pins. No response, code blue, bed number 1 ER. Bed number 1 ER. Kung nag-iisa lang ako, ikabit mo muna sa non-rebreather mask. So ito yung non-rebreather mask. Kabit mo muna. Kung nag-iisa ka. Okay, so yun ang delay. Ang delay, dinagsak sa ER, baba yung bed, lagay lang. Cardiac board, lagay ng non-rebreather mask. Okay? Then, start compression. Okay? Kapag dalawa kayo, gamitin ko itong isang dami ha, alalay ko, airway kunwari. Si airway, tulungan mo ko part sa airway. Airway na ako. Compression. Pam, 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 pam. 30. Move. Move. Dumating si AED. Pag dumating si AED, huwag kang huminto. May nanggugupit na kasama mo. So, expose. Oh, sorry, natanggal. Tuloy. Huwag hinto kasi sabi sa American Heart Association, no interruption or minimize interruption. So ito ang tinatawag na uninterrupted pads. Okay? Anong uninterrupted pads? Meron kang dalawang pads, merong sensor sa gitna. Yung interrupted, walang sensor sa gitna. Ang ZOL, meron siyang sensor. So habang nagsi-CPR ako, pin repair, angat, tuloy. Lagay ito, hindi pa nakadikit yan, tuloy lang. Tinatanggal yung ilalim, didikit. Itong sa apex, tanggal ilalim, didikit. Ang ZOL ay mayroong sensor na kung saan nagsisensya kung ang pag-CPR mo ay tama ang speed at tama ang lalim. Okay? Pag medyo kulang, sisigaw yung machine, push harder. Yan. Pag mabagal ka, push faster. May sigaw siya. Pag paulit-ulit mabagal ka, push faster. Maulit pa rin mabagal ka, push faster, stupid. Mapapahiya ka ngayon. Biro lang yan, wala pong gano'n. So, yan po ay pag automated override. Pero pag manual, yung team leader, sisigaw sa'yo, guys, ayusin mo. Pag wala, papalitan ka talaga niyan. Yan ang role ng team leader. Medyo masakit yan, mapapahiya ka konti. Kasi siyempre, palitan yung aking compressor, hindi niya kaya. Kunwari, mandiyanong maliit ako, hindi ko talaga malagay ang katawan sa taas. Kahit naka-footstool ako, papalitan niya ako. Ganun talaga ang job ng team leader. Okay, so, compress. Analyzing, bitaw. So, yung AED, sumigaw, analyzing. Nakalagay lang ito para makita niyo, may AED. Shock advice, stand clear. Okay, 1, I'm clear. Titingnan ko sa likod. 2, you're clear. Nakapatay sa kanya. 0. 3, everybody's clear. Sigaw lahat, clear. Ulitin ko yung chant. 1, I'm clear. Walang sisigaw. 2, you're clear. Si Airway lang sisigaw. Clear. 3, everybody's clear. Lahat sisigaw kasama si Airway. Clear. Pindutin ko yung pula. Poop! Bigay ng shock. Shock given. Check for pulse. Checking pulse 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 7,000, 8,000, 9,000, 10,000. No pulse. Siya rin, na-detect niyo wala. Continue CPR. Ang magsi-CPR isa na kasi sa interim guidelines of 2022, every 2 minutes nagpapalitan ng kompreso kasi nakakapagod mag-compress. Kailan magpapalitan? By the time analyzing. Analyzing, palit ka agad. Huwag dumaan sa airway, dumaan sa paa. No shock advice. Continue CPR. So no shock advice. Continue ka lang. Until the ACLS arrive. Ngayon, the patient, BLS pa lang, nabuhay siya. Anong gawin natin? Sa pre-hospital care, nire-recovery position. So, paano ang recovery position? Gagawin ko sa sarili ko. Lipat na lang ako. Hirapan ko tanggalin to. Lipat lang ako. Pag recovery, nakahiga. Nakahiga yan. Itong kamay, taas isa. Ito lagay, hawakan mo yung ito. And then, ang recovery position mo is towards the patient's right. Itong left knee, angat mo. Yan ang left knee. Nakita niyo left knee ko, angat. Ito hawakan mo kasi sa totoong buhay, pag nilagay mo dyan, hinawakan, public yan, dead weight ang tawag dyan. So ito rin, bibikaka siya. So ito hawakan mo. Una to, 1, 2, tapos yung knee, tingnan mo knee, 3, tulak, 8, sabig pa ganun. So magiging ganun ang pasyente. Sa pre-hospital, sa out of the hospital, ganyan. Pag sa inside the hospital, case-to-case basis. Kasi usually ini-intubate na yan. Mabilis kasi intubation ngayon according to American Heart. Okay? Pero, ang pag lateral recumbent position tawag nito o recovery position, kapag walang vomiting. Pag may vomiting, mabilis po. So, ganito po ang vomiting. I-demo. CPR. May damit ha, may damit. Nalunod. Biglang sumuka. Atak lang. Walang damit. Hindi mo mahatak. Ito yung modified. Hawak dito, hawakan mo yung kamay. Yan. CPR. Walang mangyari. Push hard, push fast pa rin. Andyan pa rin si push hard. Oh, sorry. Andyan pa rin si push hard, push fast. Tingnan niya. Push hard, push fast pa rin. 1. Okay. Nasa 100 to 120. Adequate recoil. Tama yung depth. Bigla siyang sumuka. Atakin mo lang yan. Yan yung mga modified. Another thing. Nasa narrow corridor ka. Hindi ka makasipr ganito kasi narrow. Ang tawag dito striding CPR. Nandito kasi babaw ng pasyente. Hindi mo sinakyan yung pasyente. Hindi sinakyan. Naka-kneel down isa, kili-kili, yan. Striding. Pero hindi ako nakadagan sa pasyente, hindi ko siya inupuan. Tawag ng striding. Pag narrow corridor. Low headroom. Mababa ang headroom, nasa loob ng helicopter or what? Ganito. Pwede ito, pwede ito. Hindi siko, kundi ulna. Yan. Hawak yan. Mababa headroom. Yan. Okay. Yan. Ganyan yung mga adjustment ng CPR. So, importante, naka-recovery position tayo just in case pag sumuka. Kasi, sa drowning kasi, there are 5 questions that the lawyer will ask you. Number 1, what kind of water nag-drown siya? So, there are 6 kinds of water. The first 2, maalat at tabang. The second 2, warm water versus cold water. Cool water, cool. Ang cool water is 20 to 11. Ang cold water is 10 to 1. Ang 0 is freezing water. So cool is 19 to 11. Warm water is 20 to 11. Warm water is 21 to 39. Beyond 39 is scalding water. So ganyan ang definition. So warm water versus cool water or cold water. The next 2, dirty water versus clear water. So yun ang unang tanong. Pangalawang tanong, gaano siya katagal nasa ilalim ng tubig? Kunwari, 5 minutes. The third question, gaano katagal ang responder? Kunwari, responde 5 minutes. Di 10 minutes siyang nasa ilalim. Next, ano yung skills ng responder? Panglima, ito yung nakakatakot. Nakalanghap ba siya ng suka niya? Kunwari, sumuka. Ang tao pag sumuka, gigilid yan. kung malakas siya. Paano kung mahina na yan? Hindi yan gigilid. Pag suka niya, the next episode, hihigupin niya suka niya, papunta sa airway. There is your aspiration. Kaya, pag nag-CPR, biglang susuka, mahina, tulungan mo na. Tapik. Yun yung essence na ina-emphasize ng Utstein style. Wala pa sa Pilipinas. Okay? Utstein. Sorry, nais ko electric fan. Tandaan niyo yung mga ano sa drowning. May emphasis ako sa drowning. So wala na tayong tinatawag na dry drowning, wet drowning, secondary drowning. Kasi under Utstein style, the Utstein style is the international regulation of pre-hospital care provider. Tapos basahin niyo na lang kasi hindi naman kasama sa BLS. Pero kung gusto niyo matuto how to take care of drowning, Orlowski kayo. Orlowski score. Edad ng bata, 5 minutes na tugunan ba? More than 10 minutes ba na nasa ilalim? Mga ganon. Ano ang pH no, sa ABG? So Orlowski score will give you that. So sa basic life support, ang ating ang unang dictum is lalo na pag pre-hospital care is the scene survey. Kasi kung anong nakadali dyan, nandyan lang sa paligid. Most likely. Lalo na pag external factor na kuryente, naglason. Sabihin natin cyanide, inahawakan mo yung cyanide, pwede ka malason. So, ganyan. Ha? And then, of course, is gaano katagal ang emergency response yung stay and play mo. Halimbawa, sa akin, CPR ako nasa bahay, gaano katagal? Are you waiting or are you gonna deliver the patient to the hospital? So, pag deliver, ano ka? So, you should know how to do CPR at the back of your car. So, nakahiga sa likod ng sasakyan, yung paa nakaangat lang, papunta kong 2-door, 4-door, sedan or 4-door, yung pick-up. Tapos ang paa nakaangat lang kasi kung hindi, lalabas sa bintana yung dalawang paa. So habang nagsisipir sa likod, drive towards the hospital. Sa tricycle, ganun din. Yung paa tumagos doon sa driver, sa tangke ng driver, merong taong nakaupo. Yung kanyang thigh, yun yung cardiac board. Ang nagsisipir, nakayuko. So itong ginagamit ko, depende sa headroom. CPR siya on the way to the hospital. So yun yung no interruption. You should know how to do that. Walang nagtuturo niyan. Pero kung somewhere in the near future you want to have an improvised CPR, I can teach you. CPR on top of parang ano, in a military truck, low headroom, gano'n. So, once you have drowning and the patient recovered, it does not mean that he's okay. It can go into another arrest. Bantayan yan. Tuloy ulit. So, en route to the hospital, you should have plans on how to do it. ACLS becomes ACLS once you put the line. Start with the line and the airway. Dati, line. After 2 salvos, airway. Ngayon, hindi. Pwede ka mauna ang airway. Kasi sa closed circuit, kailangan malak na agad, malayin ka agad para hindi nakakalat yung COVID. Nandun lang sa bag valve tapos sa HEPA filter. Tawag nila closed circuit system. Interim guidelines of 2020. So, AED, basic life support. Ngayon, pagdating natin sa bata, isa lang. Kung sa Bicol, malumoy lang. You can do one. Huwag dalawa. Kasi masyado baka madain mo. Ito, tapos itong isa, pwedeng humawak sa ulo para hindi ka walang tendency na ma-push hard. No, lalo na mga nasa 1-year-old, 2-year-old. No? Kung hindi mo na kaya kasi nakakapagod yan, pwede na to. Ito lang. Okay? Pag baby, hospital-based kayo, lagay sa platform. Hospital-based eh. Kalagay sa platform. Pero pag pre-hospital, tinatawag na CPR while on the run. Ganon. Pataas, ito, itong ulo niya lalaylay. Kaya mo nilapit sa iyo. Ang CPR, pag gano'n, hindi pa gano'n. Habang tumatakbo ka. Ang cardiac board, ito. Yan. Yan, habang tumatakbo. Okay? Huwag kang mag-mouth-to-mouth when running. Kung kamag-anak mo yan, 30, 15. Sorry, 30. Pwede ka magbigay mouth-to-mouth. Kamag-anak mo, anak mo or what? No? Sa bata, ganun din. You can do mouth-to-mouth kapag kamag-anak. Pag hindi, no. Okay? Sa choking, same, di naman mahawak yung bata, pero merong, sabi kamag-anak, may na-choke siya, 5 thrust, 5 by 5. 1, 2, 3, 4, 5, lagay sa platform, kuha, scoop, huwag sa leeg, cementum, lagay sa likod, laylay ang kamay dito sa tutuboy, lalaylay yan dyan. Ganon. Para ang spine nasa in between. 1, 2, 3, 4, 5. Scoop. Ganon, lagay sa platform. 1, 2, 3, or sa lap. 1, 2, 3, 4, 5. Habang nakatingin. Paglabas, kuha, pins, kuha, tapik, baby. Ganon. Yan. O wala, tuloy. Until the baby loses consciousness, you perform CPR. Again, CPR 30:2, single rescuer. Kung kamang-anak. Pag if not, tuloy-tuloy lang. Kasi pwede rin magbigay ng infection sa'yo. Okay? So that's it for baby. Question? Dali lang pala ng ano. Practical eh. Any question? Again, kasi in hospital kayo, bago mag-CPR, non-rebreather mask. So this is a non-rebreather mask. At hindi siya pwede ikabit sa humidifier. Ikabit siya sa emergency oxygen, walang humidifier. At 15 liters per minute. Ganon ang rule. Useless pag 10. Para ma-achieve natin na umabot tayo ng 90% of oxygen sa arresting case is the non-rebreather mask. Huwag na huwag kayo mag-address ng arrest at nakukunan ng video, pagtawanan tayo ng buong mundo. Maraming nagkakamali ganyan. Colleagues ko pa. Kasi nga, medyo hindi pa. Buti ngayon, mayroon na tayong PSEM, Philippine College of Emergency Medicine, na tinuro na. Lalo na, pag peripheral hospital ka, hindi hinog yung emergency medicine program niyo, naku, diyan nagkakamali, mag-arrest, kanyula ang nilagay. Nakunan pa ng video, pinost, patay na tayo. Okay? Any question? Walang question. Okay. If you don't have any question, or maybe there might be a question that's gonna pop out a bit later, you can drop it by, because I'm not gonna put this off until ACLS, until the next day. So your questions will be in the chat. So I'm gonna read them out and answer if you can. You don't have a question right now. You will have exam with Miss Joy or her team for basic life support. And perhaps while taking exam, you'll be shown with a video, but the video is not the interim guidelines. Baka malito kayo. Ano ba tinuturo? Wala pang video ang interim guidelines. So, ASHI video siya, panoorin nyo lang. Yung tinuro ko, medyo may pagkasalungat lang kasi hindi pa updated ang ating video kasi wala pang na-release na bago. So, wala namang problem, no? Tulad sabi ko, ang mga nabago ngayon is 100 to 120. So, ang cadence is pip, 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 yan. 2, kailangan bago mag-compress, nakalagay mo na non-rebreather mask. Kung out of hospital kayo, bago kayo mag-compress, lagay mo na ng mask bago mag-CPR. So, yun, wala sa video yun. Tapos, kung sa ACLS, kailangan mag-intubate. Mabilis ka agad. Pagkatapos, second run, intubate ka agad. And then, yung list team na mag-surround sa BLS pag in-hospital setting. And the usage of bag valve mask in the field. Kasi in-hospital kayo. So sa field, like the ambulance, required ng bag valve mask, hindi mouth-to-mouth. There's no such thing as mouth-to-mouth today. Okay, so yun ang mga adjustments. These are not dramatic adjustments. Okay. Ang in-emphasize lang ng interim guidelines is you not to be contracted with COVID. Too late. Medyo nag-relax na tayo ngayon. But the COVID is still there, ha? Gusto ko lang i-remind ng everyone na kaya na lang ng katawan. Okay? So I'm gonna endorse you back if you have a question. For those who will only take BLS, compression is a life skill. It might not, don't think of saving the world. Think of learning it because you want to save your own. That's it. No, it's something better. It's there and you don't need it, rather than you might need it and you don't know what to do. No amount of crying, "I love you very much, mother," and your mother will be resurrected back to life. That's not gonna happen. If you want your mother to be revived, compression lang yan. Hindi iyak. Hindi "I love you very much." So, inalam natin para mas mabuhay natin ang ating mahal sa buhay. Forget about saving the world. Kung ako recruiter ako, and I ask you, why do you want to join? To save the world? Out ka kagad sa akin. If you are there to save your family, and you're good in saving your family, I will recruit you because pag magaling ka sa loob ng pamamahay niyo, magaling ka sa mundo. Ganyan lang ang equation. Okay. So, for those who will be taking ACLS, I'll be seeing you 1 o'clock in the afternoon. Any question sa lahat ng topics natin? Sorry kanina na, napatay ko yung sound. Baka may nagsasalita. Ma'am Joy,
Yes, Doc.
may doctors tayo dito. Meron, wala?
Wala po, Doc.
Okay, sige, at least I know. Anyway, I'll give you back to WePump for your exam. And wish you the best. Video will pop out for you to while taking the exam, then you can watch the video. And see you this 1 o'clock in the afternoon. Okay? Enjoy the exam, guys. God bless you in your BLS evaluation.
Thank you so much po, Doc. Hello po, good morning po. Isi-send ko po sa meeting group chat yung exam po for BLS. You can take your exam na po. Yan po. Nasa meeting chat na po yung link po ng BLS exam. We will be playing some videos din po. You can watch it po while taking your exam. Thank you po. Good luck po.
Basic Life Support, or BLS, is emergency medical care provided by first responders, healthcare providers, and public safety professionals to persons experiencing respiratory or cardiac arrest or an obstructed airway. It requires knowledge and proficiency in cardiopulmonary resuscitation, or CPR, use of automated external defibrillators, or AEDs, and techniques to relieve airway obstruction in patients of every age. This BLS training program is intended for healthcare providers and other public safety professionals working in a wide variety of occupational settings, in and out of hospital, and individuals enrolled in healthcare and public safety career courses. The purpose of this BLS training program is for participants to gain or improve knowledge and skill proficiency in high-quality CPR skills for the adult, child, and infant. This training program will allow you, the BLS provider, to learn and practice skills according to your experience and in the context of your setting, utilizing different practice methods such as video-guided and scenario practices. Cardiac arrest is the loss of the heart's ability to pump blood through the body due to inadequate or absent cardiac function. The most dramatic occurrence, sudden cardiac arrest, or SCA, can happen anywhere with little or no warning.
It was a beautiful, sunny, warm July 31st, and Lynn, my wife, and I had gone grocery shopping.
It was otherwise kind of a typical summer day.
We were unloading the groceries. Lynn and I schlepped some in, and then I went out to get the rest.
We can tell by retracing my steps that I had put some things in the pantry and was headed back out to the car, but I never made it because I went down.
Was only gone about 60 seconds. In that small amount of time, my world changed. Turned over on her back, and her face was turning blue, and I heard these sounds like she was trying to breathe, sound like she was gasping for air. And it's a sound you just don't want to hear your wife have. You just don't want to hear that sound.
How did you think?
Hello? Hi, I need an ambulance right away.
At what address?
I dialed 911 right away, and I put the phone down next to her and proceeded with the chest compressions and the breaths.
It's my wife. She's turning blue. She's turning blue. I gotta give her CPR.
Is she breathing?
No.
Okay, lay her flat on the ground with nothing under her head. Do you know how to do CPR?
Yes, a little bit. Okay, I'm pushing.
When the call came in and we heard the information, it was a cardiac arrest. If I knew that the crew was not here, they were out training at another station. Knowing it was a cardiac arrest and the importance of getting there quickly and starting care, myself and the battalion chief made the decision to respond to that.
Is your door unlocked?
Yes, I'm right.
Many minutes went by while I was administering CPR before I heard sirens outside.
I entered through the front door and I was able to see CPR being performed in the living room.
I found her laying on the floor.
Quickly encouraged the husband to continue doing CPR and push hard and push fast on the chest.
No, I found her. She was loading groceries from the car into the house. She was helping load them, and then I found her just like this. Please check the pulse. Keep going, push hard.
These last moments of my opportunity to give CPR, and that's how I regarded it, was a great opportunity to actually participate in the rescue. My neighbor, who's a physician's assistant, heard the sirens and she came over to see what was going on.
As I was putting the AED on, the patches, the neighbor identified herself as medically trained.
Yeah. You know CPR? Hey, go.
I asked her to go ahead and to relieve the husband from doing chest compressions at that point and had her start performing CPR.
So she hopped in there to take over because I was kind of freaking out. I mean, right now, even thinking about it is really bringing back the memories. It was terrifying. I felt helpless. I mean, it was now all in their hands. I had done all I could do.
After analyzing the rhythm of the patient, the AED identified that it was a shockable rhythm, and we delivered a one shot. At that point, I went ahead and took over CPR, compressions, and Annie started giving airway assist. And after giving CPR for about a minute, I noticed Lynn starting to make noises with my chest compressions.
I asked him, do you have a pulse? And he said, yes, we have a pulse. And I tell you, that was a beautiful sound to hear that.
So we stopped doing chest compressions and we continued breathing for her. That's when the crew, the paramedics, and the firefighters are coming through the front door. And I was able to then step back and give a report to the lead medic that was coming in and that was going to do the transport.
And they got my heart started again, loaded me onto the gurney, and rushed me to Corvallis Samaritan Regional Medical Center, where they continued to save my life. When I woke up, they had put posters on the wall in front of me. And it was very orienting. It said, Kent called 911, did CPR. He saved your life. You're at Corvallis Good Samaritan Regional Medical Center.
The CPR being performed by the husband was huge. I'm sure it was probably 2 to 3 minutes. And during that time, if CPR wasn't being performed, that's 2 or 3 minutes that she's not receiving blood. A lot of things went right for this call and for Lynn, the chain of survival.
So it was a team effort, a chain, and that includes our dear neighbor, Annie.
Learning CPR, knowing how to do it, and then actually doing it are really important because you can literally save somebody's life.
BLS providers play a key role in the resuscitation effort following cardiac arrest, both out of hospital and in hospital or clinic settings. By training and practicing, BLS providers can help ensure the links in the chain of survival are strong in any setting for every patient. In order to clearly demonstrate high-quality skills, BLS providers in this training program may not always be shown wearing appropriate personal protective equipment. Local medical protocols are emergency medical service treatment guidelines approved by the local EMS medical director. Local protocols outline the permissible medical treatments that may be given by EMS providers outside the hospital to patients experiencing a medical emergency. EMS providers should always follow their local physician-directed medical protocols.
Marcus, you need to come here, move to Eugene, go to University.
Think about dropping out.
Sudden cardiac arrest occurs when the normal electrical impulses in the heart cause it to beat too quickly, inefficiently, or in an unsynchronized manner. When the lower chambers of the heart beat too quickly or quiver, the heart cannot pump blood. These abnormal heart rhythms, or dysrhythmias, are known as pulseless ventricular tachycardia and ventricular fibrillation. Blood flow to the body, along with the oxygen it carries, abruptly stops. Within minutes, brain cell death starts to occur from the lack of oxygen. A victim of SCA may suddenly collapse.
Grandpa, hey, stay with me. Hey, I need some help. Grandpa, stay with me. Grandpa, don't.
What's going on? Is he okay?
I don't know, he just fell out. I need you to call
Occasionally,
911, please.
SCA victims will experience 10 to 20 seconds of seizure activity when the brain
Hey, I need
stops
some
receiving
help.
oxygen.
Hey, I need some help.
Normal breathing stops. Abnormal gasping may last for several
I have no
minutes.
clue what happened till he just fell down.
Okay. Let's get his back. Can you hear me? Sir, can you hear me? I have one person down in the main lobby. He's unresponsive. Start me 911 and get an AED. Let's start CPR. He's not breathing. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20.
CPR is the immediate treatment for suspected SCA. CPR can restore limited oxygen to the brain and other vital organs through a combination of chest compressions, an open airway, and rescue breaths. However, CPR alone is not enough. The most effective way to end pulseless ventricular tachycardia and ventricular fibrillation is defibrillation.
Remove clothes from patient's chest.
Using a defibrillator and electropads adhered to the chest. An electrical shock passed through the chest can restore the heart's normal contractions.
Analyzing heart rhythm. Stay clear of patient.
Immediate, high-quality CPR and early defibrillation with an AED can more than double the likelihood for survival. These two elements are parts of the adult chain of survival, a series of 6 interdependent links that describe the best approach to cardiac arrest care. Each link in the chain is essential for the most positive outcome. If a single link is missing, the chances for survival are greatly reduced. There are 2 adult chains of survival. The links in the chain differ slightly depending on the cardiac arrest setting. The chain of survival for pre-hospital or out-of-hospital cardiac arrest consists of early recognition of cardiac arrest and prompt activation of EMS, immediate high-quality CPR beginning with chest compressions, early defibrillation with an AED when indicated, effective advanced life support treatment, effective post-cardiac arrest care at a hospital, and recovery. The adult out-of-hospital chain of survival includes continued resuscitation by EMS and transportation to the hospital for all patients with a chance of survival. Cardiac arrest inside a hospital or facility usually occurs when a known medical condition worsens, so the in-hospital chain of survival focuses on how resuscitation fits into ongoing medical care. The chain of survival for in-facility cardiac arrest includes monitoring, prevention, and treatment of pre-arrest conditions, and early recognition of cardiac arrest, prompt activation of the emergency action plan and response by teams of medical professionals, immediate high-quality CPR beginning with chest compressions, prompt defibrillation when indicated, effective post-cardiac arrest care, and recovery. The greatest chance of survival exists when all the links of the chain of survival are strong. The majority of cardiac arrests happen at home or in the workplace. Early recognition of SCA and activation of EMS or an emergency action plan gets help coming right away. Immediate high-quality CPR improves the victim's chance of survival by providing oxygen to the heart and brain. After activating EMS, an untrained layperson should provide chest compression-only CPR, ideally with their phone on speaker mode and with the assistance of an EMS dispatcher. Attaching an AED as soon as it becomes available speeds up the time to defibrillation if indicated. Effective advanced life support treatment with a focus on return of spontaneous circulation, or ROSC, and transport to a hospital for all patients with a chance of survival supports the most favorable outcome. Effective post-cardiac care, including monitoring and the use of medication, helps prevent the return of cardiac arrest and improves the likelihood of long-term survival. Recovery supports the patient's physical and emotional needs that are ongoing after hospital discharge. High-quality CPR is the primary influence on survival from cardiac arrest. High-quality chest compressions are the foundation of high-quality CPR. External compression of the chest increases pressure inside the chest and directly compresses the heart, forcing blood to move from the chest to the lungs, heart, brain, and the rest of the body. When chest compressions stop, blood flow decreases significantly. When compressions start again, it takes several compressions to restore blood flow. The more times chest compressions are interrupted and the longer the interruption, the less the blood flow to the brain, heart, and other organs. Minimal interruption improves blood flow. If the pulse is not felt and the unresponsive patient is not breathing normally or only gasping, immediately start CPR, beginning with chest compressions. CPR should be performed where a victim is found as long as it is safe to do so. To deliver adult chest compressions, position the patient face up on a firm, flat surface. If the patient is face down, carefully roll them over. Position yourself at the patient's side, kneeling close to one side of the chest. Place the heel of one hand on the center of the chest, on the lower half of the breastbone. Place the heel of the other hand on top of and parallel to the first. Interlock your fingers if necessary to keep them off the chest. Alternatively, you can place one hand on the center of the chest and use your other hand to grasp your wrist for support. Position your shoulders directly above your hands and straighten your arms to lock your elbows. Push hard and deep, straight down, using your upper body weight to compress the chest at least 2 inches or 5 centimeters. Chest compressions are most often performed too shallowly. At the end of each compression, lift all your weight off the patient's chest, allowing it to completely recoil or rebound to its normal position, but do not lose contact with the chest. Avoid leaning on the chest between compressions. Complete chest recoil allows the heart to refill. Push fast. Compress the chest at a rate of 100 to 120 compressions per minute. CPR feedback devices transmit information on compression rate, depth, and recoil. Providers can significantly improve chest compression quality by adjusting technique based on data from a feedback device. Using a CPR feedback device is shown to improve patient outcomes and is recommended during CPR training and in real-life resuscitation attempts, both in and out of hospital. Fewer and shorter interruptions in chest compressions are associated with better outcomes. Time spent during a resuscitation attempt without chest compression, called hands-off time, should be kept as short as possible. Chest compression fraction, or CCF, is the proportion of time that chest compressions are performed during a cardiac arrest resuscitation effort. Higher CCF percentages are associated with high-quality CPR and greater rates of survival. A CCF of at least 60% is recommended, but higher percentages are desirable and achievable.
Rescue breathing is an artificial ventilation of the lungs. It provides oxygenation of the blood and removal of carbon dioxide. It is an important component for successful resuscitation. Conventional CPR with rescue breathing should be performed by all BLS providers, both in and outside the hospital. To give rescue breaths, there must be an open airway. The airway is the only path for getting air into the lungs. When an unresponsive patient is lying flat on their back, decreased muscle tone and the pull of gravity causes the back of the tongue to obstruct the upper airway. The tongue is connected to the lower jaw. Lifting the jaw forward pulls the tongue away from the back of the throat, relieving the obstruction and opening the airway. Two methods to open the airway are the head tilt chin lift and the jaw thrust. Use the head tilt chin lift maneuver to open the airway of a patient when head or neck injury is not suspected. To open the airway with the head tilt chin lift maneuver, position yourself at the patient's side. Place one hand on their forehead. Place the fingertips of your other hand under the bony part of the lower jaw, near the chin. Apply firm backward pressure on the forehead while lifting the chin upward. Avoid pressing into the soft tissue of the chin with your fingers, as this can also obstruct the airway. Leave the mouth slightly open. If the BLS provider suspects a spinal injury, open the airway using a jaw thrust without head tilt. To open the airway with a jaw thrust, position yourself at the patient's head. Place one hand on each side of the patient's head. Place your fingertips under the angle of the lower jaw and lift it upwards until the lower teeth are higher than the upper teeth. If the patient's lips close, use your thumbs to push the lower lip open. An open airway is a higher priority than protecting a possible spinal injury. If the jaw thrust does not open the airway, use the head tilt chin lift maneuver. Both the head tilt chin lift and jaw thrust maneuvers should be performed correctly and quickly to minimize interruptions in chest compressions.
Rescue breaths are critically important in BLS care, as they provide life-sustaining oxygen and ventilation directly to the patient's lungs. In addition to SCA patients, BLS providers are likely to provide care for victims of respiratory arrest and secondary cardiac arrest, for whom effective rescue breaths are essential. Rescue breaths are given by blowing the BLS provider's exhaled air into the valve of a CPR mask, or by pushing air into the lungs through the airway using a bag mask device. Gasping in SCA is common but is not normal breathing. If the pulse is not felt and the unresponsive patient is not breathing or is gasping, immediately start CPR, beginning with high-quality chest compressions. After 30 compressions, open the airway and give 2 rescue breaths. Perform cycles of 30 chest compressions and 2 rescue breaths. In respiratory arrest, breathing has stopped, but the heart continues to beat. This is a life-threatening medical emergency caused by diseases such as pneumonia or other conditions such as stroke, choking, drowning, and drug or alcohol overdose. If rescue breathing is not provided during respiratory arrest, the patient's heart will stop within minutes. This is secondary cardiac arrest. If the pulse is definitely felt, but the unresponsive patient is not breathing normally, provide rescue breathing. Open the airway and give 1 breath every 6 seconds, or 10 breaths per minute. If you suspect an opioid overdose, give naloxone according to local medical protocol. Check the pulse about every 2 minutes. If the pulse is not felt and the unresponsive patient is still not breathing, immediately start CPR. Excessive ventilation, too many breaths or breaths that are too large, can be harmful. They can cause the stomach to fill with air and increase pressure in the chest, making it difficult for blood to enter and exit the heart. Air in the stomach can also cause regurgitation of food, liquids, or vomit into the airway. BLS providers should avoid excessive ventilation during rescue breathing. Give enough air to make the patient's chest rise, but no more than that. Take standard precautions when providing adult rescue breaths. Use a CPR mask or bag mask device in addition to other appropriate PPE. Some CPR masks and bag mask devices allow you to attach a high-efficiency particulate air, or HEPA, filter to provide further protection during CPR. The HEPA filter fits between the valve and mask, in the path of the patient's exhaled gas. HEPA filters can trap airborne virus particles. BLS providers can give rescue breathing using their own exhaled breath and a CPR mask. Room air contains about 21% oxygen. Exhaled air contains between 16 and 17% oxygen. This exhaled oxygen is enough to support life. To use a CPR mask, position yourself at the patient's side. Place the mask flat on the person's face with the top of the mask over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your other hand, lifting the chin, to control the bottom of the mask. Hook your fingertips of the hand controlling the bottom of the mask under the bony ridge of the jaw. Open the airway with a head tilt chin lift maneuver. Lift the patient's face up into the mask to create an airtight seal. Give a rescue breath by blowing through the valve opening. Each breath is 1 second in length. Give enough air to create a visible rise of the chest, but no more. Stop ventilating as soon as you see the chest rise. Remove your mouth and let the patient exhale. A bag mask is a handheld device used to inflate the lungs. The device consists of a bag attached to a face mask. BLS providers can give rescue breathing using a bag mask and room air. It can also deliver high concentrations of oxygen when connected to an oxygen delivery system. To use a bag mask device as a single provider, position yourself above the patient's head. Place the mask flat on the patient's face, covering the nose and mouth, with the top of the mask over the bridge of the nose. Use your thumb and index finger on one hand in a C position to press the edges of the mask to the face. Use the remaining fingers in an E position under the bony ridge of the jaw. Tilt the head and lift the jaw up into the mask to open the airway. Give a rescue breath by squeezing the bag. Deliver each breath over 1 second in length while watching for chest rise. Stop ventilating as soon as you see chest rise.
An automated external defibrillator, or AED, is a portable computerized device that is simple to operate. It can identify pulseless ventricular tachycardia and ventricular fibrillation and deliver an electric shock to restore the heart's normal contractions. If the electric shock is effective, there will be a return to spontaneous circulation, or ROSC. The heart will be able to pump blood, and the patient will have a pulse that can be felt by the BLS provider. The patient may also start breathing, moving, or reacting in other ways. If you have an AED in your workplace, be familiar with its operation. AED design varies by model and manufacturer, but they all operate in a similar manner. Proper AED operation requires direct contact between the pads and the patient's skin. Any clothing in the way must be removed. This includes swimsuits, bras, and any other clothing covering a patient's chest. If necessary, cut through clothing with the shears that are typically included with a CPR and AED response kit. Opening the lid will turn on the power for some AEDs. With others, simply press the power button. This starts voice prompts and readies the device for use.
Plug-in pads connector.
Use adult AED pads for patients 8 years or older. Locate and pull out the defibrillation pads. The pads have pictures on them to show proper placement. Peel the pads from the backing sheet one at a time and place each according to the pictures. Press the pads firmly in place. Avoid placing pads over medication patches or implanted devices. Try to apply the pads within 30 seconds after the AED arrives. When the AED voice prompts you,
do not touch patient.
Clear the patient. Be certain that no one is touching the patient. The AED may take a few seconds to analyze the heart rhythm.
Analyzing heart rhythm.
If the AED advises a shock, it will prompt you to clear the patient again.
Clear. Press flashing button.
If directed by the AED, deliver a shock.
Shock delivered.
Once a shock has been delivered, immediately resume CPR, starting with chest compressions. After about 2 minutes of CPR, the AED will prompt you again to analyze the heart rhythm. Follow the voice prompts.
Do not touch patient.
Continue the resuscitation attempt until another BLS provider or advanced life support providers arrive and take over, or until the patient starts breathing, moving, or reacting in other ways. If the patient begins responding, regularly reassess the patient's responsiveness, airway, breathing, and pulse. If a pulse is felt but the patient is not breathing normally, provide rescue breathing or bag mask ventilation.
I don't know. I walked in the kitchen and my best friend's on the ground.
Every adult resuscitation attempt is different in terms of setting, circumstance, and available resources.
You have to help her. She's right here.
While working as a coordinated team is common, BLS providers
her.
also need to be able to provide high-quality CPR as a single
are you okay?
provider.
Are you okay? Code 3, send medic.
If the pulse is not felt and the unresponsive patient is not breathing normally or only gasping, one BLS provider can provide high-quality adult CPR by putting together all the skills of assessment, compressions, airway, breathing, and AED use.
Do not touch patient. Analyzing heart rhythm. Everyone clear. Press
Stand clear, stand clear. All right, shocking.
Shock delivered. Provide chest compression.
First, assess scene safety and take standard precautions. If the scene is safe, assess the patient's responsiveness. If the patient is unresponsive, activate EMS or your occupational emergency action plan. Get an AED and emergency response equipment or send someone else to. Assess the patient's breathing and carotid pulse at the same time for no more than 10 seconds. If the patient is not breathing normally or only gasping, and you do not feel a pulse, start high-quality CPR. Position the patient on a firm, flat surface. Position 2 hands on the lower half of the breastbone. Compress at least 2 inches or 5 centimeters. Use upper body weight to compress. Compress at a rate of 100 to 120 times per minute. Allow the chest to fully recoil at the top of each compression. Use a CPR mask or bag mask device. Open the airway and give 2 rescue breaths. Ensure each breath is 1 second in length and creates visible rise of the chest. Immediately resume high-quality chest compressions. Repeat CPR cycles of 30 compressions and 2 breaths for 2 minutes. As soon as an AED is available, power on the AED.
Remove all clothing
Bare
from
the
patient's
chest. Correctly apply the AED pads.
Pull red handle to reveal pads. Do not
Make sure no one is touching the patient. If directed by the AED, deliver a shock. Immediately resume CPR starting with chest compressions. Continue the resuscitation attempt until another BLS provider or advanced life support providers arrive and take over, or until the patient starts breathing, moving, or reacting in other ways.
James?
Oh, you know, kids.
James?
Busy doing it.
Are you out here? James? James? James! James! Oh no! No! Somebody help! Somebody help me! James! 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 James, honey! James! James!
What happened?
I don't think he's breathing.
I'll come in.
Call him. All right, help me get him to the ground. All right, come on. Gently, gently. All right, gently. Okay, come on.
Hello. Yes.
All right, watch out.
We had a kid drown in the hot tub.
James! James, can you hear me?
Sudden cardiac arrest in children is not typical, but it can and does occur in children of all ages. More often, though, cardiac arrest in a child results from asphyxia, a lack of oxygen caused by respiratory failure or respiratory arrest. When breathing slows or stops, it leads to bradycardia, a slow heart rhythm of fewer than 60 beats per minute. At that rate, the heart is not able to pump enough oxygen-rich blood to the body. The lack of oxygen causes the heart to stop within minutes. Causes of respiratory failure or respiratory arrest and subsequent cardiac arrest include airway obstruction, lung infections or diseases, drowning, choking, and shock resulting from injuries, such as motor vehicle accidents, burns, falls, and child abuse. Prevention is critical in reducing pediatric cardiac arrest deaths. In the out-of-hospital setting, prevention includes the use of essential safety equipment, such as child passenger safety seats and bicycle helmets, and proper supervision. In the hospital, cardiac arrest prevention focuses on early recognition and treatment of at-risk children. In this BLS class, a child is defined as 1 year of age until the onset of puberty. Puberty can be identified by breast development in females and the presence of armpit hair in males. For those with signs of puberty, provide adult BLS. Like the adult chain of survival, the pediatric chain of survival consists of a series of 6 interdependent links that describe the best approach to cardiac arrest care. Each link in the chain is essential for the most positive outcome. If a single link is missing, the chances for survival are greatly reduced. There are 2 pediatric chains of survival. The links in the chain differ slightly depending on the cardiac arrest setting. The chain of survival for pre-hospital or out-of-hospital cardiac arrest consists of prevention of causes of cardiac arrest, respiratory failure or respiratory arrest, prompt activation of EMS, immediate high-quality CPR and defibrillation, advanced resuscitation, effective post-cardiac arrest care at a hospital, and recovery. The pediatric out-of-hospital chain of survival includes continued resuscitation by EMS and transportation to the hospital for all patients with a chance of survival. Cardiac arrest inside a hospital or facility usually occurs when a known medical condition worsens, so the in-hospital chain of survival focuses on how resuscitation fits into ongoing medical care. The chain of survival for in-facility cardiac arrest includes monitoring, prevention, and treatment of pre-arrest conditions, and early recognition of cardiac arrest. Prompt activation of the emergency action plan and response by teams of medical professionals, immediate high-quality CPR and defibrillation, advanced resuscitation, effective post-cardiac arrest care, and recovery. The greatest chance of survival exists when all the links of the chain of survival are strong. BLS providers should follow the procedure for pediatric BLS, a step-by-step guide for responding to a potential cardiac arrest. Using this procedure, you can perform child BLS as a single provider and as a member of a team. Like the adult procedure, there are 3 main elements of the pediatric BLS procedure: assessments of the scene and patient, actions based on presence or absence of normal breathing and a pulse, and use of an AED. First, assess scene safety. Upon arrival and before anything else, pause to make sure the scene is safe for you and the victim. This includes taking standard precautions. If the scene is not safe, do not enter it until hazards have been minimized or eliminated. If the scene is safe, assess responsiveness. Tap the victim and ask loudly,
"Are you okay?"
If the patient is unresponsive, call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. Simultaneously assess breathing and pulse. Look at the patient's chest and face for signs of normal breathing. Weak, irregular gasping, snorting, snoring, or gurgling is not normal breathing. It is a sign of cardiac arrest. At the same time as assessing breathing, check the child's carotid or femoral pulse. To locate the carotid pulse, use the same technique as you would on an adult. To locate the femoral pulse, place 2 or 3 fingers midway between the hip bone and the pubic bone, just below the crease where the leg joins the torso. Take no longer than 10 seconds to simultaneously assess breathing and pulse. Then take action based on the presence or absence of normal breathing and pulse. If the pulse is definitely felt and the unresponsive patient is breathing normally, maintain an open airway. Regularly reassess responsiveness, airway, breathing, and pulse. Monitor and care for the unresponsive patient according to local medical protocol. If the pulse is definitely felt and the unresponsive patient is not breathing normally, provide rescue breathing or bag mask ventilation. Give 1 breath every 2 to 3 seconds, about 20 to 30 breaths per minute. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. Perfusion is the circulation of oxygenated blood through tissues. The signs of poor perfusion include pale, mottled, or blue lips or skin, decreasing responsiveness, weak pulse, cool extremities, particularly the hands and feet. Poor perfusion is an indication that cardiac arrest is imminent. If the pulse is felt, but there is not normal breathing and the heart rate is less than 60 beats per minute with signs of poor perfusion, start high-quality CPR. Beginning CPR prior to full cardiac arrest can improve likelihood of survival. If the pulse is not felt and the unresponsive pediatric patient is not breathing normally or only gasping, take action based on whether or not the arrest was witnessed. A witnessed cardiac arrest is one that is seen or heard, or an arrest that occurs when the patient is connected to a heart monitor. If the sudden collapse of a child was witnessed, you may assume that the child has suffered a sudden cardiac arrest. If you are alone and an AED is nearby, get the AED right away. Activate EMS or your facility's occupational emergency action plan if you haven't done so already. Quickly return to the patient, use the AED, and perform CPR. If the arrest was not witnessed and you are alone, immediately start CPR, beginning with chest compressions. As cardiac arrest in children is most frequently caused by asphyxia, about 2 minutes of CPR is recommended before leaving the child to get an AED and activate EMS. Immediate CPR with an emphasis on effective rescue breaths may provide the only chance for survival.
As in the adult procedure, high-quality chest compressions are the foundation of high-quality CPR. To deliver child chest compressions, position the patient face up on a firm, flat surface. If the patient is face down, carefully roll them over. Position yourself at the patient's side, kneeling close to one side of the chest. For child compressions, place 1 or 2 hands on the center of the chest. For a small child, 1 hand may be enough. For most children, the compression technique is the same as for the adult. Position your shoulders directly above your hands and straighten your arms to lock your elbows. Whether you use 1 or 2 hands, push hard, straight down, using your upper body weight to compress the chest at least 2 inches or 5 centimeters. At the end of each compression, lift all your weight off the patient's chest, allowing it to completely recoil or rebound to its normal position without losing contact with the chest. Avoid leaning on the chest between compressions. Complete chest recoil allows the heart to refill. Compress the chest at a rate of 100 to 120 compressions per minute. Minimize interruption in chest compressions.
As with an adult, there must be an open airway to give rescue breaths to a child. The two methods to open the airway are the same: head tilt, chin lift, and jaw thrust. Use the head tilt, chin lift maneuver to open the airway of a child when head or neck injury is not suspected. Rescue breaths are extremely important for children because cardiac arrest typically results from asphyxia. If the pulse is definitely felt, but an unresponsive patient is not breathing normally, provide rescue breathing. Open the airway and give one breath every 2 to 3 seconds, or 20 to 30 breaths per minute. If you suspect an opioid overdose, give naloxone according to local medical protocol. In the case of drowning, begin with rescue breaths. As soon as the unresponsive victim is removed from the water, open the airway and assess breathing. If there is no breathing, give 2 rescue breaths that make the chest rise. Excessive ventilation, too many breaths, or breaths that are too large can be harmful. They can cause the stomach to fill with air and increase pressure in the chest, making it difficult for blood to enter and exit the heart. Take standard precautions when providing child rescue breaths. Use a pediatric CPR mask or bag mask device in addition to other appropriate PPE. Use a child-sized mask as you would for an adult. Position yourself at the patient's side. Place the mask flat on the child's face, with the top of the mask over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your hand lifting the chin to control the bottom of the mask. Hook your fingertips of the hand controlling the bottom of the mask under the bony ridge of the jaw. Tilt the head and lift the chin to open the airway. Lift the child's face up into the mask to create an airtight seal. Give a rescue breath by blowing through the valve opening. Each breath is 1 second in length. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. Remove your mouth and let the patient exhale. Pediatric bag mask devices are available in child and infant sizes. Select a child-sized bag mask. To use a pediatric bag mask device as a single provider, position yourself above the patient's head. Place the mask flat on the patient's face, covering the nose and mouth, with the top of the mask over the bridge of the nose. Use your thumb and index finger on one hand in a C position to press the edges of the mask to the face. Use your remaining fingers in an E position under the bony ridge of the jaw. Tilt the head and lift the jaw up into the mask to open the airway. Give a rescue breath by squeezing the bag. Deliver each breath over 1 second in length while watching for chest rise. Stop ventilating as soon as you see chest rise. Check the pulse every 2 minutes. If the pulse is felt, but the heart rate is less than 60 beats per minute with signs of poor perfusion, start high-quality CPR.
Most AEDs are designed for both adult and pediatric use. The energy level of the shock for pediatric use is reduced from the standard adult energy setting. The shock is reduced by an electronic device called an attenuator, which frequently comes with pre-connected pediatric pads. The attenuator may also be built into the AED and activated using a button, key, or another type of switching mechanism. Pediatric pads are recommended for children below 8 years of age. If the child pads are not available, use the adult pads. The standard adult shock will be higher, but a higher energy shock is better than no shock at all. Do not apply child pads to patients 8 years of age and older because the energy level of the shock will be too low. Turn on the AED and bare the patient's chest.
Remove all clothing from patient's chest.
If there is a button, key, or another type of mechanism for switching to child use, activate it.
Child mode.
Peel the pads from the backing sheet one at a time and place each according to the pictures. Some pads require a front and back position. Others require a left-right position. Press the pads firmly in place. Do not allow them to touch each other. When the AED voice prompts you,
Do not touch patient.
clear the patient. The AED may take a few seconds to analyze the heart rhythm.
Analyzing heart rhythm.
If directed by the AED,
Everyone clear.
be certain that no one is touching the patient.
Press flashing button.
Deliver a shock. Once a shock has been delivered, immediately resume CPR, starting with chest compressions. After about 2 minutes of CPR,
Do not touch patient.
the AED will prompt you again to analyze the heart rhythm.
Analyzing heart rhythm.
Follow the voice prompts.
Press flashing button. Shock delivered.
Continue the resuscitation attempt until another BLS provider or advanced life support providers arrive and take over, or until the patient starts breathing, moving, or reacting in other ways. If the patient begins responding, regularly reassess the patient's responsiveness, airway, breathing, and pulse. If a pulse is felt but the patient is not breathing normally, provide rescue breathing or bag mask ventilation.
In BLS, an infant is defined as younger than 1 year of age, excluding newly born infants. Like the child BLS procedure, there are 3 main elements of the infant BLS procedure: assessment of the scene and patient, actions based on the presence or absence of normal breathing and pulse, and use of an AED. First, assess scene safety. This includes taking standard precautions. If the scene is safe, assess responsiveness. Gently tap the victim and ask loudly,
Are you okay?
if the infant is unresponsive, call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. If you don't have a mobile phone nearby, bring the infant with you to activate. Simultaneously assess breathing and pulse. Check the infant's brachial pulse. Place 2 or 3 fingers on the inside of the upper arm, midway between the elbow and shoulder. Take no longer than 10 seconds to simultaneously assess breathing and pulse. Then take action based on presence or absence of normal breathing and pulse. If the pulse is definitely felt and the unresponsive patient is breathing normally, maintain an open airway. Regularly assess responsiveness, airway, breathing, and pulse. Monitor and care for the unresponsive patient according to local medical protocol. If the pulse is definitely felt and the unresponsive patient is not breathing normally, provide rescue breathing or bag mask ventilation. Give 1 breath every 2 to 3 seconds, about 20 to 30 breaths per minute. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. If the pulse is felt, but there is not normal breathing and the heart rate is less than 60 beats per minute with signs of poor perfusion, start high-quality CPR. If the pulse is not felt and the unresponsive patient is not breathing normally or only gasping, take action based on whether or not the arrest was witnessed. If the sudden collapse of an infant was witnessed, you may assume that the infant has suffered a sudden cardiac arrest. If you are alone and an AED is nearby, get the AED right away. Quickly return to the patient, use an AED, and perform CPR. If the arrest was not witnessed and you are alone, immediately start CPR, beginning with chest compressions. As cardiac arrest in infants is most frequently caused by asphyxia, 2 minutes of CPR is recommended before activating EMS or your facility's emergency action plan if you haven't done so already. As with the adult and child, there must be an open airway to give rescue breaths to an infant. The two methods to open the airway are the same: head tilt chin lift and jaw thrust. Use the head tilt chin lift maneuver to open the airway of an infant when head or neck injury is not suspected. Keep an infant's head in a neutral sniffing position. Tilting the head beyond a neutral position that results in hyperflexion or hyperextension may block the airway. Rescue breaths are extremely important for infants because infant cardiac arrest typically results from asphyxia. In the case of drowning, begin with rescue breaths. As soon as the unresponsive victim is removed from the water, open the airway and assess breathing. If there is no breathing, give 2 rescue breaths that make the chest rise. Air in the stomach can cause regurgitation of food, liquids, or vomit into the airway. BLS providers should avoid excessive ventilation during rescue breathing. Give enough air to make the infant's chest rise, but no more than that. Stop ventilating as soon as you see chest rise. Take standard precautions when providing infant rescue breaths. Use an infant CPR mask or bag mask device in addition to other appropriate PPE. Use an infant-sized pocket mask in the same manner as you would for an adult or child. Position yourself at the patient's side. Place the mask flat on the infant's face with the top of the mask over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your hand lifting the chin to control the bottom of the mask. Hook your fingertips of the hand controlling the bottom of the mask under the bony ridge of the jaw. Open the airway with a head tilt chin lift maneuver. Tilt the head and lift the chin to open the airway. Maintain a neutral sniffing position. Lift the infant's face up into the mask to create an airtight seal. Give a rescue breath by blowing through the valve opening. Each breath is 1 second in length. Give enough air to create a visible rise of chest, but no more. Stop ventilating as soon as you see chest rise. Remove your mouth and let the patient exhale. To use an infant bag mask device as a single provider, select an infant-sized bag mask device. Position yourself above the patient's head. Place the mask flat on the patient's face, covering the nose and mouth, with the top of the mask over the bridge of the nose. Use your thumb and index finger of one hand in a C position to press the edges of the mask to the face. Use your remaining fingers in an E position under the bony ridge of the jaw. Tilt the head and lift the jaw up into the mask to open the airway. Maintain a neutral sniffing position. Give a rescue breath by squeezing the bag. Deliver each breath over 1 second in length while watching for chest rise. Check the pulse about every 2 minutes. If the pulse is felt, but the heart rate is less than 60 beats per minute with signs of poor perfusion, or there is no pulse, start high-quality CPR. There may be a rare or extraordinary circumstance when a barrier device is not available, and a BLS provider is willing to provide artificial ventilation without a barrier. For infants, the preferred technique is mouth-to-mouth and nose rescue breathing. To give mouth-to-mouth and nose rescue breathing to an infant, open the airway with a head tilt chin lift. Take a regular-sized breath and place your mouth over the infant's mouth and nose, creating an airtight seal. Give 1 breath over 1 second. Give enough air to make the chest visibly rise, but no more than that. If the chest does not rise, repeat the head tilt chin lift, make a better seal, and try again. It may be necessary to move the infant's head through a range of positions to provide effective rescue breathing. If you have difficulty making an effective seal over the mouth and nose, try using the mouth-to-mouth technique.
As in the adult and child procedure, high-quality chest compressions are the foundation of high-quality infant CPR. To deliver infant chest compressions, position the patient face up on a firm, flat surface. If the patient is face down, carefully roll them over. For infant compressions, Use one of 3 hand position techniques: the 2-finger, 2-thumb encircling hands, or the heel of one hand. For the 2-finger technique, place 2 fingertips in the center of the infant's chest, just below the nipple line on the lower half of the breastbone. Do not press the tip of the breastbone. Use both fingers to compress the chest. For the 2-thumb encircling technique, place the pads of both thumbs side by side in the center of the infant's chest, on the lower half of the breastbone. Your thumbs may overlap on very small infants. With the fingers of both hands, encircle the infant's chest and support the back. Use both thumbs to compress the chest. For the heel of one hand technique, place the heel of one hand on the center of the chest, on the lower half of the breastbone. Position your shoulder directly above your hand and straighten your arm to lock your elbow. Use the heel of one hand to compress the chest. This technique may be useful for larger infants, or when the BLS provider has difficulty compressing to the appropriate depth using fingers or thumbs. Whichever technique you use, push hard, straight down, compress the chest approximately 1 1/2 inches or 4 centimeters. This depth should be at least 1/3 of the diameter of the infant's chest. At the end of each compression, allow complete chest recoil. Compress the chest at a rate of 100 to 120 compressions per minute. Minimize interruptions. Pediatric pads are recommended when choosing AED pads for an infant. If pediatric pads are not available, choose the adult pads. The standard adult shock will be higher, but a higher energy shock is better than no shock at all. Turn on the AED and bare the patient's chest. If there is a button, key, or another type of mechanism for switching to pediatric use, activate it. Peel the pads from the backing sheet one at a time and place each according to the pictures. The front and back pad position is common for infants. Press the pads firmly in place. Make sure the pads do not overlap or touch each other.
Not touch patient. Analyzing
When the
heart
AED
rhythm.
voice prompts you, make sure no one is touching the patient.
Everyone clear.
If
Press
directed by the
flashing
AED,
button.
deliver a shock.
Delivered.
Once a shock has been delivered, immediately resume CPR, starting with chest compressions. Assess the scene for safety, regardless of whether you are first on the scene, and take standard precautions. If the scene is safe and you are the first BLS provider to reach the patient's side, assess responsiveness. As second BLS provider, activate EMS or the Emergency Action Plan and get the AED and emergency response equipment if available. Assess the patient's breathing and brachial pulse at the same time for no more than 10 seconds. If the pulse is definitely felt and the unresponsive patient is breathing normally, maintain the airway. Activate EMS or your facility's emergency action plan if you haven't done so already. To help protect the airway, place an uninjured infant in the recovery position. Lie the infant face down on your forearm. Support the infant's head with your hand. Monitor and care for the unresponsive patient according to local medical protocol. If the pulse is definitely felt, but the unresponsive patient is not breathing normally, activate EMS or your facility's emergency action plan if you haven't done so already. With 2 or more BLS providers and appropriate equipment on hand, each provider takes a role to deliver effective ventilation using an infant-sized pediatric bag mask device. Position one BLS provider above the patient's head, in charge of opening the airway and securing the mask with 2 hands. Position a second BLS provider on the patient's side to squeeze the bag. As BLS provider 2, deliver a rescue breath by squeezing the bag. Give 1 breath every 2 to 3 seconds, or 20 to 30 breaths per minute. Deliver each breath over 1 second in length while watching for chest rise. Give enough air to make the infant's chest rise, but no more than that. Stop ventilating as soon as you see the chest rise. Regularly assess the patient's responsiveness, airway, breathing, and pulse about every 2 minutes. If the pulse is felt, but there is not normal breathing and the heart rate is less than 60 beats per minute with signs of poor perfusion, start high-quality CPR. If the pulse is not felt and the unresponsive patient is not breathing normally or only gasping, the first BLS provider should immediately start high-quality CPR, beginning with chest compressions. The second provider should activate EMS or the facility's emergency action plan if you haven't done so already. When 2 or more BLS providers attempt to resuscitate an infant, use a compression to ventilation ratio of 15 compressions to 2 rescue breaths. Compress fast at a rate of 100 to 120 times per minute. Compress the chest approximately 1 1/2 inches or 4 centimeters. Allow the chest to fully recoil at the top of each compression. After 15 compressions have been given, the second BLS provider should open the airway and give 2 effective rescue breaths using a pediatric bag mask. Keep the infant's head in a neutral sniffing position. Repeat cycles of 15 compressions and 2 effective rescue breaths. Switch the person in the compressor's position frequently, about every 2 minutes. Try to minimize interruptions to compressions to less than 10 seconds. As soon as an AED is available, power on the AED. Bare the chest. If there is a button, key, or another type of mechanism for switching to pediatric use, activate it. Correctly apply the AED pads according to the pictures. When the AED voice prompts you, clear the patient. Make sure no one is touching the patient.
Analyzing heart rhythm.
If the AED advises a shock, clear the patient and deliver the shock. Once a shock has been delivered, immediately resume CPR, starting with chest compressions. If the AED does not advise a shock, immediately resume with chest compressions. Follow the AED's voice prompts. Continue the resuscitation attempt until advanced life support providers take over or until the patient starts breathing, moving, or reacting in other ways.
While working as a coordinated team is common, BLS providers also need to be able to provide high-quality infant CPR as a single provider. First, assess scene safety, taking standard precautions. If the scene is safe, assess the patient's responsiveness. If the patient is unresponsive, call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. Assess the patient's breathing and brachial pulse at the same time for no more than 10 seconds. For witnessed sudden collapse, if you are alone and an AED is nearby, get the AED. Activate EMS or your facility's emergency action plan if you haven't done so already. Quickly return to the patient, use the AED, and perform CPR. For unwitnessed arrest, if you are alone, immediately start CPR, beginning with chest compressions. Perform 2 minutes of CPR before leaving to activate EMS or your facility's emergency action plan, and get an AED. Position the patient on a firm, flat surface. Perform 30 high-quality chest compressions. Use one of 3 techniques to compress the chest: the 2-finger, 2-thumb encircling hands, or the heel of one hand. Compress the chest approximately 1 1/2 inches, or 4 centimeters. Compress at a rate of 100 to 120 times per minute. Allow the chest to fully recoil at the top of each compression. Use an infant-sized CPR mask or bag mask device. Open the airway and give 2 rescue breaths. Ensure each breath is 1 second in length and creates visible rise of the chest. Immediately resume high-quality chest compressions. Repeat CPR cycles of 30 compressions and 2 breaths for 2 minutes. As soon as an AED is available, power on the AED, bare the chest. If there's a button, key, or another type of mechanism for switching to pediatric use, activate it. Correctly apply the pediatric pads according to the pictures. If the pediatric pads are not available, use the adult pads. Follow the AED's voice prompts.
Everyone clear. Press flashing button. Shock delivered.
Continue the resuscitation attempt until another BLS provider or advanced life support providers arrive and take over, or until the patient starts breathing, moving, or reacting in other ways. Breathing, moving, or reacting in other ways. Choking, also known as foreign body airway obstruction, can occur when a solid object, such as a piece of food or a small object, becomes stuck in the upper airway. The person cannot breathe. A forceful thrust beneath the ribs and up into the diaphragm can pressurize the air in the chest and pop out the obstruction. Chest compressions can also create enough pressure to expel a foreign body airway obstruction.
I'm exhausted.
To provide the appropriate care, you must be able to recognize the difference between a mild and a severe airway obstruction. With a mild obstruction, the patient can speak and cough. They may wheeze between coughs. A mild obstruction is typically cleared naturally by the patient through forceful coughing.
Cough it out. Come on.
If the person can inhale and exhale, encourage the patient to continue coughing. Watch for signs of the airway obstruction becoming severe.
It's intense.
That was scary.
Morning, Chrissy. How are you feeling?
Much better, thank you.
I need to get another set of your vital signs.
When a severe airway obstruction occurs, the patient cannot get air in or out of the lungs.
Are you choking?
This is a life-threatening medical emergency. If the foreign body is not removed, the patient will quickly become unresponsive and suffer a secondary cardiac arrest within minutes. Signs of a severe airway obstruction include the inability to speak, a weak cough, or no cough at all. The patient may make a high-pitched noise when trying to inhale or make no sound at all. They may hold their hands to the throat.
Try and get your breath.
If the patient is an adult or child, ask, "Are you choking?" If the person nods yes or is unable to speak or cough, act quickly. If you are not alone, have someone use a mobile device to call 911 to activate EMS or activate your facility's emergency action plan. Stand behind the patient. If needed, kneel behind a child. Reach around and locate the navel. Make a fist with the other hand and place it thumb side against the abdomen, just above the navel and below the ribs. Grasp your fist with the other hand. Quickly thrust inward and upward into the abdomen. Repeat. Each thrust needs to be given with the intent of dislodging and expelling the object. Continue until the patient can breathe normally or becomes unresponsive. If the object is expelled and there is good air exchange, encourage the patient to be seen by a healthcare professional. Infrequent but serious complications from abdominal thrusts can occur. If the patient becomes unresponsive, carefully lower the patient to the ground. Begin CPR starting with compressions. Do not check for a pulse. Before opening the airway to provide rescue breaths, open the patient's mouth wide. If you see an object, remove it with your fingers. Perform about 2 minutes of CPR and activate EMS or your facility's emergency action plan if you haven't done so already. Continue the resuscitation attempt until advanced life support providers take over or until the patient starts breathing, moving, or reacting in other ways. If an infant appears to be choking but is responsive, watch for signs of the obstruction becoming severe. If there is good air exchange with a mild airway obstruction, the infant is coughing forcefully, has a strong cry, and can inhale and exhale, stand ready to help if things get worse. With a severe airway obstruction, the infant may cough weakly, be unable to cry, or unable to make any sound at all. There may be a high-pitched noise when the patient tries to inhale. If the infant is responsive and you are not alone, have someone call 911 to activate EMS using a mobile device or activate your facility's emergency action plan. Kneel or sit with the infant in your lap. Hold the infant face down over your forearm with legs straddled and with the head lower than the chest. Support the head by holding the jaw. Rest your forearm on your lap or thigh to support the infant. Using the heel of the other hand, give up to 5 back slaps between the shoulder blades. Give each back slap forcefully with the intent of dislodging and expelling the object. Sandwich the patient between your forearms and turn the infant over, using the palm of one hand to support the face and the palm of the other hand to support the back of the head. Place 2 fingers on the breastbone, just below the nipple line, and give up to 5 chest thrusts. Give each chest thrust forcefully with the intent of dislodging and expelling the object. Repeat the sequence of back slaps and chest thrusts until the object is expelled and the infant can breathe or becomes unresponsive. If the patient becomes unresponsive, place the infant on a firm, flat surface. Begin CPR with compressions. Do not check for a pulse. Before opening the airway to provide rescue breaths, open the mouth wide. If you see an object, carefully remove it with your fingers. Don't stick your finger blindly in an infant's throat and attempt to sweep out an object. This can cause injury or push the object further down the throat, worsening the obstruction. Perform about 2 minutes of CPR and activate EMS or your facility's emergency action plan if you haven't done so already. Continue the resuscitation attempt until advanced life support providers take over or until the patient starts breathing, moving, or reacting in other ways. If the patient is pregnant or obese, use chest thrusts instead of abdominal thrusts. Position yourself directly behind the patient. Reach under the armpits and place the thumb side of your fist on the center of the chest. Grasp your fist with the other hand and thrust straight backward. Try to not put pressure on the ribs. Give each chest thrust forcefully with the intent of dislodging and expelling the object. Repeat the chest thrusts until the object is expelled and the patient can breathe or becomes unresponsive.
Oo, particularly on airway, nauna si airway. Halos yun lang naman yung adjustments. No? For the reason that they want to establish a closed circuit format. Ibig sabihin, walang aerosol. Nakalock lang doon sa tube going to the bag valve mask, which ideally has a HEPA filter. Mas malit yun yung bago ngayon. Subukan kong bumili. Pagka-time ako, bibili ako isa. Now, what are the objectives? One is what's ACLS, and another visit or a revisit to the chain of survival. And then we will study ECG separately. And we will go into pharmacology, ACLS pharmacology, mga drugs. And we will do stations on airway, intraosseous, and a lecture on transcutaneous space. Kasi itong machine ko, wala yung kanyang adapter for transcutaneous spacing. Tapos how to do the mega code. Nagkataon lang na nag-iisa ako. Tapos pangalawa, because of pandemic, nag-virtual tayo, medyo mahirapan akong hikayat kayo into a into a code blue scenario na malayo tayo sa isa't isa. Now, ACLS is about algorithm. So mas maswerte kayo ngayon, di katulad sa amin, marami kaming algorithms nung mga early 2010 yan, 2005, 2000, grabe, magkakahirap, maraming terminology. Mas mahirap yung ACLS namin noon. At yung mga drugs, merong mga nababawas na ngayon, nagbawas na ng drugs. So it's a set of clinical algorithms for the urgent treatment of cardiac arrest, no? Stroke, MI, tapos yung mga tachyarrhythmias, bradyarrhythmia, and tachyarrhythmia. And it's an interplay or interface of CPR, drugs, and electrical therapy. So naglalaro dyan. And of course, performing advanced airway. It is performed by people or by medical personnel who are trained. Pag kayo na-train kayo, depende sa inyong hospital, kayo yung ipapamember sa Code Blue Team. Pero kung wala pa kayong Code Blue Team, pwede kayo magtayo ng Code Blue Team. Yan. Now, we will discuss ECG reading, pharmacology, advanced airway. Hindi na ako magdi-discuss ng IV kasi familiar sa inyo. IO na lang yung ipe-perform. And then defibrillator, no? Klaseng defibrillator. Tapos cardioversion, ipapakita ko sa machine. Then capnography, meron ako pero sira siya. Pero meron talaga akong capnography. Ito yung medyo hindi sikat sa Pilipinas. Transcutaneous spacing, selection lang. ACS, saka CVA, tapos hypothermia. Now, ACLS is the cornerstone of all ALS kasi lahat ng mga pwedeng mangyari sa tao, ang lalandingan niya is cardiac arrest din. So pag magaling ka sa ACLS, medyo kuhang-kuha mo na yung ibang advanced life support, particularly when you employ drugs, nahulog yan sa cardiac arrest. Although ang ATLS, ibang highway because it's more performing like creek, chest tube, cut down, you know. But once you address, while you do that and the patient goes into arrest, ACLS pa rin yung kanyang landing. So lahat to, pag pumangit yung pasyente nyo, bagsak sa ACLS. So there are 10 core ACLS cases. Respiratory emergency, tapos yung ventricular fibrillation, pulseless ventricular tachycardia, asystole, PIA, tapos bradycardia, stable tachy, unstable tachy, ACS, stroke, so 10. So yun yung pag-iikutan natin, paano natin tugunan itong 10 na. Now this is your in-hospital chain of survival. I-review ko lang, 6 na siya ngayon. So we go into early recognition and prevention, which I will discuss a while ago, bago mag-heart attack, ma-prevent natin. No? And then in case merong cardiac arrest, you know whom to call. Yan, during arrest, perform high CPR, defibrillation. Hindi pa ACLS itong defibrillation. Unless nasa hospital ka, piniprep up mo na. So manual defibrillation. Pag oras nagbigay ka na dito, habang naglalaro ko, wala pa akong post-cardiac arrest. Dito, pwede ka na umangat ACLS, defibrillation ko na rin. Nag-IV ka na, epinephrine, defib, drug shock, tapos tuloy-tuloy CPR, drug shock. Dito yan. Tapos kung meron ka ng mga nasa CCU ka na, naka-inotropes ka, ito, post-cardiac arrest until you are discharged. Now, this is our airport runway. This is the sandbox. You know, the sandbox is where you will play. Yung mga bata, sandbox. You will do lots of things there and arrange and what. So this is somehow a sandbox, but this is a fixed what to do. So lahat, when you read ACLS manual, masasagupa nyo ang tinatawag na COR or Class of Recommendation. Tingnan nyo rito sa cursor ko. And then the LOE, the levels of evidence. So halimbawa, pag sinabing class 1, benefit is 3 times greater than risk. So ano yun? CPR. CPR is classified class 1. Giving of oxygen is classified class 1. So sample yun. No? Pag nagbigay ka ng epinephrine, epinephrine is class 2A. Benefit is greater than risk. Tapos level A siya, high quality evidence. Kaya si epinephrine ay hindi mawala sa cardiac arrest. So nahulog siya. Pag halimbawa, epinephrine, first time na mention sa libro niyo, merong open-close parenthesis, class A, and then level A. Pag sinabing class 2B, medyo weak na yung evidence, weak na yung kanyang let's still the benefit. Mataas na. Katulad ng mga sodium bicarb, no? In certain instances na bumabagsak siya sa 2B. Pag class 3 na no benefit, moderate siya, ito na yung sample is vasopressin. So si vasopressin, hindi siya as effective as epinephrine. Nahulog siya na class 3 na siya. Class 2B, class 3. So hindi na natin siya binibigay. Then we have the class 3 hazardous katulad ng or the risk is higher than the benefit. So like, what do you call this? Sodium bicarb na binibigay natin sa long-standing arrest. So hindi na siya pwede. Yan. So sa level of evidence, depende sa level, halimbawa, class A, talagang like epinephrine, oxygen. Level B, moderate quality siya, amiodarone, tapos naka-undergo siya ng randomized trial. Meron ding B, non-randomized, tapos C, limited data. May mga gamot tayo or intervention na hindi pwede. And of course, yung sinasabi nating level C expert opinion. May mga katulad ng ivermectin, ginagawang expert opinion. So, hindi siya dumaan ng meta-analysis. Okay. Sarahan ko lang yung door. Yung pusa na pumapasok. Okay, I will not talk about this abbreviation and what. So, ito yung ating bakit may guhit? Joy, kung sino man, tatanggal na. So, ito yung lumang algorithm natin. Punta tayo sa bagong algorithm. So, this is the new algorithm of ACLS. So, same pa rin sa BLS, except na meron lang emphasis, particularly on drugs. So, when you look at the algorithm for ACLS, ito yung makikita niyo sa arrest. Nakakalito kasi may naguhit. Joy, kayo ba tanggalin yan? Hindi ko kasi matanggal yan from my end.
Wait lang po, Doc. Try ko po.
Anyway, sige. Tuloy yan. Yung ating ACLS, yan yun na lang mo ng gulit. Pareho pa rin sa BLS kanina. So, the first box is limit personnel, naka-PPE ka na, consider resuscitation appropriateness. Ibig sabihin, ang gamit sakto lang, hindi yung overkill, at ang staff sakto lang. Then, give oxygen. Pag nagbigay ka ng oxygen, seal talaga para ang aerosolization sa environment na di-defeat natin. Attach to monitor defibrillator katulad nga sa likod ko. Meron ako monitor defibrillator yan. Yun. Kita ba? Ewan ko kung nakikita. Oops, saglit. Yan. Attach natin kung ano yung display. Then, prepare to intubate. Tandaan nyo, intubate ka agad. wala pang sinabing IV na una yung intubation. Yan yung 2022 interim guideline. Bakit kailangan yun? Para masara na. So, tingnan natin kung rhythm shockable versus shockable. Pin-repair pa lang, hindi pa na-intubate. Manual tayo dito. Pag nakita nating ventricular fibrillation or pulseless, malit na PVT, pulseless ventricular tachycardia, shockable yan. Pag dito naman sa kabila, asystole. So dito muna ako babaybay sa shockable. So dito sa shockable rhythm, shock ako. After first shock, usually IV ang binibigay. Hindi IV. As per interim guideline, ang unang gagawin natin, pag shock niya, nakaready na si intubation. Huwag mo na mag-compress. Nakaready na, no? Kasi dito pa lang sa first box, prepare to intubate. So nagsi-CPR ako, prepare intubate. By the time na tinignan ng team leader, nasa foot ng defibrillator siya. Okay. Guys, after I shock na. Okay. So, pag shock, tingnan natin yung kung masyadong may secretion, mabilis. Kung may secretion, compression muna. Kasi nga, minimize delay. Kasi kung mag-suction ako, walang compression, na-defeat yung compression. Compression muna, suction. Ganon ang interplay. Hindi siya halos binibigyan natin ng ano ba talaga dapat dito sa libro. Although kung basahin yung libro, lumilitaw siya. So gawin ko lang shortcut para sa inyo. Nag-shock ako sa pasyente. After shock, tiningnan ko BF on screen. Pagtingin ko ngayon, marami pang yung secretion. Respiratory leader, continue CPR. Okay, pag-suction to prepare intubation. So suction. Ngayon, along the way, wala pa akong 2 minutes, ni-ready ko na intubation, pwede ka na mag-IV. So, wala namang ibig sabihin na kailangan ma-intubate or kailangan si IV. Pwede sa IV while waiting. Pag sinabi kong stop and intubate, pag sinasabi ang intubate, hinto ka agad. Kailangan ma-practice yung tinatawag natin na first pass success. What do we mean by first pass success? Yung first pass success, ang unang intubation mo, kuha ka agad. Kaya, balik ako dito sa pinakataas, consider resuscitation appropriateness in personal and in equities. Naintindihan? Question? Tanong? So medyo nilinaw ko lang to kasi ito yung bago. I need to clarify this as before ko iusan. Ulitin ko. Naka-level 3, kahit level 2, okay na. Sige, assist. Si pasyente, kabit sa bag valve mask. Bag valve mask pa lang, CPR. Abang nag-CPR kasi kompleto naman si team. Crash cart, ready. Okay, standby. Kahit hindi ko abutin 2 minutes, CPR. Okay, hold. What's on screen? Okay, on screen is ventricular fibrillation. Okay, I'm going charging down. Charging. Ako yung team leader. Tanggalin ko na lang. Para makita niyo. Yan. Defibrillator. Sa defibrillator ko, pads. Yung iba pads. So dito, meron tong energy select. So, energy select. Tapos, energy select, ayan. Pababa, pataas. Tapos, dito, ayan yung yellow charge. Beep, beep, beep. Ito ang fire, dalawa. Boom! Okay, sabay yan. Okay. So, kasi manual na, pwedeng naka-pads. Yung pads, ang control panel ko ay nandun sa machine. Okay. Charging machine. One and clear. Clear. Very clear. Shock. Ngayon, nag-shock ako. CPR, nag-shock ako. Wala pa akong Pwede dito, tingnan yung cursor ko. Pag start CPR, kasi code blue siya, Actually, way back before, ginagawa na. Habang nagsi-CPR, hindi pa ako inabot ng 2 minutes. Hindi pa nga inabot ng 1 minute kasi nasa crash cart ako. Pwede na ako nag-IV. Pero malabo na makapag-intubate ako this time. Malabo pa. Kasi kailangan sakto yung lahat mas marami tayong makukuhang magaling mag-IV kaysa sa makukuha magaling mag-intubate. Yun yung doon, yun yung dynamics. So una maglagay si IV. So doon pa lang habang nagsi-CPR, pagdating doon, sakto si Code Blue inabangan. Bakit nag-abang? Kanwari sa ambulance conduction. We are already doing CPR. We defibrillated already. Uli kami naka-IV kasi wala kaming makuha. So ibig sabihin zero IV. So nasa ambulance, ready sa ER, we are 20 seconds out. Ibig sabihin 20 seconds, nasa bungad na. Pagpasok doon, CPR, pasa na sa ER, boom, bed number 1, alagay doon. Pwedeng tuloy na siya or activate mo yung code team. Pero kung nasa ambulance na naka-code ka, pwedeng naka-activate na sa hospital ang code team. Yan yung tinatawag na synchronization ng sequence of intervention. So, yan, step up. Kaya pagdating sa, kunwari, sa ER, nakaabang na ang code team. So, paglatag doon, boom! Continue CPR, naka-down PPE na, continue CPR, okay? Yung pinaka-team leader, pwede siya kumatras, okay? Endorsing to him, limit personnel tayo. We'll just be on the nurse station. Standby lang. Huwag kayo sa paligid. Nagmamarites kayo doon. So, hayaan natin sila. Tapos tulong ka lang sa likod. Pwede kang yung electric fan or create a wind corridor. Mga ganun. Common sense lang yun para maging effective yung team. Hindi naman kailangan ikaw yung compress, kaya nag-intubate para ikaw yung parang hero. No? So, depende sa setup ng hospital, attendance down. So, ngayon, IV ka agad. IV pa yun, wala pa akong gamot. Unless, pag sinabi nila, okay, may IV, tapos palapit na sa 2 minutes. Sige, drive ka muna ng epinephrine. Okay lang yun. No problem. So, wala tayong definite highway. Kung sino na una. Intubation, ready na. Parating na po yung anesthetist. Nandito na siya, malapit na siya. Anesthesiologist or anesthetist or intensivist. Kasi yun yung appropriate. Yan sila yung magaling sa pagtubo-tubo. So, dumating na. Palit na si airway. Standby. Okay. Hands off. Let me see what's on the screen. Ventricular fibrillation again. I'm going to shock the patient. Okay, charging now. Parang clear. Clear. The average clear. Tingin sa screen. And shock. Boom. Tingin ako. Okay, paki-suction. Continue CPR. Suction mo muna yung bibig. Okay. Advanced airway ready. Ready na. Suction. Then. Ngayon, ang problema ngayon, depende na sa kung active sa COVID to, bawal mag-suction na nagsi-CPR. Bakit? Tanggal So, lipad ang aerosol. Pero ngayon, kung kaya niyo na, kaya naman ng katawan, okay lang, suction. Tuloy. No? CPR. CPR, suction. Okay, I'm ready. Pag ready na, okay, bitaw. Pag bitaw ngayon, naka-laryngoscope aided, intubate siya, suksok, lock, pag-lock, capnometer, lagay BBM, check, continue CPR. CPR siya, bomb, CPR na naman. Check, okay, negative sa gastric area. Okay, sige. Okay. Check, positive, left at saka right lower, positive, upper right, upper left. Okay, then inflate. Pag inflate mo ngayon, lock na, lagay mo na ng nilock mo na, lagay mo na ng endotracheal tube holder. Tuloy-tuloy na yan. Ikaw naman, asynchronous na kayo, hindi na 30 is to 2. Kung hindi, every 6 minutes ka, nagbibigay ka. Tapos binabasa mo ngayon yung capnometer kung merong carbon dioxide readout. So yan yon. So CPR ulit, shock ka ulit. Tapos ikaw naman, pwede kang, kung naka-IV ka rito, dito ka magbigay ng epi. Tapos, pwede mo na ikabit into mechanical tamper. Siya yung nagpapa-CPR. Okay. Now, I want you to look at this side. Lipat ko lang itong mga video-video. Makita niyo ang CPR quality natin. So, emphasis. This readout is only in ACLS algorithm. So, coming from your BLS, push hard at least 2 to 2.4 inches at 100 to 120 and allow complete chest recoil. Minimize interruption of compression. Number 3, avoid excessive ventilation kapag nakabag-valvas. Then, change compressor every 2 minutes. Yung nagko-compress si Hichon. So every time kung, okay, change compressor. Kung ako na naman mag-CPR. Can you team lead? Okay, team lead. Kasi hindi pwede mag-team lead ang CPR. Bakit? Nakakapagod siya eh. So, ang mag-team lead ay yung naging defibrillator. Pwede rin sa airway yung team lead. So, depende sa setup. Papasok pala kasi pag nag-ACLS, ang minimum is 4. Ang optimal is 5. Ideal is 6. Yan. So, may airway ka na, asynchronize na ang compression ventilation ratio, tapos bigay ka na ng next, kunwari epinephrine ulit, shock na naman, epinephrine, amiodarone, 300 mg. So, depende kung anong gusto mong gawin. Until, whatever, magkaroon ng return to spontaneous circulation. Another thing here, in advanced airway, meron tayong tinatawag na quantitative waveform capnography. So makikita nyo siguro bukas pag nag-advance airway tayo, pakita ko yung capnometer. Tapos pag hindi maganda ang readout, less than 10, ibig sabihin hindi maganda ang compression. Unless long-standing arrest na, babagsak talaga siya 10 below. Kasi wala ng carbon dioxide mapuproduce ang tissue. Patay na yung tao. Okay. Then we have this defibrillation. So itong machine ko, monophasic yan. Yung mga bago ngayon, biphasic. Ngayon, yung biphasic, bakit siya biphasic at monophasic? So, i-explain ko. Yung paddles or pads, ang nagpa-fire ay ilalim. Apex, sasaluin ni sternum. Okay? Fire sa apex, sasaluin ni sternum. Pag biphasic, pero yung apex, saluin ni sternum, less than 1 second yun. Ganun kabilis. Pag fire mo, salo nito. Ganun lang kabilis. Pero sa biphasic, fire salo, balikan. Kaya it means only lower joules. Pero less than a second, ganun siya kabilis. Kaya hindi mo malaman. Pero ang machine, dinisign siya na ganun. Okay? So that's how your defibrillator goes. Now, biphasic is 200 because they saw that 360 can somehow, in little ways, can cause also cardiac muscle, tawag dito, yung pagkasira. It destroys cardiac cells. Kaya binabaan sa 200. Pero kailangan sa 200, dalawa yung takbo. Hindi yung isang takbo lang. Now, what else about defibrillation? Let's go into advanced airway. So dito, makapansin nyo, there's a saying, minimize closed-circuit disconnection. Pag sinabing closed circuit, naka-enclose lahat, yung daluyan ng hangin, wala siyang contact sa environment. Therefore, yung aerosol nasa loob lang. Yan yung closed circuit. Kung in case lalabas, katulad ng exhalation ng pasyente, meron yung filter. Then, intubator with highest likelihood of first pass success. So, ibig sabihin nun, ang nag-intubate, kuha ka agad. Hindi na siya mamali. Consider video laryngoscopy. Since year 2003, 2004, meron akong laryngoscopy na, video laryngoscopy. Pero medyo black and white pa ngayon, colored na eh. Endotracheal intubation or supraglottic advanced airway, yun yung ating ginagawa. So, ang ET, sa inyong location, sa in-hospital, ang endotracheal tube, ginagamit natin. Pag hindi tayo successful sa dalawang attempt, mag-supraglottic. Ipapakita ko bukas yung supraglottic. Then, pag naka-intubate, then hook to capnometry. So, mapansin natin, ayan, meron tayong ina-achieve na ayusin natin yung cause ng cardiac arrest. It can be hypovolemia, so we can give blood or fluid, hypoxia, then high tension oxygen. Hydrogen ion, or the oxygenation plus sodium bicarb and other. Hypothermia, hypokalemia, o di yung sodium bicarb and kaliumdorol. Pag hyperkalemia, marami. Calcium gluconate or calcium chloride, kayakselate enema, marami siya na. Hypothermia, hypothermia labas. Pero ang ginagawa natin fluid ay 40 degrees centigrade. 30 bukas. Tamponade cardiac, ituturo ko bukas. Yan. So these are all the reversible. Yung toxin, may mga antidotes. Tapos thrombosis pulmonary and thrombosis coronary. MI. So this is your interim guideline. Engage yung intubator mo, yung intubate, and ang ating bagwal mask ay merong HEPA filter. Kapag again, I will not read on the details of the COVID protocol. Ito yung mga luma na algorithm. Yan sila. So, in case there is a pulseless tachycardia or ventricular fibrillation, anong gawin natin? Quality CPR, pwede tayo magbigay ng 1:10,000 epinephrine, pero wala siya ngayon. Amiodarone after an epinephrine or lidocaine after an epinephrine. We can do advanced airway. So I'll also do some demo there. And achieve like a 10 breaths per minute with continuous chest compression. So yun yung ginagawa natin. Hindi natin sila bitawan kahit nasa loob ng aeroplano, tuloy-tuloy yung kunwari sa medevac airplane ka nag-arrest. Pag nabuhay ang pasyente, bigyan natin ng chronotropics para hindi pa lumaglag yung mga inotropes, no? Hindi malaglag yung kung nabuhay na natin, mahina pa yung heart niya. So case-to-case basis. No? Then the energy we use are 360 at saka 200. Then of course, the reversible cost. Now let's go into abnormal fast beating of the heart. There were situations that your heart rate might go beyond 150. So if it's beyond 150, cannot oxygenate the brain. Then your heart will get tired. So pinapababa natin ang rate or yung bilis. Now, the patient comes in And we hook him to oxygen and then the vital signs monitor para makita natin kung maganda hemodynamic. So, what are the parameters that we have to know? Ang kanyang heart rate ay 180. So, nakita mo, although sa ECG ko ipapakita, ano yung mga rhythm niya. Ngayon, tingnan natin sa blue box, ano ba yung kaakibat ng sintomas ng pasyente? Okay, tandaan niyo lang yung mnemonics HASIA. Okay? Tawag doon, HASIA. So, alamin natin is the presence of hypotension. So, pag merong hypotension, ibang paradigm natin of treatment. Pangalawa, meron bang acutely altered mental status? Wala sa wisyong isip niya? Meron bang signs of shock? Yung bluish na nangitim yung lips? Kasi kulang sa hemodynamics? Or you're being struck by a bee na kung saan nag-vasodilate, hindi nabigyan ng sapat na ang brain mo, nagkaroon ka ng altered mental status. And of course, you have any signs of shock, no? And isa pa, is there presence of chest discomfort? Itong acute heart failure, sinama to kasi there might be some aberrancies na bibilis ang tibok. But usually acute heart failure will give you brady. Pero for the sake na there are instances na nagtatake ka. So tandaan mo yung HASIA, hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, and acute heart failure. And or any entity present, lipat tayo dito sa horizontal, we can cardiovert the patient. Cardioversion is like a Joules. It's like a defibrillation, except may timing lang siya. Doon siya sumasabay sa R-wave. Kaya synchronized cardioversion, si synchronize. Saka hindi siya gumagamit na yung mga wide QRS na SVT, no? But usually yung acute heart failure, hindi SVT, acute heart failure usually mga 3rd-degree heart block. Now, cardioversion, isang problema lang, patulugin mo kasi masakit po kapag kinukuryente ka. So, kailangan patulugin mo siya. What if there's none? You cannot find any HASIA. Tingnan natin kung yung QRS ay sakto lang. No? Hindi siya, not beyond more than 0.03 of a second. More than that, 3 small boxes, which is 0.12 of a second. 0.12 of a second. Pag sumobra dyan, ang tawag dyan white QRS. Okay, so anong gamot sa white QRS? So, yung according to American Heart Association, adenosine 6 mg ang unang gamot. Okay, so sunod na lang yung iba. Like, kung gusto mo blocker or even calcium blocker. So, balik ulit ako dito sa QRS. Is there a white QRS? Wala kayo sabi. Meron pang succeeding. No? Kung walang white QRS, nakita na sa screen, ano pa bang iba? So, depende, ano pinipresent pa ng pasyente, but this time, we have to give them access. Pag nakita ka ng pag nakita ka ng like SBT, no? Silit-silit yan, makikita mo yung pasyente, Namumutla talaga yan. And when you check it out, ang bilis ng tibok ng puso. Substance abuse or may hyperthyroid. But sometimes, kabog. Tapos later on, mag-a-arrest lang ito. So itong algorithm na to, hindi to nagtatawag ng help kasi hindi naman siya arresting. Tachyarrhythmia. So what you can do is just call your on-duty cardiologist. So ayan yung mga gamot. Narrow siya, regular naman, ganda tingnan. Kung gusto mong mag-defeat, cardiovert, you can start at 50 to 100 joules. Pagka nagkataon na narrow QRS pero irregular siya, you can start at 120 at even up to 200 biphasic or 200 at monophasic. If there is a freak reason na nagkaroon ng wide regular, 100 joules, and wide irregular, no need to cardiovert. Pwede ka na mag-defib. Adenosine, mahal na gamot, kaya bira lang ko nakagamit yan. Pero yung mga nagamitan ko, nagmimilagro talaga, bumabalik sa NSR. So adenosine 6 milligrams. Rapid to, kailangan na i-demo ko sa inyo kasi pag kuya-kuya ka dito mag-drive, namamatay ka agad yung gamot sa red blood cell. Well, kung ayaw nilang adenosine kasi mahal na, tapos medyo maing-ing pa yung shelf life niya, pwede verapamil. Balik tayo sa adenosine, pag hindi mo bro yung first shot mo, then you can go into double shot. Now, let's go to anti-arrhythmic infusion for stable white QRS or tachycardia, white QRS tachycardia or procainamide or using procainamide. So, yung procainamide, bira mo siya magamit kasi sa akin third year lang siya. Pero anyhow, kung gusto nyo naka-drip kasi stubborn yung arrhythmia, then you can start with even as high as 40 milligram per minute until ang arrhythmia, yung pag-irregular tibok ng puso, nawawala na. Amiodarone, kapag tachyarrhythmia, 500 milligrams lang siya. 150 milligrams pala. Sa arresting heart, double that is 300. Okay. Sotalol, isa rin sa, pero problema. Selective na kasi ngayon din yung beta blocker. Now, you can, sotalol, you can give 100 milligram per kilogram. Kailangan matapos over 5 minutes. So, ito yung intervention kapag may arresting heart and you drug shock. Now, let's go into bradyarrhythmia. Ay, hindi pala arresting yan. Sorry. Tachyarrhythmia pala, not an arresting yan. So, dito tayo sa bradyarrhythmia. Dumating yung pasyente, hook natin sa vital sign, hook natin sa oxygen, okay? Hook sa cardiac monitor, tapos identify kagad ang rhythm, baka mabutan tayo ng siyam dito na alam mo, pag mabagal ang ritmo, kulang sa hemodynamics, mamaya mag-collapse na yan. So mabilis, oxygen, cardiac monitor, IV access kaagad, then 12-lead ECG. Again, pag merong presence ng hasiya, katulad ng hypotension, we have to be a bit more aggressive. Or acutely, altered mental status, signs of shock, ischemic chest discomfort, and acute heart failure. Kung wala kayong nakita, o di monitor. Pero pag may nakita kung sino dyan, wala kayong gawin. Do not shock the patient. Drugs ka lang. So, pwedeng dalawa kasi, yung kinacardiovert chemically, initial ang or kinacardiovert electrically. So, ito, chemical, Ay no, sa tachyarrhythmia yan. Ito, walang ano to. Sorry, ang nabanggit ko, cardioverter ko ni pacing. Sa luma, pinipace to. Ngayon, after 2015, hindi na po siya pinipace. Mainly, ano lang siya, atropine. So mabagal siya, usually nangyayari to sa heart block. So no electrical therapy of any sort sa bradyarrhythmia except transcutaneous pace. Kung nag-atropine ako, 1 milligram, repeat every 3 to minutes, hindi umasenso, then patulugin ko na siya para mag-transcutaneous pacer. I-discuss ko na lang yung tungkol. Kaakibat noon kasi by the time naka-IV na, you can even give dopamine, naka-piggyback. I-titrate mo lang starting from 5 to 20 microgram per kilogram per minute. So yan yung bago. Hindi katulad nung panahon ko, hiniwa ko si dopamine into 3. From 1 to 5, tinatawag kong renal dose. From 5 to 10, tinatawag kong renal dose, cardiac dose. And then 11 to 20, tinatawag siyang vasopressor dose. Ngayon, wala nang gano'n. Titrate lang, increase or decrease, depende sa display ng patient. You can also drip epinephrine 2 to 10 microgram per minute. Pero habang nagdi-drip ka, meron kang tinatranscupase mo kasi wala talaga makapalit sa transcupase. So ito naman, sa buong assembly na to, tinatawagan mo ang cardiologist. Ganito rin, kapag bumalik na sa kamalayan, tama pa yung Tagalog ko, yung return to consciousness na, tuloy-tuloy lang din yung pag-manage. Formalize mo na, no? You have to understand na meron tayong ROSC, Return of Spontaneous Circulation. So, nabuhay din ito. Ibig sabihin, okay yung heart niya, tutulungan pa natin. We'll give oxygen, kung maganda sana, advanced airway, tapos nakaka-capnograph. Okay? So, ito yung gamot sa bradyarrhythmia. Pag mabagal kayo, kasi athletic kayo, no? Kakaiba yon. Itong bagal ng puso dito ay naging pathological, sobrang bagal. Nagkaroon akong pasyente, German national ako. 30 to 40 lang, bumagsak sa doon sa clinic. So, na-transcutaneous pace ko siya. Okay, again, pag meron kayong ganung pasyente, usually, sina-challenge nyo 1 to 2 liters normal saline, LR. Hindi pa ako nakatry ng 4 degrees centigrade fluid, yung tinatawag na therapeutic hyperthermia. Now, how do we manage stroke people? Lukso na tayo sa panibagong topic, stroke. I mean, same line pa rin. Medyo hindi tugma sa Pilipinas kasi pinapalakas ng bansang US ang kanilang pre-hospital care. Kaya mga paramedic nagtatrabaho dito. So malabo sa atin. Although pag may pasyente tayo, pwede naman mo sa oxygen. Tapos perform Cincinnati pre-hospital stroke scale. Yung tinuro ko kanina. You can, stroke scale gagawin mo po sa pasyente. Tapos you can check glucose also sa glucometer mo. Ang tawagan mo na ang stroke center ng hospital para ma-activate siya. Okay? By the time na dumating sa hospital, nagtitiktak na yung relo, kailangan sundin natin yan. Pagdating sa ER, kasi ang ideal is 10 minutes nasa ambulance. So, 10 minutes gagawin din sa ER. Kukuha ng ABC, saka initial blood chem, nakahook sa oxygen, kung hindi na IV-han doon, this is the time na ma-IV-han sa ER. But even if may hypoglycemia, you have to check kung yung pwede namang sabihin natin ang cause is not hypo. Cause is like bara. No? You have to check also glucose. Nasa necessarily lapasan mo lang siya. Kasi compromise na yung brain, lalo mo pa siya i-compromise sa circulation, saka sa Yeah, sa circulation. Now, we can obtain 12 lead ECG at the same time. So, may mga machine na ngayon na isang machine kompleto. Hindi katulad sa akin, na hindi ko nasa itaas yung ECG ko. Iwala yung ECG, iwala yung limb lead. So, after 10 minutes, i-detect ko na for CT scan. So, ibig sabihin, within 45 minutes of ED arrival, nakalagari papuntang CT scan. Bakit? I-CT scan natin para malaman pag walang hemorrhage versus may hemorrhage. Siyempre, mas matatakot kayo sa hemorrhagic stroke kasi mas masalimuot kaysa sa non-hemorrhagic stroke. So, i-checklist natin kung allowed siya sa fibrinolytic therapy. And sa hospital, repeat neurologic exam. Katino naman ang alay mo, nakabawi sa'yo. I-side by side mo rin yung for example, yung pagtawag sa stroke team, hanggat hindi to arrest, hindi to ginagawa ng code blue team. So, meron talagang stroke team. So, candidate siya for patient therapy. Ngayon, ano ang parameter para maging candidate siya? So, titingnan natin. Baka naman bleeder to. Makikita mo ito sa box ilalim. No? Kung baka kandidato, baka kaano lang nito. Kung ipipiprenalize ko to, baka sira yung pathway. No, lots of things. Titingnan natin yung ano. Or recent head trauma. So, within 60 minutes of ED arrival, up to 3 hours, dito yung interplay ng intervention for stroke. So, dito tayo sa malas-malas na side, hemorrhagic stroke. So, tawagan si neurosurgeon, si neurologist ako si neurosurgeon. Then, tingnan natin yung begin stroke or hemorrhage pathway. Admit ka agad sa ICU kasi wala tayong magawa sa ER. Now, this one, ay lulukso din dito. Begin post RTPA stroke pathway. So, aggressively monitor the patient. Now, this is more, hindi na to pre-hospital. More in-depth into the stroke section kung meron ang hospital yung ganon. Now, let's go into ACS, sakit sa puso. So again, dito sa pre-hospital, ito yung armada. Isipin mo sa atin, wala tayong morphine sa loob ng ambulance. So you can start your 325 chew de aspirate, hook to oxygen, nasal cannula. Dito kayo mag-nasal cannula. You may hook to ECG monitor. ECG yung 12 lead. Naalala ko yan. No? Nagkaroon kami ng Rosetta. So sa loob ng ambulance mayroong ECG. Pero nakikita ng ER kasi may Rosetta eh. It's like binabato niya. So nakikita rin niya yung ECG. Pagdating sa emergency department or i-bypass mo si ED, diretso ka sa cath lab na sa'yo. Ganon din ang gagawin. Except may physical examination by the doctor. Ngayon, kung senior cut nyo, well, tuloy-tuloy naman. Pwede kong painumin ulit ng Mona. Oxygen, aspirin, nitroglycerin, tapos morphine. So yan lang yung rundown ng ating acute coronary syndrome. Okay. Now, in-emphasize natin good quality CPR. Ayan. And then, how fast can you intubate the patient for a closed circuit assembly? Kung nabasahin yung ano ha. So dito ako sa capnography. Nung wala pang intubation, CPR lang, wala talagang readout. Nung na-intubated na, ang normal capnometer is 35 to 45. No? 35 to 45 millimeters of mercury. By the time intubated, yun. Pero hindi, babagsak siya at 12.5. Okay na yan. Even 12 to 25. No? Along the way, maganda ang CPR mo, tumataas pa siya. Kapag may presence ng carbon dioxide doon sa capnometer mo, masaya ka kasi hindi pa dead answer. Until the patient goes into return to spontaneous circulation, ganyan na kalaki. So yan yung capnograph po, yung yellow. Mahal yan. So kinakabit yan between the valve mask and then the ambu bag. Between the valve mask and the endotracheal tube. Meron din tinatawag na mechanical CPR para hindi na ikaw mag-CPR pero hindi pwede sa baby to. So yan ang forma niya, oxygen powered siya. Pinakamarami dyan yung auto-pulse, force, yung pareho lang naman mechanics niyan, oxygen powered siya pero depending branding. So yan yung ating chest compressor. Wala lang akong video pero makikita mo, dinidiin yung dibdib. Meron din bago ngayon, yung tinatawag na ECMO, sinusubukan nila kung pwede sa pre-hospital care. Binabypass mo ang yung hirap ako Tagalog. Yung ECMO para siyang dialysis. Iba-bypass niya at ino-oxygenate dito. Kaya pagbalik sa katawan, oxygenated na. Although nakagawa sila ng ECMO na medyo maliit, kaya ginamit nila dito sa subway. I think this is in France. ECMO na yan, ganyan ang high-tech. Sa pre-hospital care, tingnan natin kung obra si ECMO. Yung maka-full swing siya. Although there exists no high-quality evidence to either support or refute the use of pre-hospital ECPR or So, depende pa rin, tuloy-tuloy pa rin yung study. Another thing na napakaganda, lalo na sa trauma, meron tayong artificial red blood cell. Ang maganda sa kanya ay nakakakuha siya ng oxygen. So, it behaves like the heart. Ang gawa po nito ay kalimutan ko anong sa so powder siya. By the time na nilagyan mo ng fluid, liquid na siya and then it absorbs oxygen. Benefits powdered synthetic blood. Matagal siya sa shelf life. Okay. So, ayan po, no refrigeration required. Pabor yan ngayon. Sa ACLS, ito yung kinokorek natin. Hypovolemia, so fluid resuscitation. Kung blood ang nawala, di blood ang ibigay. Hypoxia, di airway management. Hydrogen ion, airway management. Kaya kayo nag-hydrogen ion kasi mahina yung oxygen niyo. Hypoglycemia, of course, IV dextrose. Hypokalemia. Hypoglyce dextrose, hypokalemia is IV magnesium. Hyperkalemia, medyo marami-rami. Calcium chloride, sodium bicarb, insulin, tandem glucose. Yeah, yung hyperkalemia. Then hypothermia, which is extracorporeal rewarming. Tension pneumothorax, i-demo ko na lang yan. Yung needle decompression. Cardiac tamponade, i-demo ko yung pericardiocentesis. trauma, no? Toxins, which is ang ano natin pang-kontra. Kung ahas yun, meron tayong pang-kontra doon. Tamponade cardiac, pericarditis disease, thrombosis, fibrinolytics, or envelopectomy. Pag, ano naman, pag combat naman, combat, thrombosis coronary. Fibrinolytics or PCI. Ito yung mga ST elevation MI. Hypoxia, anong goal natin sa hypoxia? So, bigyan natin ng ng oxygenation na tataas ang ating arterial pressure, no? Para ma-achieve natin ang auto saturation like 95% and up. So, depende kung anong klaseng form of illness, we can even use mask and other people, no? I mean, mask. Non-rebreather mask na kung saan para mas high tension oxygen. Other people do that, no? Lalo na sa COVID, nandadaya kasama ako. Dinadaya ko na. Hypovolemia, so depende kung kung blood transfusion kailangan o di blood transfusion, kaya naman saline, okay lang. Hydrogen ion, so depende ano ang treatment paradigm. Hydrogen ion. So, oxygenation lang. Yung presentation. Ngayon guys, punta tayo dito sa heart natin. I mean, sa ECG. Sa ECG reading, tuturuan namin kayo on how to read pathological ECG para mabigyan natin ng intervention. So, bago ako mag-ECG, mag-rundown lang muna ako dito. Tandaan niyo yung mga small boxes yan. Small box or small square, tapos ito big square, itong buo. So, kaibiganin lang natin yan para maintindihan natin. Makukuha natin yung normal, kitang-kita na yung abnormal. I think yun lang naman yung sa general, I think that's all in general ACLS. Generalized na lang yan on what to do. Okay, my next topic is ECG unless you have any question. Kunin ko lang yung ibang ECG, ECG, ECG. Share. Yun. So luma na siya, 2003, pero hindi pa na magbabago ECG. So you have to note that the organ, the heart is an organ with three presentations. It's a mechanical organ, chemical organ, electrical organ. So with that, it emits electricity and you can somehow read what's going on inside the heart. So Simula dito sa primary pacemaker, merong internodal tracts of Bachmann, Turrell, and Wenckebach, bundle of his, AV node. Now, pag nag-fire si SA node, may time frame. Dadaan siya sa internodal tract to allow what they call this, filling of the ventricle. Tapos baka mag-fire si ventricle. Pero less than of a second lang. Ganun kabilis. And then bundle of his, 4 kg system, and what, no? Then, SA node, kung tanggalin ko, ang kanyang rate is 60 to 100 firing rate niya. Si AV node naman, ang kanyang firing rate, abot na 40 to 60. Si bundle of base, 40 to 60. Si 4kg is 20 to 40. Baka sa tanongin nyo, ay kung wala na pala akong pacemaker, si ventricle na lang, mamamatay ako kasi hindi ang 20-40. Hindi po. Because the heart will accelerate all by itself. Kanya, yan ang kanyang, so meron kang accelerated rhythm. Okay? Now, ito lang yung kayang basahin ni ECG. Heart rate, regularity of the rhythm, tapos yung conduction time, tapos yung abnormal conduction pathway. Baka magtaka kayo, ang cardiac muscle hypertrophy ay hindi na-detect. Actually, na-detect. Ang nangyari lang, huwag mo lang siya isama sa halimbawa, may mga doktor kasi na pagtingin sa ECG, alam nila may hypertrophy. Pero sa standard kasi, huwag kang mag-judge ng hypertrophy hanggat hindi x-ray yung tingnan. Yung ganun talaga sila. So, ECG is the graphic representation of the electrical activity of the heart. Usually, yung katulad sa akin, sing strip, sa inyo kasi plate na eh. Sa marami ng pagkakataon. Our lecture for today. Okay, so ganito guys, stretching muna kayo. Ako ititimpla ng medyo nahilo ako. Pagpigyan ako. Stretching for a while. Mga around 5 minutes. Okay? Stretch na. Kasi alam ko, yung iba marunong magbasa siguro. Pero majority baka hindi nakakabasa. O, tingin sa akin dito. Gising-gising. Kasi medyo bubugan na to. Now, tingin dito sa kanan. Back. Yan ha. Big box o big square. Okay? So, yung big box o big square na yan, iba yung wala. Pat ko ang picture ninyo. Nakita niyo to? Everyone? To? Cursor ko?
Yes po.
Okay. Ang big box or big square ay merong 25 small boxes or small squares. Yan. Huwag niyo munang tingnan yung box na buong box. Tingnan niyo lang muna horizontally. Ha? Horizontal. O, tingnan niyo to. Horizontal. Pag horizontal ang orientation ko, I'm talking about time. Pag vertical ang orientation ko, I'm talking about millivoltage, voltahe. Okay? So para lang doon ako mag-start. Ngayon, dito muna ako sa time kasi ito yung unang gagamitin natin. Itong big box, horizontally may 5 small boxes. Yan, 1, 2, 3, 4, 5. Yan. Itong big box horizontally is equivalent to 0.20 of a second. So sa isang segundo, less than of a second siya. Itong big box, ipabiyahe ko yan horizontally, kailangan kakain ng 5 big boxes sa isang segundo na pitik sa relo. So bawat pitik ng relo, 5 boxes ang dumaan. You understand? Parang pinapatakbo ko yung ECG strip. So yung big boxes na yon, sa isang segundo, 5 kakainin niya. So hiwain ko siya, 0.20 times 5 is 1. Okay? Ngayon, ang small boxes, hihiwain ko rin sa 5. 0.04. So 0.04 times 5, ito, tingnan nyo, 1, 2, 3, 4, 5. 0.04 times 5 is 0.2 or 0.20. Okay. Proceed. So ngayon, I have ECG. Noong lumang panahon ko, hindi ko kinakaedad. Sa inyo ngayon, ang printout ng inyong ECG digital, no? Buong 12 lead na sa harap nyo. Sa amin, hindi. Strip lang yan, tumatakbo yan. Lumalabas yung strip sa machine, may guhit. Ang guhit na yun is not made of ink. Hindi siya ink. Ang guhit na yun is made of, tawag nito? Stylus na mainit. Mainit yung stylus kasi yung strip is a thermal strip, thermal paper. Pag in-expose mo sa init, mangingitim. So yung stylus na bumabiyahe, mainit yun. Kaya nagmamarka yung paper. It's a thermal paper. Okay. Ngayon, bumayahe yung strip. Ito ngayon ang lumabas. Nakikita nyo dito sa kanan ko. Itong linya, straighten ko yung linya. Ulitin ko. Tingnan nyo para straighten ko yung linya. Ang tawag niyan, baseline. Diyan naninimula lahat. So, mano-mano kami. Kung ang ECG nasa taas, nakataas tayo, imanumano namin, ibaba namin. Or else ang ECG nandun. Sa inyo ngayon, enjoy nyo na. Ang ECG niyo fully automated. Lahat siya nagsi-self-calibrate para siya may AI na, artificial intelligence. No? Napakaswerte ng inyong henerasyon ngayon. No? So, balik ako sa baseline. Itong P-wave, pataas, ang tawag dyan positive deflection. Pagpababa, ang tawag negative deflection. Okay. Ang P-wave, meron siyang alphabetical, no? P, Q, R, S, T. So we just name these waves P, Q, R, S, T. Kung tanungin ako bakit hindi ABCD, hindi ko alam. P, Q, R, S, T na lang. Okay. Si P-wave is a positive deflection upward. Magkakaroon ulit sa baseline, babalik siya. May baseline no, sa gitna. Then you have the Q wave, and then the R wave, and the S wave, balik ulit sa baseline, and then the T wave, and then balik sa baseline. So papangalanan na natin to. P wave, meron siyang segment. Okay. Q wave is a negative deflection. R wave is positive deflection. S wave is negative deflection. Baseline konti, segment ulit. T wave is a positive deflection. Although, walang activity kay T wave. Absolutely si heart on a resting mode. Dito, pahinga si heart, isoelectric line, babalik ulit sa P wave. So P wave, dyan po nag-fire si atria. Dalawang atria. Paisahin ko na lang. Nag-fire si atria para itulak ang dugo dito sa segment, itulak ang dugo sa segment. Na-fill up na si ventricles, nag-fire si ventricle, si QRS ventricle yan, and then rest yan. Balik ulit kay P-wave. So P-wave is a waveform. Then this one is a segment. Pag isama ko si P-wave and this segment, hihinto kay Q, ang tawag sa kanya ay interval. Isama ko isang deflection or isang waveform plus a segment, it's called an interval. That's why this one is called a PR interval. Somebody will ask me, Sir, bakit PR interval pero huminto sa Q? Hindi sinagot yan sa libro. Sa normal ECG kasi, hindi mo nakikita si Q. Kasi pag nakita mo si Q, ibang reading yun. Ito, inuturo lang sa inyo yung baseline. Q wave must not be around because it implies an abnormality, an old MI. Si R wave ang ating base. Pangalawa, dinosaurian principle. Among these three complex waves, no? By the way, pag naghalo ang waveform, another waveform, ang tawag complex. Guys, saglit, may tumatawag sa akin. Baka Lazada. Saglit lang, saglit. Sorry for the interruption. Okay, balik. So, ito si Q wave, si R, pag naghalo ang tatlong waveform ang tawag complex. In normal ECG, wala si Q wave. If there is a Q wave, there is a problem. Kaya hindi ginamit yung tinatawag na PQ interval, PR lang siya. Ang dinosaurian complex, ganito rin. Isa rin yung isang explanation is the dinosaurian complex. Ang dinosaur, para maging hari ka ng dinosaur, you must be the fierce and the biggest, no? So naghalo yung dalawa. So usually it's always the big, but the fiercest. Although sa among dinosaurs, hindi naman si Tyrannosaurus at saka si Stegosaurus ang big eh. Malaki si Brontosaurus, nagkataon lang vegetarian. Ngayon, dahil pinakamalaki si R, siya na lang yung aking pagbasihan kasi malaki. Okay? So sige. Kaya tinawag siyang PR interval. And then, dito sa S and then sa T, merong segment. So, ang tawag dyan, ST segment. Now, there is relevance here when it comes to ST segment elevation, ST segment depression. Okay. Now, binibilang natin itong small square kung saan siya nakasakop. Kaya malalaman nyo mamaya. So, tandaan nyo ha, QRS interval or the segment, interval, so sila, na pwedeng tawag QRS or QRS complex, PR interval sa ST segment. ST segment, wag natin guloy. Dito tayo sa PR interval at saka sa QRS segment or interval. Pag pataas naman, voltahe. Bawat isa is 0.1, 0.2, 0.3, 0.1, 0.1. Pag nakaakyat ako ng 10 na small squares, equivalent to 1 millivoltage. 1 millivolts. Malalaman natin mamaya kapag darating tayo sa pacing. So, ganun na. So, question? Tuloy ako. So, breakdown of ECG, si P-wave, nag-fire si sinoatrial node, tapos dadaan siya babiyahe siya into PR interval, babiyahe, or less than a second. Ang tawag, may tatlong daanan yan eh. Internodal tract of Bachmann, internodal tract of Torel, internodal tract of Wenckebach. Tatlo yan. PR interval. Then, QRS. Nag-fire si ventricle. No? So, pansinin niyo, si ventricle, kailangan hindi lalampas sa 3 small squares or 0.12. Diba? Sabi ko sa inyo, 1 small square is 0.04. Dapat si QRS complex hindi lalampas sa 3 na small squares. Pag lumampas sa 3, ang tawag dyan, wide QRS. Okay, wide QRS. So, ibang storyline pag wide QRS. Laging narrow QRS tayo kasi yung normal. Sa normal muna tayo bago tayo mag-abnormal. So yan, si T-wave is the resting phase of the cardiac cycle. Now let's look at how do we interpret the ECG. So I'm not asking you to be like the cardiologist or internist. No? Tingnan lang natin paano magbasa ng heart rate. Na-addict ako dito. Sarap. Galing Cambodia. Mental. Na-addict ako dito. Wala namang walang shampoo. So heart rate, rhythm, presence of P wave, PR interval, at saka QRS complex. Doon lang tayo sa 5. Makuha mo na yung 5, kuha mo na yung ACLS. ECG. Sige. Pag nag-compute sa heart rate, simple lang. Multiplication yung the second strip. Okay. Tingin natin. Tingin sa... Usually, ang ECG, makikita ka ng broad mark. Maliit, broad mark. Yung broad mark na yan to another mark is 5 according to 1 second. Sabi ko inyo kanina, kasi ang big box is 20 times is 1. So, by 3 seconds. Another marker, 6 seconds. So, tingin ka lang sa ECG, mo lang may tatlong broad mark. May tatlong broad mark corresponds to 6-second lead. Lahat ng pumasok na RS, bilangin mo lang yan, i-times 10 mo, that is the heart rate. Ilan to? 1, 2, 3, 4, 6, 7. Oh. RS times 10. Easy. Maraming naiinis. Pag ito, topic ko to sa ACL, pag ALS, hindi ACLS. Ang ALS, lahat ng advanced life support, kinukuha yan for 4 days. Lahat dyan. 4 days, stuck yan hanggang gabi. Nagraran lang kayo, diploma for ALS. Maraming, ipa-cut down mo, gulong itong cellphone ko, ipa-cut down mo, ang galing. Cut down, no? Cut down, cut down, venous cut down. Ala. Chest tube, kuha. Wala ko nakita problema. Talaga, ano. Pero, pagdating sa ECG, patay. Kahit doktor, ano sila, para umakyat sa Calvary, no? Yung Golgotha. Alam niyo, sino nakapunta sa Israel? That is what we call Via Dolorosa. Dolor means pain. The pathway of pain. Yun lang, pag akyat mo doon, ako naman na, I was disappointed. Pag akyat ko, pagdating ko, where's Golgotha? Napako si Kristo. Wala. Ginawang simbahan. Punong-puno. Hala, siksikan ka doon. Hindi ko alam, kapag hawakan mo yung Golgotha na rin, hinawakan ko rin. Wala. My golly. The religion becomes a economic institution na people will go there to pay on what, no? Ang nakakainis. Leave the Golgotha be. Wala na ako nakitang Golgotha. Parang gano'n. Pagdating sa ECG, it's like walking to Golgotha. Okay. Now, moving forward, we detect rhythm. So, ang rhythm natin, irregular or irregular, regularly irregular, irregularly irregular. So, 4. Pero mainly, regular, irregular. Okay? Tingnan nyo ha. Regular saka irregular. 1 and 2. Regular saka irregular. 3. Regularly, irregular. Irregular siya pero may regularity. Okay. Worst is irregularly irregular. So, paano 'yon? Anong dating? So, titingnan natin paano 'yon? So, balik ako dito. Tumingin kayo sa strip R to R. Pareho ba ang distance ng R to R ng R to R? Yan. Pag pareho ang distance or may little variation of 0.06 second, interval ng 0.06, paano yun? Less than 2 small squares. Di ba ang isang small square is 0.04. Pag nagdagdag ka ng points ng isang small square pa, 0.08 na yon. I-less than mo konti. Yan yung 0.06. Meaning 1.5 small squares. Pag may lumampas doon na R, that's the term irregular. Okay? Yan ha, lumampas doon. So, paano ang natin? Paano ang basihan? Ako, tinitingnan ko lang itong R to R wave. Yan. So, isang tingin mo lang, R to 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 R. Equidistant to each other. Wala na maraming storya. Alam mo, uy, regular yan. Okay? So, kanina, rate, ngayon rhythm. Then let's go into what is it? Is there like a P wave? Okay. So, tanungin natin ang sarili natin. Hey, may P wave ba yan? Let's ask ourselves. Okay. So, tingnan natin kung may P wave. Balik ako doon sa wave, balik ako dito. Di ba? Ito, P, Q, R, S, T. may P wave. Therefore, it's a sinus rhythm. From the word sinoatria, sinoatrial node, SA node. Pag doon nag-fire, may P wave. Pag may P wave, ang tawag sa rhythm is a sinus rhythm. Yan. Okay. Pag wala kayo na rhythm, ventricular rhythm, I don't know. Let's check. Or a junctional rhythm. I don't know. Let's see. But that's absolutely not a sinus rhythm. Okay. Let's go into PR interval. PR interval ay dapat 0.12 to 0.20. What's 0.12? How many small squares? 3 small squares. 0.04 times 3, 0.12. Hanggang 0.20, 5 small squares. 5 times 0.040, 0.020 is 5 small squares. Yan. Ganyan ang laro dyan. So, tingnan natin kung sakto. Pag lumampas sa PR interval, lampas ang layo. Kunwari, 6 small squares, it's called a heart block. May heart block siya. Lumampas na sa 5, 3 to 5 small squares. Okay? Sir, meron bang less than 3? Meron po. Ang tawag natin dyan ay early takeoff. Nakikita natin yan sa Wolff Parkinson White Syndrome, WPW. Yan. Mga nag-addict-addict dyan. Saan makakita ka ng early takeoff. Pag pitik ng P, wala ka ng interval. Pag pitik ng P, umangat na. Diretso sa R. Ang tawag doon early takeoff. Ang lapit. Ang problema dyan, kulang yung feeling ng blood to the ventricles. Sumirit. So nakikita sa Wolff Parkinson White, WPW syndrome. Yan yung ECG reading niya. Okay. Then we go into QRS complex, which is no greater than 0.12 or 3 small squares. Pag lumampas ng 3 small squares yan, wide QRS na yan. Okay? Story yung utak ko. Now, merong ganitong rhythm. Oh. Kailangan, pag nakita kayo very sharp, yan. Although may P-wave siya, pero sharp. Wala yan. Sira ang ECG mo. Ibig sabihin, artifact. Anong cause ng artifact? Nagmo-move ang pasyente, loose or defective electrodes, improper grounding, yan. Faulty ECG apparatus. Tapon niya na. Tapon niya na ECG mo. Tingnan mo itong ECG ko. Ano yan? Monophasic yan, pero kapuhay ng mga tao. Kahit pa hanggang ngayon. Naghintay nga ako, mayroong sponsorship sana na may basic eh. Hindi nagtuloy si Zon, baka mayroong kakasa na masponsoran. Okay. Ito naman yung balita. Kaibigan ko, namatay daw. I don't like to react. Sorry ha. Ay, nako. Now, let's go into rhythms. When do we say like brady or tachy? Siyempre, pag brady less than 60, but if it's 60 to 100, that's normal. And then tachy is 100 up. Tandaan nyo, ang sinus is only up to 150, 160. When the rhythm goes up way beyond the 150, 160, that's not anymore sinus in origin na tachycardia. It can be like atrial tachycardia. So sinus rhythm is SA node 5. Pag atrial rhythm, tingnan nyo ang cursor ko ha. Tingnan nyo cursor. Tingnan ko cursor. Okay. Atrial, SA node fails. Wala na si SA node. Ang impulse ay nanggagaling kay atria. Pwede sa internodal tract or pwede sa AV node junction or even sa walls ng atrium. Pag ventricular rhythm naman, well, ang firing mo ay nasa ventricles. Magtanong kayo, bakit ganun siya? Well, there are 3 kinds of muscles because the heart is a muscle. The skeletal muscle, okay? Yung mga muscles ng ating vessel at yung cardiac muscle. Pasingutin nyo lang ako. So, ang cardiac muscle ay para siyang skeletal muscle except na self-excitatory. So, kung tanggalin nyo itong aking muscle dito, flexor, boom! Makikita nyo, tinanggal niya. Muscle lang siya. Tanggalin yung heart ko, boom! Paglabas ng heart ko, makikita nyo, nagbibit yan. Until maubos na ang metabolites, mawala na. Okay. Pinapakita ko palagi yan sa mga estudyante ko sa bayawak. Although, bawal to. Kasi dati, nagtuturo ako maghuli ng bayawak. How to entrap sa survival medicine. So, kinakatay namin yun. Minsan buhay pa, kakatayin yung bayawak. Tinatanggal ko talaga intentionally yung heart. Pag tanggal mo sa heart, nagbibit pa talaga. So, pinapakita ko, that's because the heart is self-excitatory. Okay, mandiri. Ang special, isa sa natutunan ko, survival medicine. So, medyo weird, no? Doktor ako, nagtuturo ako ng, yeah. So, weird nga ang aking kinuhang specialty. Kasama doon, manghuli ng bayawak. Pero ang pinakaayaw kong bayawak hulihin ay yung sa Malaysia. Kasi ang bayawak nila parang buhaya na kalaki. Kasi walang kumakain ng bayawak doon, bawal sa Islam daw. Ngayon, so ang lalaki. Kaya sabi ko nga doon sa mga yung bayawak na yun, sobrang laki, no? So, tinuro ko manghuli doon. Hirap hulihin kasi parang buhaya, ang bigat. So, pag tinanggal ko yung heart, nagbibit yung heart. Ganon din ang heart natin lahat. Pag tanggalin, magbibit yan. Yung biglaan mong tanggalin, tanggalin mo ganun, bibit yan. Yan. Because hindi siya yung mga smooth muscle tissue saka yung skeletal muscle. Iba yung smooth muscle. Ang smooth muscle, hindi siya striated. Ang skeletal striated. Cardiac muscle is striated pero specialized lang. So si ventricle, kung wala na si atria, wala na si SA node, si ventricle mag-fire, wide QRS na ang makikita. So let's go into sinus rhythm. There are four kinds of sinus rhythm. Okay. Ngayon, what's the rate? Pakisulat. Kasi mamaya mag-exam kayo, mag-practice na kayo sa chat. Kasi mamaya, ang exam chat, sa chat lang. Tapos minumonitor lang yung name. Hindi na tayo kung ano-ano dyan. Ito na yung name. Mag-exam sa ECG, tapos tingnan natin kung sinong papasa. Ilan ang rate? Kadali lang isulat sa chat. Ilan ang ano ulit ang regular? Ulat ulit sa chat. Isang tingin lang kuha na kagad yan. Sumagot, nahirapan. Grabe, kadaling tanong. Okay, regular, very good. My next question, is there P-wave? May P-wave ba? Yes lang. Yes or no lang sa tanong. Hindi pa ako nagtatanong ng rocket science. Kung merong P-wave. Yes. Ang dali. PR interval within normal range? Yes or no? Normal range ang PR interval? Yes. Very good. QRS, narrow or wide? Yes, ang sagot. Tinanong ko kung narrow or wide, ang sagot yes. Narrow, very good. So ladies and gentlemen, with a 70 to 80, regular ang rhythm, P-wave present, PR interval normal, QRS normal range, QRS is normal. It's called a normal sinus rhythm. Yan. Di ba? Ang dali lang ng ECG. Okay, ito. 1, 2, 3, 4, di 40. Is there P wave? Yes. PR interval, sakto. Tingnan natin ang equidistance. Uy, the regular rhythm. P wave, yes. PR interval, sakto. QRS narrow. Sinus brady. Kompletohin na, huwag kayo magsabay ng sinus rhythm, normal sinus rhythm. Kasi, pag sinabi kong sinus rhythm, a bradycardia is a sinus rhythm. Brady nga lang. Ang tachycardia is a sinus rhythm, tachy nga lang. Kung normal ang rate, normal sinus rhythm. Kompletohin. Dito ko si baba. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. 130. Tingnan ko ang R2R, equidistant, regular, P-wave, yes, PR interval, normal, QRS narrow, sinus tachycardia. Dali lang. May sinus arrhythmia. Paano ang sinus arrhythmia? Ito yun. Kunwari, 70 or 80. Biglang ito, lumayo konti. Lumayo siya. Tapos bumalik ulit sa normal. Lumayo siya. Ang tawag doon, sinus arrhythmia. Okay? It's not a killer. Don't worry if you have sinus arrhythmia. Usually, mga athletes, mga teenager, may gano'n. So, there are 4 types of, so madali lang, no? Normal sinus rhythm, sinus tachy, sinus brady, and sinus arrhythmia. So, there are 4. Okay? Dito sa presentation ko, 3. Dinagdagan ko isa. Now, let's go into atrial rhythm. Kaya nagkakaroon ng atrial rhythm. So, ang atrial rhythm, kapag wala na akong sinus fire, no more sinus, the origin of the firing is not anymore in the SA node. It can be somewhere in the atria, it can be in the internodal tracts, can be anywhere. Basta nasa itaas. Ang QRS ko, narrow pa rin. Yan ang difference. The QRS is still narrow. So there are 4 atrial dysrhythmias or sinus or atrial rhythms. So ano yung 4? 3. Atrial flutter, atrial fibrillation, and supraventricular tachycardia. Okay, let's look at this. What's the rate? 1, 2, 3, 4, 5, 6, 7, 8. 80. What is the rhythm? Titingnan ko ang distansya ng R to R to R to R to R. Oy, regular. What is where is there P wave? Wala. Hindi ko alam saan si P wave, but actually these are all P waves. Pero regular firing. Other than SA na sila. Pero nagpa-fire. Makikita mo ngayon, nagpa-fire si P wave. Hindi ko alam saan si P wave. Hindi wala akong PR interval. Ang next tatanungin ko, QRS, narrow. So lahat to narrow. If I have this kind of rhythm na mukha siyang lagari, sawtooth in appearance, it's called a flutter. Wala nang ibang rhythm magbibigay sa akin ng sawtooth appearance if it's a flutter. But, is this delikado or not? Hindi po yan delikado. Bantayan lang natin, huwag tayong mag-create ng imbolay. So, binibigyan lang natin ng mga clopidogrel dyan or in my time, ina-aspirin namin to. Another thing, ito ang tawag 3:1. Merong 4 na sawtooth tapos isang QRS. 4:1 yun. Okay? Ang ayaw nyo lang sa flutter, kapag nag-2:1 na yan, or nag-1:1, SBT na yun. Nag-1:1, ang tawag doon, actually, hindi ginagamit ng word 1:1, pero dumikit na yung QRS, ang tawag noon, rapid ventricular response. Atrial flutter, biglang bumilis, rapid ventricular response, hindi na 3:1 or 4:1, naging 2:1, naging 1:1, parang SBT na siya, no? Yun ang ayaw niya. Mapapagod si heart. Rapid ventricular response, okay? So, flutter. Then we go into this. Tingin. Tatanungin ko ulit, pakitanong sa chat. 1, 2, 3, 4, 5, 6, 7, 8, 9, 90. Ngayon, ang tanong ko, anong klaseng rhythm? Pasulat sa chat. What kind of rhythm? Hintay ako. Irregular daw. Okay. Masanay kayo magsulat sa chat kasi sa exam yung mamaya chat kayo lahat. Okay, so tatlo na sabi irregular. Okay, sagutin ko na. Walang tamang sagot na nakakuha. Walang tamang sagot. Sorry. Ang tawag sa written na yan, tingnan nyo ha, malapit. Tumingin kayo dito sa cursor ko. Cursor. Malapit. Lumayo. Sobrang layo. Medyo malapit. Malayo. Malapit. Medyo malayo. Malayo. Paano naging irregular yan? Iwendang yan. There is a right term there. Yeah. It's an arrhythmia. Anything na abnormal ang rhythm, generally it's called arrhythmia. Okay. Arrhythmia. So, hindi siya arrhythmia. I'm asking for what kind of rhythm? Regular rhythm, irregular rhythm, or irregularly irregular rhythm. Ang tawag dyan, irregularly irregular rhythm. The only rhythm na magbibigay ng irregularly irregular rhythm is an atrial fibrillation. Tandaan niyan. Sigurado yan sa exam, sa ECG reading. Okay. So 90, rhythm is irregular, irregular. Is there P wave? Wala. Wala. Walang PR interval. QRS narrow. Delikado? Hindi. Bigyan lang natin yan para hindi magkaroon ng emboli. Ano pa ang pwedeng gawin? Wag lang siyang bumilis ang QRS response. Pag meron akong atrial fibrillation, tapos bumilis yung tibok ng bilis ng pick up ng QRS, rapid ventricular response, RVR, yun ang ayaw ninyo. Okay? Next, ito yung pinakaayaw na. Eko, hinahabol ako nito. Lagi akong hinahabol ng rhythm na to sa mga pasyente. This is around 150 up to 250. Okay? Ang atrial rhythm mo, more than 150 up na. Ang ventricular rhythm mo, 150 up. Regularly, irregular, no? P-wave, none, PR interval, QRS, narrow. Pag nakita kayo ng ganyang rhythm, huwag niyong patagalin. Kasi maya-maya mag-arrest yan. Kasi sobrang bilis ng tibok ng puso. Hindi na yung makapagbuga ng dugo. Huwag niyong patagalin yan. So yan. It's called supraventricular tachycardia or paroxysmal supraventricular tachycardia. Saka ko na kayo turuan paano minamanage siya pagdating natin sa pharmacology. Ngayon, SA node or yung atrial wala na, yung junctional wala na, hindi na, they fail to initiate impulse. Ang impulse ngayon is shoulder na ng ventricle. So there are quite number of meron namang iba na normal pero merong ventricular response like PVC. NSR, may naligaw na beat, PVC or extrasystole. So walang problema yun. So ano to sila? Ito yung PVC, BTAC. Pag magsabi kayo ng BTAC, dalawang klaseng BTAC. Monophasic, monomorphic, isang morph, isang form, monomorphic, and polymorphic. So ventricular tachycardia, monomorphic. Then ventricular tachycardia, polymorphic, which is your torsade-poa. Ventricular fibrillation, asystole, yung flatline, saka pulseless electrical activity. Merong movement sa ECG pero walang pulso. Okay. Tingnan natin si extrasystole. So ito, meron lang akong ST depression, no? ST depression, pero may extrasystole. Okay? Extrasystole. So ayan, wag lang siyang sumirit ng maraming PVC, hindi siya maganda. Ito naman, ventricular tachycardia, wala ng P-wave, medyo regular konti tingnan, isang forma, so monomorphic. Okay, monomorphic. White QRS na lahat yan. Okay? So, una, may pulso pa yan, pero hindi katagalan, mawawala ng pulso, mag-a-arrest. Siyempre, wala na akong PR interval, QRS ko, why? Pag tachycardia na polymorphic or torsadipoa, pabago-bago yung forma. Pwedeng ganito, biglang bumago ang forma, biglang magbago ang forma. Ito, biglang nagbago forma. Akala mo, ito, typical na typical. Pag ganito na nakikita mo, matatakot ka na. Arresting na yan, papunta na. Mawawala na pulso niyan, mabilisan. Then, ventricular fibrillation, dalawa. Ito, automatic, wala nang dugo isisipa. Bagsak ng tao dito. Ito yung coarse ventricular fibrillation. Ito yung fine ventricular fibrillation. Then, ito asystole. Okay? Although, hindi totoong asystole ito kasi ang asystole, makikita mo, may konting movement. Pero siguro, para makagawa ng presentation, ginawa nila, inon yung ECG, pinaran yung strip, ang ano na, pag nag-run ka kasi ng strip, mag-print ka, guguhit lang siya. So, yan. Okay, ganito yun, guys. Kunin ko tong ECG. Pag nakikita kayo ng asystole, ano kung makikita nyo to? Ah. Okay. Sige lang, Mar. Okay lang, Mar. Tadaan ka. Sige lang. Sige ka, yuko naman. Tayo lang. Pwede kang dumaan. Okay. So, ano ko muna, i-set ko sa, ay, nako. I-set ko sa, guys, i-set ko sa paddles. Sa paddles, ito. Home search. Ayan. Paddles. Hindi. Okay. Lead. Okay, sa lead. 2, 3. Sa 2 ako. Okay. Tapos, ito. Selector. Hindi ako familiar. Ay. Ayan. Sorry. Sorry guys, hinanap ko yung paddle eh. Ay, hindi pala nakakabit yung paddle ko. Kaya. Ay, nako. That is why. Lousy. Okay. Ayan, tanga-tanga ako dito. Current charge, select. Ay, nako, umanap si paddles. Saan ba yung paddle dito? Dapat naka home screen. Home screen. Ayaw. Tagal na wala sa akin to. Nakakalimutan ko. Meron tong paddle sign. Select advisory. Connect ECG leads. Analyze. Connect cable. Yun. Saan ka ba? Advisory. Anyway, no waste of my time to. Pag meron kayong asystole, ang pindutin niyo lang, hanapin ko. Sorry hanapin ko lang. Pindutin niyo, meron kasing sign yan na nakalagay doon, lead, L-E-A-D. Ito wala kasi nandito sa loob ng computer niya. Hindi ko lang mahanap saan. So yung lead, naka-default sa 2. No? Naka-default sa 2. So, pag nakita niyo sa 2, ano ba, yan, lead 2, naka-default sa 2. Hindi ko lang kung nakikita niyo. No? Naka-default sa 2. I-check niyo sa 1. Display ng ECG, ano siya? Flatline. Then, lipat kayo sa 2, flatline pa rin. Then, lipat kayo sa 3, flatline pa rin. Then, sa paddle sign kayo. Lipat kayo sa paddle sign, yun yung wala dito. Paglipat nyo sa paddle sign, flatline pa rin, balik kayo sa 2. Pagbalik nyo sa 2, balik ko sa 2. Yan. Flatline. Saka kayo magsabi, flatline, start compression. Yan. Huwag kayo magsabing asystole ka agad. Bakit? Malay mo yung ECG natanggal lang siya. So yun yung assurance mo na, oops, let's make sure na hindi siya na-detach na lead. So yan yung sa asystole. Ngayon, if you have any rhythm na other than ventricular fibrillation, other than asystole, other than ventricular tachycardia, usually mga 3rd-degree heart lang. Tapos, walang pulso, ang tawag doon, pulseless electrical activity. Okay? Yan yung PIA, pulseless electrical. So, CPR lang tayo dyan. Now, let's go into, may questions, guys? Questions? Wala. So let's go into heart block. Ay, nako. Heart block. Meron tayong first degree AB block, second degree Mobitz type 1, saka second degree Mobitz type 2, saka third degree AB block. Now, let's review again. Count natin 1, 2, 3, 4, 5, 6, 7, 70. What's the rhythm? Okay, equidistant, regular rhythm. Is there P wave? Yes. PR interval? Uy, lampas 1, 2, 3. Lampas 5. Therefore, it's a first degree AB block. QRS narrow? No problem. Is this patient okay? Yes, no problem with this patient. It's not a problem. Na-delay lang. Ang feeling, medyo na-delay lang konti. But, okay lang siya. Now, let's go into second degree AB block. Ang tawag nito, ito na ang Mobitz 1 or Wenkeba. Tingnan natin. PQRS, P, lumayo na si QRS. Equidistant, biglang lumayo. Equidistant, biglang lumayo. Yan yung regularly irregular. Medyo nakakalito na, no? So, tingnan muna natin. What is the rate? 1, 2, 3, 4, 5, 6, 60 per minute. Rhythm, irregular. Is there P wave? Yes. QRS, PR interval? Oh, there's a problem. QRS, narrow. So, balik ako sa PR interval. Tingnan nyo ang PR interval ito. PR interval is normal. Pagdating dito, nako, malayo na. Pagdating dito, nako, sobrang lumayo. Pagdating dito, no QRS. Meron siyang tinatawag na the drop, QRS drop. Yeah. Yung atria, unaffected siya. Tapos yung ventricle rate is usually slower than atria. Okay? Now, there is a gradual lengthening of your PR interval and then there is a drop bit na kung saan there is sinus fire but no subsequent ventricular response. Ito yon. Babalik ulit siya dito. Okay? Dagdagan ko pa. Oh. P, QRS, T, P, lumayo, QRS, T, P, wala. 2:1. Ito, 3:1. Dagdagan ko pa. Ito ang 4:1. 4:1. PQRST, 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 P-drop. 4:1 yan. Patient is not yet an emergency. Okay? So that is the Wenkeba or second degree type 1. Let's go into second degree Mobitz type 2. Ito yung problema. P, wala nang pattern. P, QRST, P, drop, P, drop, P, QRST, P, QRST, P, QRST, P, drop, P, QRST, P, drop, P, drop, P, drop. Ang binabantay lang natin to, yung the more maraming drop, the more may hirapan ni si heart. Bakit? 1, 2, 3, 4, 5. 5 na lang yan, no? Eh kung mag-4 pa yan, eh kung mag-3 na yan, wala nang ventricular response. Narrow QRS ka pa rin, pero may mga P na no subsequent QRS complex contraction. Ventricular contraction, sorry. Yan. This is an emergency. What to be watched? This patient must be admitted. Potential for for implant. Yan. Then the third degree AB block ay absolutely hindi nag-uusap si atria, hindi nag-uusap sa ventricle. Equidistant ang ventricle, equidistant ang distant. Tingnan mo si atria. Atrium, 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 nasa T-wave, atrium, 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 nasa QRS. Nagpapire si atrium kanya-kanya, nagpapire si ventricle kanya-kanya. Wala nang demarcation. Yung AB node mo hindi gumagana. Hindi na siya maganda. Ang pasyente dito, matutumba na yan, wala na yan. So, pinipaste na natin. Okay? Third degree. Ito pa, third degree AB block, makikita mo. P-wave, P-wave, si P-wave nasa QRS. P-wave, P-wave, ayun si P-wave. P-wave, 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 P-wave. QRS or equidistant, kanya-kanyang fire. Ito yung typical, YQRS. P-wave, P-wave, si P-wave, P-wave, P-wave nasa QRS. P-wave, P-wave. Si QRS naman, naku, 30 na lang. Wala, bagsak na yung tao dito. So, yeah. Then, one is artificial pacemaker. So, merong machine siya sa loob, meron siyang pacer, implant, merong QRS response, no? Yan. So, ang nagbibigay ng beat sa kanya kasi wala na siyang SA nun is the machine. Yan. Okay, now let's go into exam. Tandaan nyo, atrial fibrillation with PVC. Hindi nyo nakikita si atrial fib, pero bantayan nyo, irregular siya. Alam nyo, AFib yan. Sinus brady, beta. Ito, mahirap to. Third degree heart block. Makikita mo, walang pattern. No? Ito yung asystole na tama. Yan. Okay, let's go into exam, guys. Pabilisan ang sagot sa chat. Imo-monitor ng WIPAM. Okay? So, pabilisan sa chat, monitor ng WIPAM. Tingnan natin kung makapasa o hindi. So, the more bibo kayo sumagot, at tama naman, di pasado. Pag hindi, ay. Okay. Ready? Ready ha? Pabilisan ha? I'm gonna count 12 seconds only. Sobrang bait ko na. So, 1,000, 2,000, 3,000, kailangan may sagot kayo. Beyond 12, di na i-honor. Okay, number 1 is this. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 7,000, 8,000, 9,000, 10,000, 1,000, 2,000. Okay. Aha. Hindi, hindi 60 yung ang sagot ECG na. Okay, ito. Sabi ni Beverly, first degree. Sinus rhythm. Paano naging sinus? First degree AB block? Walang nakasagot. This is, tingnan nyo, PQRST, P. Hindi, it's not a sinus rhythm. Merong PO, pero walang QRS. Merong P, walang QRS. This is a second degree Mobitz type 2. Walang nakasagot. Next slide. Ay, kadali. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000. PVC. That's not PVC. White QRS siya, pero tingnan mo, regular rhythm ng QRS. Sinus brady. Paano naging sinus brady? P-wave, 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 walang QRS. Kasunod, parang sinus brady. Wide QRS nga. Si QRS mo, wide kanya-kanya. Okay, walang nakasagot. That's a third degree AB block. May nakasagot si Elian. Okay, very good. Isa. May isa ng ano. Next. Yan. Okay. Cut, cut, cut. Okay. No more. Walang kasagot na naman. May problem tayo dito. Okay, that is an atrial fibrillation. Ang flutter ay sawtooth in appearance. Yan, no? AFib. May nakasagot na kahabol. Dalawa. Okay, sige. Habol dalawa. Okay, close. Next. Ayan. Okay. That's not atrial fib. That is NSR. That's not even a third degree AV block. Grabe. NSR lang. Marvin, kompletohin, hindi sinus rhythm. Normal sinus rhythm. Next. Very good. Marami nakasagot. Sinus tachy. Next. Ito, mahirap to. 2 points. 2 points. Very good. Sige. Grounded. Artifact tawag. Pero sige, i-ano ko yung grounded. Rhythm is artifact. Ang resulta yan kung grounded ang ECG. Pero rhythm. Pero sige, ibigyan ko ng points. Marvin. Next. Let's see. Sorry, nag-charge ako ng defibrillator. Okay. Sige, namamonitor nila sino ang nakakuha. Okay, good. Flutter. Next. Oh, 1,000, 2,000, 3,000, 4,000, 5,000. Okay, cut. Walang nakasagot. Okay, cut. It's spacer. Naka-pace. Bakit nagtatanong? Dapat sagot, hindi tanong. So, no point. Next. $10,000, $11,000, $12,000. Walang nakasagot. Ba yan? Cut. It's a third degree heart block. That's not a BFib. Sus, grabe. Ano ba yan? Ito. Cut. That's not sinus tachy. That's NSR. Paano naging sinus tachy? 1, 2, 3, 4, 5, 6, 7, 8, 9. 90 lang. Sinus tachy. Next. Ito. Cut. NSR. Tama. Next. O yan. Cut. Galing. Polymorphic beta or torsa di pois. Okay, good. Sige. Next. Yung mga names niyo, kinukuha lang ng ano yun. Cut. That's not sinus tachy. That's SVT, PSVT. Okay, good. Next slide. Hmm. Cut. Okay. Very good. NSR yan. Next slide. Pambawi. Cut. Grabe. Dumami yung ano. Next. May dalawang sagot yan. Demarcation yan. Border na yan eh. Cut. Okay. Pwede tayong mag polymorphic dyan. Polymorphic beta or course, papuntang course BF. Yan, nagde-demarcation na siya. So both sides kayo, magtatama kayo. Okay, bahala na yung mag-check na we pump dyan. Okay, next slide. Cut. Okay, next slide. Ang sagot dyan, PVC. Ito. Cut na, cut na. Huwag na kayo humabol. Cut na eh. 12 seconds. Saka kayo, hindi kayo makapans ng 12 seconds. $6,000, $7,000, $8,000, $9,000, $10,000. Cut. That's grabe. Paano nag-sinus written? Okay. Oh, wala na. Cut na. Cut. Cut. No more. It's a third degree AB block. Ito. Ventricular fibrillation. Paano naging ventricular fibrillation yan? May narrow pa ako. Ito, artifact lang yan. Huwag niyong pansinin, ito yung main, no? Cut. That's sinus tachycardia. Next slide. Nako. Biphasic. Yung rhythm, yung rhythm, I know it's kung gusto nyo kompletuhin, okay lang. Pero kung maghiwa-hiwa kayo ng sagot, parang hirap. Noted, it's a sinus brady. Sinus brady with, ganon. Hindi lang yung sinus bradycardia. Mas prominent dyan. Cut. Ang tamang sagot ay sinus bradycardia with PBC. Saka na yung mga trigemini na yan, bigemini. Next slide. Ito, dalawa sagot. Ano to? At ano to? Dalawa sagot yan. Yan at yan. $4,000, $5,000, $6,000, $7,000, $8,000, $9,000, $10,000, $11,000, $12,000. Cut. It's not artifact. Okay, cut. That is ventricular fibrillation and defibrillation. Dinifibrillate. Okay, next slide. Oh, ito. $8,000, $9,000, $10,000, $11,000. Cut. Walang nakasagot. Atrial fibrillation. Okay, next slide. Yan. Hypervoltage lang yan. Pero kung titingnan mo, ano yan siya? Hypervoltage lang. Cut. Okay, isa nakasagot. That is NSR. Next slide. Iyan second degree. Ito, wag yan. Ulit-ulit. Okay, ito. Wag to wag niyong sagutin yan wag. Ito lang siya. Wag niyo nang pansinin. Wag niyong pansinin to. Ito lang. Cut. Lang nakasagot. That's an atrial fibrillation. Irregular rhythm. Ito. Bonus round. Ano naging NSR yan? Cut. That's not It is not NSR. 1, 2, 3, 4. Paano NSR yan? Okay, cut na. Sinus brady yan. Okay, next slide. Bonus round ulit. Balikan nyo lang, what is the rate? What is the rhythm? P-wave, meron ba? QRS, narrow ba? Nakalimutan niyo yung tinuro kanina eh. Cut. Okay. Sinus tachy, very good. O, ito. 2 points. Pag may makakuha niyan, 2 points siya. Pambawi man lang. Yes, is a sinus brady. Pero anong nag-cause? Bakit nag-sinus brady siya? Anong klaseng kumpletohin nyo? Pag second degree, type 1, type 2. Ano ba siya? Type 1, type 2. Cut. Okay. So, that's a second degree, type 1. Okay. Next slide. O, ano yan? Cut. Third degree AB block yan. Very good. Next slide. Last slide is this. 1,000, 2,000, 3,000, 4,000, 5,000, 6,000, 7,000, 8,000, 9,000, 10,000, 11,000, 12,000. Cut. Okay. Ang tamang sagot, cut na. No more. First degree AB block. Oh, malayo si PR interval. Okay? So, our next presentation, our next topic is about fluid. Bilisan lang tong fluid kasi this is not really a main topic. Meron lang ibang emphasis dito sa fluid and electrolytes for ACLS. Merong ine-emphasize lang. Okay. Now, I'm not gonna discuss about osmotic and oncotic. Approximately 70% is water. Mas medyo dramatic sa mga bata, sa baby. Kasi sa ratio and proportion, mas mataas ang fluid sa kanila. Kasi growing sila eh. 75 to 80% sa newborn. 20% of fluid loss in the body. For example, 5 liters ako. Mawalan ako ng 1 liter. Deadly na yun. Now, we have an intracellular fluid compartment of which the cation is potassium, yung pinaka-influencer niya. And extracellular, which is divided into intravascular sa loob ng vessel, interstitial surrounding the tissue, and then transcellular sa mga joints, no, sa cerebrospinal fluid. Your extracellular cation is sodium. Ngayon, sa intravascular natin, i-deep dive natin, yan, may plasma ka, which is composed of protein para maghakot ng tubig, no, and other amount of substances. Okay? Sa interstitial naman, ito yung reservoir. No? Galing sa intravascular, papunta sa cell, dadaan mo na ng interstitial. Sa transcellular, ito yung 1% of your ECF, extracellular fluid. And it serves usually parang mga shock absorber. In between bones, no? Yan yung fluid para merong, pag nagbanggaan yung bone mo, masakit. Lalo na yung cerebrospinal fluid. Pag ang brain bumangga sa cranium, masakit yan. Thanks to the cerebrospinal fluid, it serves as a shock absorber. Now we have this osmosis, which is a water potential. It is about the movement of water through a selectively permeable membrane from an area of low solute concentration to an area of high solute concentration. Ito yung until it reaches an equilibrium. Simultaneously, diffusion naman talks about solute. It is solute potential. So maraming solute sa kabila, ililipat ka sa kabila, pantay. Therefore, your osmosis and diffusion can occur at the same time and they don't need energy requirement. Yan. Ang active transport, pinaka numero 1 is sodium potassium pump. Yan ang totoong nagmamahalan at may forever, si sodium potassium. Without potassium or without sodium, potassium is useless. Without potassium, sodium is useless. Sila yung kasi sa cell membrane mo, trabaho niya is exchange of sodium ions for potassium ions para more water is pulled into cell, tapos magkaroon ng balancing ng ECF sa ECF mo. Then you have the insulin and glucose. Si glucose, pag na-release, pag nasa loob ng vessel after galing sa intestine, ma-stimulate si insulin released by the beta cells in the islets of Langerhans. Siya yung magiging kotse from intravascular space to papunta sa cell upang dalhin si glucose. Except in the form of exercise, hindi kailangan si insulin. Pag pumunta si glucose papunta sa cell, sumasabay din si potassium. So, osmolality talks about hydration status, no, which is measured in the serum and in the urine. So, hindi ko na i-discuss to. Ang ano na lang is, anong fluid ba ipiprescribe? Para sa ACLS, 0.9 saline. Okay? So, mainly crystalloids and colloids. Pero i-breakdown natin, pag nawalan ka ng dugo, hypovolemia, which is one of the indicators of cardiac arrest, replace blood with blood. Then replace plasma with colloid. Resuscitate with colloid, pataasin ng BP. Replace ECF with saline, and then rehydrate the cell with dextrose. Yan lang yung rule of thumb, di ka na mawawala. So, let's go into solutions available in the market. Ginagamit natin sa ACLS, sa armada natin is the crystalloid 0.9 NSS. Sa colloid, ang ginagamit namin sa field ay haze sterile sa plasma sterile. Hindi kami nagdadala ng whole blood. Dati, nung nasa abroad ako meron kasi may ref yung aming helicopter saka ambulance. Of course, water and glucose for long range. So ito lang yung mga sets of fluids binibigay namin. Ngayon, anong mangyayari? If you look at this, I want you to look at this picture. So this is intracellular, diba? Sabi ko sa inyo, pinaka-main tubig sa katawan nasa loob ng cell kasi doon siya kailangan. Then ito interstitial, ito intravascular. Nagbigay ako ng blood, 2 liters of blood sa 3 liters of blood intravascularly. Ang mangyayari dyan ay 5 liters of blood. Simple. Nagbigay ako ng colloid. 2 liters of colloid, what will happen? 5 liters. Pero dahil colloid siya, high protein siya, sisip-sipin niya yung water sa interstitial sa cell. Tataas pa siya. Kaya ang colloid ay maganda ibigay pampataas ng BP except wala lang siyang oxygen carrying capacity. Nagbigay ako ng 2 liters saline, ang mangyayari 5 liters, pero si saline pupunta sa interstitial. Ang maganda kay saline may maiiwan sa intravascular, kaya maganda rin siya ibigay sa mga tao na merong trauma na pagdurugo initially, kasi nakakapagpataas pa siya ng BP. Yun lang, wala siyang oxygen carrying capacity. Nagbigay ako ng dextrose, automatically papunta sa intracellular. So, yan lang ang kailangang malaman ninyo. And then, itong ating potassium. Ang potassium, gusto ko lang i-discuss sa inyo kasi napaka-sensitive ng ating heart sa potassium. Pag mababa si potassium, mag-abnormal si heart rhythm. Pag mataas si potassium, mag-arrest tayo. Kasi reversible siya eh. Di ba? Yung mga reversible H, hypokalemia sa hyperkalemia. Pag hypokalemia, ang ECG mo, possible cardiac arrest ka. No? Pag hyperkalemia naman, tented T waves naman or peak T waves, cardiac arrest din. So sinusolusyonan natin. So saka ko na ibigay solusyon doon sa pharmacology. Calcium na magnesium naman, pag si magnesium ang problema ko, pag kulang ako, nagkakaroon ako ng ECG changes which is polymorphic ventricular tachycardia. Yan. So binibigyan natin ng mag-sulfate 1 gram to 2 grams. Okay? So yan lang ang ating fluid. Let's go to oxygen. The oxygen, kasi maraming mga tao, maraming hindi nakakaintindi paano ibigay ang oxygen sa ACLS. Okay. So, ang oxygen sa ACLS, ang oxygen, is sa green tank ninyo, 100% yan. 100. Pero pag deliver nyo, bumabagsak. Lalo na sa nasal kanila. Tingnan natin. So, let's start with understanding na dapat ang emergency oxygen is 15 liters per minute. Yan. Ang kanyang rate. Yung karamihan sa ospital ninyo, 10 liters via humidifier. Emergency oxygen has no humidifier. Okay. And then what delivery devices ang ating ilagay? Depending on the flow rate also. So number 1, nasal cannula, adult sa child. Ang 100% mabagsak ito 24 to 30 lang. Kailan natin binibigay? Sa patient without lung disease or sa chest pain. Yeah. So 1 to 4 liters per minute. Usually 3 ang optimum kasi magdadry sa nose ang 4 liters. Hudson mask or simple face mask, pwede tayo umabot ng 30 to 40. Ngayon, kapag ang inyong tangke ay nasa 10 liters, huwag nyo lang lagyan ng humidifier, ng tubig. Pwede ka magbigay ng 10 liters. No? Lalo na sa mga type 1 respiratory failure. Pero okay na rin yan. Kung walang iba, okay na, forgiven. Pero ang kaya niyang ibigay is 30 to 40 only. From 130 to 40. Then we have the Venturi mask, which is not common in this country, pero hindi yan sa ACLS. Binibigay lang natin ito sa mga COPD. So bawat jet, we call it the colored jet, no? Merong kaakibat na flow rate. For example, pag blue 2 to 4 liters, kapag yellow 8 to 10 liters. And yung 8 to 10 liters, you will enjoy 35%. Green ang pinakamalaki, 12 to 15 liters per minute ang kanyang flow rate, 60 ang kanyang ibibigay, yung green ito. So sa COPD natin yan binibigay kasi kailangan control ang ating delivery of oxygen. Non-rebreather mask is our emergency mask. So yung pinakita ko kanina, mask yan na merong reservoir. Ito yun. Yan. Meron siyang natanggal na yung mga bulbs dito. Walang makapasok na yan. Sa 15 liters flow rate, aabot siya ng 85 to 90. Oh, ayan na. So sa arrest, cardiac arrest, yan yung binibigay. Hindi nasal cannula. Yan. Okay. Non-rebreather mask. So ito yung non-rebreather mask. Hindi tayo gumagamit ng partial rebreather mask sa ACLS. Non-rebreather. Okay. Now let's go into therapeutic electricity. Don't worry, malapit naman. Inano ko lang para bukas, wala na tayong ganong problema. Therapeutic electricity, people, is ano yun yung defibrillation. No? Yung pagbigay natin ng defibrillator, yan yung therapeutic electricity. Nasaan ba yung aking slide? Saglit ha. Yun. Therapeutic electricity. Saglit. Pinapatay ko lang yung ibang labo-labo yung aking slide. Okay, therapeutic electricity, where are you? Uy, bakit wala ka? Handa. Share screen. Ayun, kita rin kita. So, ito ay about defibrillation, cardioversion, at saka transcutaneous pacing. Plain CPR, let's start with defibrillation. Plain CPR is okay. Pero pag nagbigay ka ng defibrillation, umakyat ng 74. So yung survival rate, no, lalo na pag binigay natin 3 to 5 minutes of collapse, 50 to 70%. One of the greatest inventions of man is a defibrillator. So who gets defibrillated? So number one, forced ventricular fibrillation. Meron pang VTAC, remnants ng VTAC. Then ito fine, ito asystole, ito ang hindi pwedeng i-defibrillate. So nakita natin, ito ay monomorphic ventricular tachycardia. Sa lead number 2, biglang nag-shock ako ng 200 joules. Nabuhay ulit ang pacer ko except wala akong capture. Pero nag-normalize ang beat. So ayusin lang yung capture. Ayusin lang yung pacing nito. Nasira yung pacing. So defibrillation means you defibrillate, no? Whether you use monophasic, katulad sa akin, monophasic pa yan. And biphasic of 200, hindi siya jump start. No? Yung akala nyo, gina-jump start. No? No. Kasi may beat pa yung heart eh. So why, di ba sa kotse, ang gina-jump start yung ay dead battery. Ang heart mo hindi pa totally dead, nagbibit except wala lang sipang dugo. That's jump starting is not the right word. Well, wala talaga akong magawa. Sabihin na lang natin, alam naman electrocute para naman pinatay mo yung tao na electrocuted. No? Just defibrillate. Just make it like a common word. Okay? So, it's either you use the paddle, katulad sa akin, paddle, or pads. No? So, bahala kayo. Pero pag paddle, ang maganda sa paddle, may paddle pressure ka, may diin. So, yung diin mo, 25 pounds na nakatulong. Kung taba-taba yung chest mo, idiin ko ng 25 pounds, mas medyo malapit sa heart. Kaya ako, gusto ko talaga paddles. Naging ISO lang kasi yung pads para lang hindi ganong exposed ka sa danger. No? Now, again, ang nakaka-apekto dyan, pagbasa, kailangan malinis. Pag balahibo, tanggalin ng balahibo. Tapos, yung implanted device, iwasan mo. Although, lahat ng implanted device, dinesign niya nandito sa upper left. Now, again, ang positioning is sternum and apex. No? Sa bata, anterior, posterior. May manok, anterior, posterior. So, yan ang tamang posisyon ng paddles. Pag ikaw gumagamit ng paddles, you should be on the left side of the patient. Okay, sa left side ka para maganda ang diin. But of course, this is the pad. Walang problema naman kung paddle. Pad ang gamit. So, paddle or pad. Now, energy level, maglalaro sa dalawa. Pinaka-common ngayon, 200 joules. Tapos, luma, katulad sa akin, 360 joules. Okay, pag pediatric dose, 2 joules per kilogram. Now, so, what is the, bakit may manok? Papatay lang para mute. Now, there are two things that you have to know. We have the AED, Automated External Defibrillator, and we have the manual. So tayo po, sa hospital, manual tayo. Na hindi tayo nag-AAD. Kasi ang AD nang inimbento yan para yan sa common people. I mean, sa lay people. The word is lay people. Tayo po ay professional. Nurses, doctors, we are professionals. So, manual tayo. Pero yung mga bago ngayon, may manual with AED override. Ako, manual ako, plus may dalawa kong AED. So, yun. Kasi yung isa, dinadala ko, yung isa naiwan sa bahay para sa mother-in-law ko. Siyempre, matanda na sila. Now, yan po yung lumang-luma na. Ito yung ginamit ko early 2000, LifePack 10P. Okay, yan ang battery charger. Yan ang LifePack 12, katulad sa akin. Nag-charge sa baba, LifePack 12. And then, ito yung mga AED. Meron akong Zol. Yan, Zol na yan. Now, let's go into cardio version. So, yung cardio version ay para siyang defibrillation except ginagamit lang siya sa tachyarrhythmia, hindi sa arresting heart. So, katulad ito, heart rhythm ko, AF with rapid ventricular response. May presence of HASIA. Naalala niyo yung HASIA kanina? HASIA. Hypotension and or altered mental status and or signs of shock and or ischemic chest discomfort and or acute heart failure. Yan. So, and or. Pag may present doon, kandidato for cardioversion. Patutulugin ko kasi isa-shock ko. Pero siya hindi arrested na. Ipindutin mo lang yung sync SYNC. I-demo ko na lang yan bukas. I-demo ko siya. Pindutin yung sync. Pag the time na pindot ng sync, depende. Katulad nito, irregular, yung mga joules ko is around 100. 100 to 150. Yan. Pag gusto mo siya i-shock, nakatulog yung pasyente, hindi arresting ha, natulog siya, patulugin mo kasi hindi pwedeng i-cardiovert mo gising yan. Charging now to 150 joules. Charging. 1 ampere, 2 you're clear, 3 ampere, clear. Pag shock ko ngayon, yung machine, itatiming niya na nasa R-wave. Para during contraction, sumabay. Kaya tinawag na synchronize. Guguhit, idadat niya yung mga R-wave. So, anong idadat ng R-wave? Ganito ang dating. Yan o. Dinat-dat yan. Pag pinindot mo tong sync, SYNC, magdadat siya o. Pag tanggalin ko yung sync, pag 12 to. Pag dating, katulad sa akin to. Pag tinanggal ko yan, mawawala yung dot. So, pag nag-fire ka, i-fire mo itong shock na to, boom! Ang machine automatic magpa-fire siya nasa QRS. Kaya tinawag na synchronized cardioversion. So, sino ang kina-cardiovert? Yun yung mga SVT, yung mga atrial tachycardia, yung rapid AF, atrial fibrillation, rapid ventricular response. Pag narrow regular like an SVT, maganda ang 50 to 100 lang. Narrow irregular with katulad ng AF, atrial fibrillation with rapid ventricular response, 120 to 200. Pag wide regular, BTAC with pulse, 100 is okay. Pag wide irregular, no need to synchronize. Defibrillation yan kasi mabilis lang yan, magka-cardiac arrest na yan. So defibrillation na siya. So tandaan nyo lang, baka lalabas sa exam. So yan yung ating kina-cardiovert. Okay? So again, LifePack 20. Again, sinong kina-cardiovert? Yung mga yon at unstable na. Presence of hypotension and or altered mental status and or signs of shock and or ischemic chest discomfort and or acute heart cardiac failure. So, diretso na tayo sa transcutaneous pacing. Yung sa akin ay fixed. Ang gusto ko talaga ay demand. So, ang pacing ay ganito. Considered siya to be class 2A. Dati, pinipace natin ang bradyasystolic cardiac arrest. 2B siya. Tinanggal na. So, 2A siya ngayon, di ba, sa class of recommendation. So, paano ang transcutaneous pacing? So, nagbibigay ng electricity sa heart in series, pero hindi joules ang ginagamit, milliamperage na ang ginagamit para mag-beat yung heart. So, kailan ginagamit? Sinus bradycardia na hindi ma-resolve ng atropine or dopamine. Second or third degree heart block, yung sabi ko rin, second degree type 2 and third degree, kailangan yun. Junctional rhythm na hindi accelerated, idioventricular rhythm na hindi accelerated, na hindi umugra sa atropine. So, paano natin piniprepare? So, ang pasyente, i-prepare natin, patulogin natin. Pagtulog na, mag-start ako sa pacer at 60. Ibig sabihin, magpa-fire siya 60 fires per minute. Ang aking kuryente mag-start sa, pwede ako mag-start ng, mataas na yung 40, pero usually ako 40 ako. So may mga, ano lang, tutulog naman yan, ipino-40 ko kagad yan. So, walang nakalagay dito na 40. Baka mamaya, okay? So, i-pace ko. Pag-pace, pag-pace ko ngayon, ito pace of boom, meron siyang capture. So, dalawang capture. Pag pace ko, nag-capture yung ECG, pero yung aking pulse oximetry mababa, ibig sabihin, hindi siya nag-beat ng maayos. So, meron siyang electrical capture but no mechanical capture. Okay? So, ang gagawin ko, tataasan ko yung milliamperage. Kunwari, nag-start ako 40, increment of 10, taasan ko ng 50. Pag may mga ECG, pacer na merong sensitivity, pag umabot, for example, ang threshold ay nasa 7 millivolts. Ang ECG ko, yung heart ko nag-fire ng 10 millivolts. Mamamatay ang machine. Sa akin, wala. Ano lang siya, talagang demand. Asynchronous. Yun yung pangit sa machine ko. So, nawala ko. Yan. Mamamatay ang machine, tutuloy yung intrinsic activity of the heart. Sa akin, hindi. Dahil asynchronous siya, kahit may intrinsic activity, fire lang talaga siya ng fire. Ang problema nito, delikado to, lalo na kapag nag-R-on-T phenomenon. No? Kailangan, nagbabasahin mo, pag nakita mong ganyan na, hintuin mo na yung machine, manumanuhin mo, hintuin mo. Tingnan mo kung ano. Yun lang, manunood ka sa machine. Hindi katulad pag automated, hihinto ang machine. Sa akin, hindi. Manunood ako. Pag ganito na. Okay? So, depende, pag nagkaroon ng electrical sa mechanical capture, tinataasan ko yung pacer spikes. Kailangan may capture ako, ventricular capture. Okay. So, ano lang naman yun eh. Actually, sa simula lang, medyo may ilang ka. Kasi nakatry. Halimbawa, gusto kong bawasan ngayon, 3 milliamperage ako, merong capture, tapos maganda ang pulse ox ko. 2 milliamperage may capture. Binitawan ko sa 1, wala nang capture. Ibig sabihin, yung 2, ang aking, balik ulit ako sa 3 para mag-capture sa heart ko. Okay? So again, ito, tingnan nyo, kung ang threshold ay 7, ilagay ko sa 7. Ito, 1, 2, 3, 4, 5, 6, 7. Lumampas sa 7, 8, 9, 10, 10, mamamatay ang machine ko. So itong 1 millivoltage nito, 0.7, yun yung sensitivity. Kasi kaya ngayon, hindi katulad sa machine ko, pacer rate sa milliamperage. Sa bagong machine ngayon, meron pang millivoltage sensitivity. So ilagay ko sa 7, ang spike ng heart mo ay nasa 6, ang machine ko tuloy-tuloy magbibigay ng energy. Pero pag ang heart ay meron ng capability magbigay ng 10 or 8, mamamatay na ang pacer ko. Sorry with the word, mamamatay pa. Hihinto. Alam mo, pag Bisaya ka, medyo magulo-gulo yung Tagalog mo. Hinto siya. So yun yung maganda pag asynchronous. Malay mo, balang araw may mag-donate sa akin. Hindi, ayos. Okay, so that's the pacer. Yung sinabi ko kanina, yung sensitivity, 2.5, 1.5, yan. Depende. Okay. So, yan po yung pacer, yan, no? Kasi sina-charge ko sa ibaba yung pacer. So, yan ang pacer. Iba ang kanyang output. Pindot si pacer, tapos rate, pag pindot mo sa rate, tapos output niya in milliamperage. Pag start mo, mag-start na si pacer. Pag gusto mong hintuin, stop mo, pindutin mo lang yan. Pero pag meron pang sensitivity, iba yun. Ito, luma na yan ang machine mo. So, that's all there is for pacing. At least you have an idea how it's being done. Okay? Now, any question, guys? So, ayoko lang kasi alam ko bugbog na yung utak nyo. We'll start at 8 o'clock tomorrow. And I will discuss about drugs, and airway. And after that, mag-code na tayo. Okay? So, any question? Wala. If there's none, see you tomorrow at 8 o'clock in the morning. Thank you very much for, I know some of you are sleeping or what. Kaya siguro bumagsak-bagsak kayo dito sa ECG. Kasi you thought, ECG is a graveyard. Pero, isa yan sa, sabihin ko, pillar yan. Kailangan mahusay din kayo sa ECG kasi you don't treat the rhythm, but you will be dependent on the rhythm. Okay? Anyway, see you tomorrow at 8 and have a rest. Dahil na-squish yung brain ninyo, I will not say sorry, ganun talaga serious. But in time, when huwag kayong minto after my talk, after the course, online. Huwag kayo, gawin nyo, mag-simulate kayo, kahit wala kayong dami, mag-simulate lang, around the bed, kunwari, simulate nyo lang. Tapos, kumuha kayo sa internet ng mga rhythm, anong gagawin? I-rundown nyo lang anong mga gamot. Makakaya nyo yan. Tapos, i-live nyo lang yung IV line, yung mga wala na, gamit na IV line, i-live nyo. Tapos yung dulo, is kaysa walang tao, isuksok nyo lang doon sa, yung dulo, ilagay nyo lang sa, nakalawit doon sa trash can or what. Para pag nag-drive, i-drive nyo talaga, kahit water, gawin yung NSS, tapos, pala kayo kung anong kaso. Magsisimulate yung code. Ganyan lang. You don't need to have, like in Israel, yung training namin, sa simulation hospital, napakaganda. Magsisimulate ka talaga. Hospital siya, pero ang laman, AI, artificial intelligence. Lahat ng kaso, tuwang-tuwa. Kuhang-kuha ko yung ACLS sa katroma. Pagdating sa mga kidney, yung mga medyo, chronic kidney, chronic kidney disease, medyo may ibang gamot na, doon ako nalalaglag. More on intervention lang talaga. Anyway, see you 8 o'clock tomorrow and enjoy the rest of the afternoon.
Hello po. Good afternoon po. Regarding your certificates po, we will send it via email po. Once ready na po yung certificates, it will take 1 to 2 days po after training. Probably Tuesday po. And sa gusto naman pala mag-avail ng hard copy po ng certificates, pesos lang po. Shipping na po siya nationwide. Teacher coordinators po, or you can message our official Facebook page po, WIPAM Training Center. And kung may gusto din po pala mag-upgrade to BLS ACLS with first aid or to BLS ACLS po, pwede din po kayo mag-upgrade. Just message your coordinators po, or you can message our official Facebook page din po. Then, Tomorrow po yung continuation ng ACLS at exactly 8 o'clock AM po. Same Zoom link lang po na sa ginamit po natin today. Ayan po, thank you so much and see you again tomorrow po. Thank you.